bacillus. Since then, it is celebrated every year on March 24th. This year, TB theme is Yes, We Can End TB, which aims to inspire hope, encourage high-level leaderships, increased investments, innovations, and collaborations to combat the TB epidemic.
For the same, the Ministry of Health and Family Welfare has taken a note of WHO TB report 2022 that was released on 27th of October 2022, which clearly says that the India's TB incidence for the year of 2021, it is 210 per lakh of population. That was compared with the baseline year 2015, that was 256 lakh per lakh of population. And these figures clearly end up the India at the 36th of position, just from the largest to the smallest incidence number of TB.
And our fight against TB has just begun. India has made a cash transfer of $89 million to the TB patients through a direct benefit transfer program. And the President of India has launched the first of its kind Pradhan Mantri TB Mukt Bharat Abhiyan to provide additional nutritional support to those on TB treatment. And the TB program's nutrition support scheme, Nikshay Poshan Yojana, has also proved critical for the vulnerable to fight the TB epidemic.
And this CME, that is tuberculosis and update, conducted on this wonderful day, that will also help us to go more ahead, and it will surely be an academic feast. So just let's begin with no further delay for our first session. Our first session, it is on update on TB, and for the same, I would like to invite Dr. Jay Kishan, that is Professor and Head of Respiratory Medicine, MM Institute, who will be the moderator for the same session. Please give a big round of applause for him. For the same session, Dr. M.C. Gupta, ex-professor and head pharmacology, PJIMS Rohtak, who will be the chairperson of this session. Please give a huge round of applause for them. Dr. Aparna Parmar, Dr. Sandeep Goyal, Professor of Department of Medicine.
Dr. Aparna Parmar, Head of Department of Microbiology, PJIMS Rohtak. I hand over to you, Dr. Jay Kishan, for the session.
So good morning everybody. At the outset, I would like to congratulate the Department of Pulmonary and Critical Care Medicine, Dr. Chaudhary and his team for organizing this program on the pulmonary TB update. And you will be seeing that why the Critical Care Medicine Department is organizing the TB update. Because TB enters into each and every field. The patients of the TB are requiring the critical care, and many times the patients of the delivery, meningitis, the land into ARDS, the patients of the TB going into the advanced stage, and then it will failure. Even after the treatment of TB, we are seeing the patients who require the critical care, and many times I am saying that the patients are not able to afford the critical care, and at least in the private hospitals, they are not able to afford, and they ask for the lama because they lack of the money. So what I feel at the outset, I will say that there should be a dedicated ICU for the TB patients, and many times even the regular CC, the ICU patients, the TB patients are not admitted, especially the MDR TB. So it is a very good effort, and we start with this session, the update on the TB. There are various topics on the diagnostic, microbiology, preventive therapy, the thimerosal extended use, abdominal TB, and with liver dysfunction, all are there. So for the diagnosis of the TB, we should have the point of care test, and there should not be a delay in diagnosis, not point of care test, not for the diagnosis only, but for the drug resistance testing as well. So that the treatment of the drug resistance TB is not delayed. So we are having one of these eminent personality, Dr. Rushi from the AIMS, and she is going to deliver the topic diagnostic microbiology, and including something very important, the therapeutic drug monitoring. So she is down with the COVID, so she is not amongst us, but she will be delivering the lecture on the online mode. So I invite Dr. Rushi to please start her session, the lecture on this diagnostic microbiology, including the therapeutic drug monitoring. Yes. In the meantime, I would like Dr. Parna to please have some comments on this.
Good morning, everyone. So welcome to the PCCN midterm CME on tuberculosis and update. So today we are going to have so many eminent speakers here, and we are going to learn. We will go our homes learning, having an update. So I welcome you all to this CME. And our first speaker is Dr. Urvashi Singh, which is a very eminent speaker, and she will be giving a very explicit overview on diagnostic updates in detail, telling about the algorithms which are to be followed and which are being followed by us today. So let us have the session. Thank you.
Good morning, all. Good morning, all. It's an honor to be here with you today. I would have been happier to be physically present, but due to COVID, I am unable to come today. I must thank the organizers, Dr. Chaudhary, the National Academy of Sciences, and all the esteemed guests. So I'm going to quickly cover the new diagnostic tools available to us in TB diagnosis, and we'll touch upon therapeutic drug monitoring briefly. As we're all aware, COVID actually put TB control behind by several years, and these are the top 10 countries where gaps have been reported between notifications of new and relapsed incident TB cases. And some of the countries were able to make up the gaps in reporting. Some were able to actually improve with time, while some are still to improve. So COVID actually was quite a deterrent, quite a difficult time for tuberculosis per se. Now, this Venn diagram actually briefs the available knowledge on the number of people who are actually exposed to tuberculosis. WHO says 1/4 of global population remains infected, and a smaller subset of that presents with true active TB. The smaller circle talks about the microbiologically confirmed tuberculosis, and
Sir, which video? Dr. Vishi.
good morning, all. Good morning, all. It's an honor to be here with you today. I would have been happier to be physically present, but due to COVID, I'm unable to come today. I must thank the organizers of Chaudhary, the National Academy of Sciences, and all the esteemed. So, I will just quickly cover the new diagnostic tools available to us in TB diagnosis, and will touch on therapeutic drug monitoring briefly. All aware, COVID actually put TB control behind by several years, and these are the top 10 countries where gaps have been reported between notifications of new and relapse cases. And some of the countries were able to make up the gaps in reporting. Some were able to actually improve with time, while some are still to improve. So COVID actually was quite a deterrent, quite a difficult time for tuberculosis per se. Now, this diagram actually briefs the available knowledge on the number of people who are actually exposed to tuberculosis. WHO says 1/4 of global population remains infected, and a smaller subset of that presents with true active TB. The smaller circle talks about the microbiologically confirmed tuberculosis, and another subset which talks about patients who have clinical symptoms consistent with TB. In the National TB Prevalence Survey conducted by SEMA during 2019 to 21, published in 22, we learned, that microbiologically confirmed tuberculosis, pulmonary TB in our country is to the tune of 316 per lakh population. In Delhi, we have around 534 per lakh population, while Kerala fares better with 115 per lakh population. High PTD prevalence was, as is well known, found in smokers, alcoholics, and non-diabetics. But as the survey actually confirmed multiply confirmed pulmonary TB, you can well imagine the true burden of tuberculosis in our community. And the advantage of this particular survey was this was an active surveillance. Hence, it's possible that we were actually able to tap all the true active pulmonary TB of the districts which were included in the study. 60% of chest symptomatics in the study had actually not gone to the clinics or healthcare to seek clinical care. Now, coming on to the triage tools which are available in today's time, and of course, all available at the graphic level, we could go symptom screening, digital chest X-rays. Now, what interesting is these blood signatures, C-reactive protein, transcriptomic signatures, for example, the Sweeney 3 signature, now taken up by CECID and called FTBHR, use of cytokine kits named as CT and MDT. All these are blood signatures which can actually tell us whether a patient is moving towards active TB, that reactivation of latent TB, or they will also tell us if a patient is responding to treatment. Ultrasounds have been used by several different firms to actually guide us in diagnosis of active TB, active tuberculosis. Volatile organic compounds have been around for some time, and a lot of research has gone into it. Aerosols, that is detection of aerosols, impinging on masks, for example, and detection of DNA from the masks is another triage tool which is being developed and may be available soon. This is the treatment action groups, the collection of all the underdevelopment tools which are being developed. The previous slide had cuffs, sound tools, and the slide includes, for example, the Lumira DXCRP includes C-reactive protein, Ichroma CRP includes C-reactive protein detection, and this is commercially available but pending validation. Against the Lumira DX is commercially available. Evaluation is ongoing for TB screening and PLHIV and so on. Now, moving on to WHO endorsed products. Now, I bring to you the latest WHO algorithms today, and what WHO has included in addition to Gene Expert and the variants of Expert, that is the Expert Ultra and Expert XDR. We now have something called as moderate complexity automated nets, which includes the machines by Abbott, BD Max, Roche Cobas, and also Hein Life Sciences. And the Expert MTB and Expert XDR, which are low complexity, can actually reach the periphery, are called as low complexity. The moderate complexity are bigger machines, need a tertiary care laboratory or referral laboratory. The pyrazinamide detection by NIPRO has been given the term high complexity reverse hybridization assay, but as we're all aware, pyrazinamide is important for the treatment of MDR, so the diagnosis of resistance can be very helpful. We have the Indian indigenous tests also recommended by WHO, and I'll come to that shortly. Now, this is the first algorithm where WHO recommends that we use the molecular. WHO recommends rapid diagnostics as initial diagnostic test for TB. And what WHO also recommends is to use the molecular methods as a universal DST at the baseline. So what we have available widely today is the Gene Expert MTB RIF, which has become synonymous with NATs, and it'll take a little time for us to actually go on to use the other moderately complex tests. But the other moderately complex tests do offer us INH at the baseline. For example, a patient who's been screened positive for TB on a molecular test, if in case there is MTBC is not detected, so what is recommended is we reevaluate this patient clinically and conduct additional testing to confirm to exclude TB in accordance with different national guidelines. In case MTBC is detected, and we have to talk about trace and not trace. Gene Expert Ultra detects very low bacterial load as trace, which in an endemic country could actually detect dead bacillary DNA. And if we consider this patient as true TB, we may be actually wrongly. So, if the patient is not trace and if resistance detected, we patient to the algorithm C, and we look at INH resistance and discriminant. And in case MTBC is detected and RIF isn't determinate, So coming on to this is an old Cochrane review slide which tells us the sensitivity specificity. Sanjay, I don't know how slides are moving on their own. Something about it, I don't know. So this is the Cochrane review from 2014, where sensitivity specificity of gene expert was detected as very high, and in PLHIV also the sensitivity was as high as 79%, while in HIV negative it was much higher. Going on to the recommendation by WHO for the extrapulmonary TB, what they recommended was the use of Gene Expert MTB RIF for lymph node TB, and for CSF, while pleural fluid was the good sample. We contribute our data. This blackened one is our data in extrapulmonary tissue, extrapulmonary samples. This table tells us very high sensitivity, not so optimal specificity when you compare it with culture as a reference standard. So culture yield per se is not very high, and it's not a very good gold comparator. But this table actually just compares that. The idea was to recommend the gene MTB for extrapulmonary TB diagnosis. This was the TrueNet depiction of the graph of TrueNet test, which was validated by us in a multi-centric study and recommended by ICMR and the National TB Elimination Program, followed by WHO, which is now being used, in several developing countries for the diagnosis. The Gene Expert Ultra, which came in much later, has higher sensitivity because it takes in more genes into account. It takes in IS1081 and IS6110, along with the RPOB to tell us about the resistance. Now, the use of several genes improves upon the sensitivity, but the specificity is lower than that of Expert MTB-RIF in participants, especially those who have a history of tuberculosis. And the sensitivity specificity trade-off would be expected to vary by setting. For detection of resistance, rifampicin resistance, Expert Ultra and Expert MTB-RIF have similar limits of detection as can be appreciated in this slide. The limit of detection of Expert, as published in 2010, the first paper in NEHM was 112 per CFU per ml, and the limit of detection of rifampicin resistance was similar. While in the case of Ultra, we can detect about 15 to 16 bacilli per ml, but the limit of detection of resistance remains the same. The RPOB is what is being used here as well. That is how the resistance to rifampicin is actually appears in the mutations to the mutations in the RPOB region, which will deter the rifampicin action. Now, this is a graph from the 10-color assay where we have 16 mutations which will give us resistance to INH, fluoroquinolone, amikacin, kanamycin, caprimycin, and ethionamide in 60% of cases. So in this particular graph, we were able to detect the INH resistance. Here it uses both INHA and CATG genes, so we can actually also say if it is high-level resistance, if CATG resistance is detected, or it's low-level resistance if ethionamide resistance is if INHA resistance is detected, which actually gives 100% resistance to ethionamide. But ethionamide also has another gene which is not covered here, hence we are only detecting ethionamide in 60% cases. Fluoroquinolone, yes, we detect both GAIR A and GAIR B. And so this is as far as the limit of detection of Expert and Expert XDR is concerned. And though we detect, the limit of detection is higher than Expert Ultra, but it gives us resistance to the drugs used in second-line regimen. Not all of them. We still have, to look for methods of detecting resistance of bedaquiline and linezolid. And in 100% of cases of quinolone resistance, INH resistance, and for the other group C, and of course the clofazimine and cycloserine, we do not have a molecular method. We have to depend on phenotypic DST. I'll come to that shortly. Here we have how we discern low-level and high-level resistance in the case of quinolones. So we could use high MOXY. The second algorithm I must bring in here. So this is something that is not yet available to us under the program, though the efforts are being made. Now, in PL-HIV, WHO recommends the use of lateral flow LAM assay. And in case the patient is symptomatic, the 4S signs and symptoms are there. We do the LF-LAM. If positive, we further confirm using the molecular methods, and we'd like to know resistance to both rifampicin and INH so that we can design the regimen accordingly. In such a symptomatic patient, if LAM is negative, we would still like to try the molecular methods and reach a definitive diagnosis. If the patient does not have any symptoms and the patient is an inpatient, we could actually, we can do LAM still. And we also evaluate the CD4 count. We decide the clinical management based on the CD4 count. If the LAM is positive, we further confirm using the molecular methods. But in case the patient was not symptomatic, LAM is also negative, and the patient has CD4 less than 200, we still do not rule out TB. Going on to the management, and so the WHO further defines if the patient is an outpatient. If the LAM is positive, we follow the same method as described above. LAM negative, we follow again the same method. But in patients who are not symptomatic, in those who have CD4 less than 100, we always perform LAM, and we conduct a molecular method for diagnosis of active tuberculosis in these patients. Now, the importance of this algorithm is that what we have published briefly about LAM, and then I'll talk about the publications and what they tell us. Liporabinomannan is an antigen which is excreted in the urine, and this slide summarizes it all. I do not really need to speak much. I would like to draw your attention to the comparison. This was published in 2020 between the Abbott, determined earlier, it was earlier called as the earlier LAM, now it's been bought up by Abbott. The Fujifilm Silva LAM actually amplifies, so the Silvamp TB LAM assay amplifies the silver, which is actually the indicator. So this has slightly improved sensitivity, as you may appreciate here. The study was done in PL-HIV, where earlier gave 42% sensitivity, while Fuji-LAM gave 70% sensitivity. Of course, expert MTBRIF is 90% here, and a molecular test any day offers higher sensitivity and higher specificity. Going on to a summary of several, so this is a gist from a meta-analysis, where they also concluded studies where LAM has been tried in specific samples. For example, in sputum, LAM studies detected all smear positive and 50% smear negatives, and they detected, to the tune of 5,000 picograms per ml of LAM on an average. In serum, the LAM studies detected 10 picograms per ml. So concentration of LAM is 500 times higher in sputum than serum. And it's in fact 50 times higher than urine. Urine has 10 times higher concentration. Detection of LAM and treatment initiation reduced mortality in people living with HIV. This was published by WHO, and this was the reason why WHO recommended the use of LAM for diagnosis of TB in PL-HIV, especially those with lower CD4 counts. Quickly running through the evidence that is available with us, this was one of the recently published articles where they compared LAM in HIV patients. This was a systematic review, and they compared both earlier LAM and Fuji LAM, and they found the specificity and sensitivity quite close. The advances in LAM technology, I'll come to that shortly. Now, this was the first study done by our group, where we showed the utility of LAM in immunocompetent children. These children were not PL-HIV, these were immune-competent children. And what we found was not only an improved sensitivity, but LAM testing showed high specificity and sensitivity was detected in more cases initiated on treatment on the basis of clinical reference standards. So this was in fact in our study proved better than expert as well. And so this is a treatment action group table which tells us that the Fuji LAM is still improving their test, and it's in late stage development, should be ready by late 23 or early 24. And also a third generation LAM which further amplifies the signal is also being proposed. So we may have something very highly sensitive soon. And moving on to the third algorithm proposed by WHO, where they recommend the use of second-line drug DST. And this is the critical concentrations recommended by WHO. The ones in the red are the latest recommended critical concentrations, and for BDQ, as you can appreciate in red, We have critical concentrations for testing in 7H11 and midget media. For clofazimine, again, we can do it in midget. For delaminid and pyrazanamide, of course, this was already available. These critical concentrations have been described in 2018, and we can use it very easily in our patients. Coming on to the fourth algorithm. Now, what is important for us, we realized, is when we change from RH to RHE in our continuation phase in our vancomycin sensitive patient treatment, we knew that the INH resistance in the country is quite high, and the drug resistant surveillance also showed the INH resistance to be quite high. And so it's important to know the INH resistance right at the baseline so we can actually have individualized treatment, and that's what the WHO is recommending, and where the moderately complex NATs come into play. And for us to get that in a country, it may take some time. Now, these are certain scenarios which have actually put together the previous algorithms. I do not think I may be eating into others' time if I go through these algorithms. Coming on to modalities of judging progression to active TB and treatment monitoring, what I mentioned earlier, people have utilized transcriptomic signatures, like I talked about the Sweeney 3 signature, which has been now taken up by Safir, and it's called MTB-HR. This is, though it says, the tag says early stage development, but I have brought in certain articles which have used MTB-HR. The RISC-6 signature is another transcriptomic based host RNA response signature, which has been studied and has shown high sensory specificity, and the evaluation is ongoing, will be available to us soon. We have something developed by BioVary called the ICTB, which again detects the host RNA response progression to active TB or treatment monitoring. So we have always had this issue of endpoint definition. If we have a tool which tells us, yes, you're sensitive or your MDR TB patient is responding to your treatment, so we would definitely be on stronger grounds when we decide to stop treatment, or we always keep worrying whether the patient will come back with a relapse. Another assay, the TAM-TB assay, has been taken up by Beckman Coulter, and as you're aware of the studies which talked about response, showed good sensitivity, specificity. To the right is a bit of our work, which is under communication, where we looked for STREM levels, serum soluble TREM levels, which were pre-treatment pulmonary TB patients, to early prognosticate these patients. And what we found was decline in STREM levels after 1 and 3 months of treatment indicated good prognosis. Patients who had significant increasing levels in the second follow-up, that is after first month, and if the increase was more than 1,000 picograms per ml, definitely relapsed or accumulated resistance during treatment, and they were detected much later. Those which had a slight increase got cured. Now, 2 of our patients here had very high baseline levels, more than 10,000 picograms per ml, and died 1 to 2 years after treatment completion. One had diabetes, the other had no known comorbidity. Hence, we propose this could be another very good marker. This is the rest of the TAC-TB line, where people are developing bacillary load. This is again some work which we have done in the past, looking at the mRNA, and we still have a continuing ongoing 2 projects with RBI PMT where we're looking at the load of mRNA. These are commercial products which would be available soon, where the load of bacilli could actually tell us if the patient is responding to treatment or not. Now, this is a study where people living with HIV, they use the MTB-HR to look at the response to treatment, and they found it to be highly sensitive, highly specific. Another study where they used the same MTB-HR, which was initially named CEPI3 host gene response, in a fingerstick blood test in a prospective multi-site study, and they found this to be sensitivity was quite high, to the tune of 90%. So probably, we may be actually hoping for, this is the study of TAM-TB, the initial study. Now, briefly coming on to something called as the transrenal microbacterial DNA. Several studies have described presence in urine of small mycobacterial DNA fragments due to apoptosis of mammalian cells, and these fragments appear in the soluble fraction. So, several studies have worked on this. One study reported presence of small fragments in 79% of patients, and as you can see on the figure, in the figure on the right, it's something self-explanatory. Now, this is a study where they looked for urine cell-free DNA, and they found the sensitivity to be as high as 83.7% and 100% specificity when they compared to expert MTB-RIF. This is another study where they did both expert
Dr.
versus TB
Urvashi,
lab
Urvashi, please
for diagnosis
stick
of
to the
pulmonary
time.
TB. So
We have to keep up with the time.
this is something where we can, still hope for better tests coming our way. This to the right is our study where we use expert ultra in urine to detect the transrenal DNA for diagnosis of extrapulmonary TB. In fact, the study included LAM assay as well, all under communication. Coming on to the next generation sequencing and whole genome sequencing, which offers a lot of promise, but may take some time to be available. These are the WHO guidance documents over the past few years, and briefly, a few countries which have done whole genome sequence to guide their program. In fact, this is how it goes hand in hand with phenotypic testing. And this is these are the countries where they used it for designing the drug regimen, especially in their DRTB patients, and they found it quite useful. So the developing world, such as Congo, Eswatini, Myanmar, could do it. We could also do it. Coming on to newer biomarkers. Now, this is where, again, before I go on to the biomarkers, the detection of heteroresistance at baseline. Heteroresistance is nothing but a mixture of clones which have different resistance profiles, and while the patient is on treatment for sensitive TB, there's accumulation of resistance due to the presence of resistant clones already in the patient. The problem of detection of heteroresistance stems from the problem of limits of detection of our testing methods. Even expert MTB-RIF clearly marks that for detection of a certain mutation, for example, the most prevalent mutation responsible for rifampicin resistance, we need at least 60% of the colony-forming units in a sample to have that mutation. So if the number of resistant clones present is less than that, it will be missed at the baseline. And we may sometimes blame the lab, as is the trend, that the lab did not detect resistance while the patient was resistant 2 months later. It may actually have to do with the play of clones in presence of RIF-sensitive TB, that is the selection of resistance mutant. And so, like I said, it is the limit of detection of a test, and whole genome sequencing may not always be able to offer us an answer. We need a better answer. We hope to have it in the future. Coming on to the biomarkers, this is our recently published work in the field of proteomics in pulmonary TB, where we detected certain peptides, and those are now patented, and we may come up with a good test soon. Our recent work, published only a week back in NMR Biomedicine, we use a metabolomics to give us markers of detection in difficult to diagnose TB, pediatric TB, extrapulmonary TB. So, the more the markers we have, we may be better off. Now, an aspect of TB treatment, as is familiar to most physicians who would be attending today, is difficult to treat patients who are on treatment regularly. They are compliant, they are following all guidance. But this is a study we did in retreatment patients. We did their therapeutic drug monitoring, and we wanted to actually know why did they have to undergo retreatment despite a thorough completion under care of the previous treatment. And we wanted to see if the drug levels did vary in these patients. And this study was actually done before the times where daily treatment actually came in darts, and this was initially started as a wonderful project. It took us some time to publish it. So what we did was we sampled these patients. We did the pharmacokinetic studies and the PKPD studies. We looked at the drug levels and we looked at the patient outcomes. What we found was, so this is just a schema. We use the LCMS-MS machine in the pharmacology department and AIMS. Dr. Vel Pandian, who's an expert in the field, did the LCMS-MS for us. And we looked for, so of all the patients included, 134 patients, 108 got cured, but 9 patients were not cured, and in fact, some patients landed up as MDR while on treatment. And what we found was the levels of drugs, as you can appreciate in this graph, was much lower in those patients who were not cured. So this is how much the difference between the cured and not cured patients was. As can be well appreciated. In the interest of time, I'll straight away rush off to the conclusions. This is the ROC curves for different drugs, and what we found was drug concentration was significantly lower in the not cured group. Differences in drug levels between the two groups were evident very early, as early as day 0, and definitely as month 2, day 0. Sometimes may misguide us because the drug will get absorbed, bind to lipids, and different drugs have different binding to proteins and lipids. So we need to really understand all that very well. Now, these patients actually landed up with poor outcomes because they had lower drug levels. So what we recommend is that we look at patient drug levels, especially those who've had a difficult treatment in the past, and we design regimens with better dosages, higher dosages, ensure that the drug levels are maintained and the Cmax and area under the curves are reached. So, in fact, the HIRIF and the other studies which have guided us have been designed based on such studies only. So, coming on to the concluding slide, it's what we do is what is easy. That's kind of practice. But in the with newer tests available to us, so the questions that these difficult to treat patients bring up actually encourage new research. And what we have seen in the past 20 minutes is that lot is happening and a lot is available. We just have to reach out with our questions and look for the right answers. We need markers for treatment endpoint decisions, and we talked about several tests which may be actually offering us. We need to detect gaps early. We published something early on to the mRNA at day 0, and we could actually predict that this patient will relapse or will land up as drug resistant. So there are markers available to us. We just need to look for those markers. We need markers of detection of latent, incipient, subclinical, or active TB. We wish to eliminate TB. Why not target the latent or the incipient or the subclinical stage? Why wait for the bacteria to multiply in so many numbers that we have to deal with active TB or the worse MDR TB? That's all I have for you today, but I will be happy to take questions, hopefully in real time. Thank you so much for the patient listening.
So Dr. Urvashi has given an elaborate account of the latest advances in this diagnosis of the TB. But the real challenge is to differentiate between the exposed, the infected, the treated, the BCG vaccinated, the relapses. And one thing very important, my appeal to the clinicians, whatever test you may be having, the microbiologist will be limited by the approach that you should be giving the good quality sample. So many a times, the good quality sample is not coming. Dr. Arpana will agree with me. And you should be getting the sample from the site involved, especially the EPTB cases. So Now the approach is shifted to the accessible sites. Instead of say pulmonary tuberculosis, we be getting these samples from the urine, the blood and other tests. So we have to give the good quality specimen. Lot is there, but we need to have the diagnosis. We should have the drug sensitivity available at the very first starting of the sample, and we should be reducing the turnaround time also. And as far as therapeutic drug monitoring is concerned, the therapeutic drug monitoring is required when you are having the HIV or other problems and the vomiting and others. But you need to have the pharmacokinetics and dynamics at the site. Instead of the, say if the patient is having TBM, if the patient is having TB abdomen, whether the drug is reaching at the site or not, that is equally important. And we may be seeing these in vitro, but in vivo what is happening? And once a combination of drugs is being used, that is again very important. So when the sample is to be taken, that again becomes important. When the peak is achieved, that becomes important. So these are some of the challenges in the diagnosis and the therapeutic drug monitoring. So we should be taking care of this and hope that we will get an answer in the near future. With me are Dr. M.C. Gupta, the HOD Pharmacology, Dr. Arpana, and others. I would like to have the comments from them.
Well, I think right at the outset, first I need to convey my most sincere thanks to the organizers for giving me an invitation to join you guys, and special thanks to my dear brother Dhruv Chaudhary and Pawan, and I'm very happy to see here Dr. Sonal also, who is from the district authorities and who have been a part of Department of Oncology at my time in that department. Coming to therapeutic drug monitoring, rather than going to tell you how to go about it, more important question is it worth it? Should we be carrying out? See, these are some of the questions. And here I would like to make first some general comments. Number one, no size fits all. So all the patients are individual. And when we talk of the anti-tubercular treatment, it's a generalized pattern all over the globe, I understand. So there is hardly any change which we do for the individual patient, number one. Number two, India, in that context, we are still a developing country, I would say, and we have a very heavy load of tuberculosis. And in spite of all the progress we have made, still I think there is always some crunch as far as finances are concerned. So the cost of doing the TDM in a conventional matter in all the patients receiving ATT, I would like to clarify these facts, whether this is really needed or it is not needed. Then third point, I came across a study from South India, Geeta et al., I understand. They have done rifampicin levels, and they found in 90% plus patients receiving rifampicin, the levels were below the desired levels, and we all understand that this can really contribute probably development of multi-drug resistant tuberculosis. So, to put the perspective, now one, I'll start with a disclaimer actually. If you ask me why I should be talking on TDM, do I have a hands-on experience on TDM of ATT? Answer is no. You ask me, you have some exposure at TDM hands-on? Yes, I have multiple drugs during my tenure at PGI Chandigarh, at CDRI I had. But then I have some fundamentals which are clear to me regarding TDM. So going into a little bit of that, some questions are to be raised. First question is, does we need to do TDM in all cases of tuberculosis? Very simple and honest answer is no. So we have to differentiate between uncomplicated and complicated TB. So when we talk of the complicated TB, we have a basis for going for therapeutic drug monitoring. Now, what do we understand when I say complicated TB? That means there are certain associations. Those associations are when we see that there is a delayed response. When we see a patient is showing a resistance, and we are talking of MDR resistance. A patient who is getting ATT and simultaneously has got HIV, something like diabetes mellitus. We have some question regarding compliance. We have some question regarding the reduced response rate. We have some question on the quality of medicament. A patient who may be having chronic kidney disease, patient who may have very seriously and severely deranged liver function tests. So these are some of the situations where we have a rationale for carrying out therapeutic drug monitoring. Now coming to therapeutic drug monitoring, I'm not going into the complexities and nitty-gritties of TDM, but let us understand it. Proper TDM will always need a standard drug curve which needs to be drawn, and this will be based upon the multiple samples, few samples taken in the absorption phase, few in the distribution phase, few in the elimination phase, and generally it would mean 10 to 12 samples. Is that okay? For TDM in ATT, answer is no. We cannot really go for 12, 13 samples for TDM. No, it's not done. So now, second option. Second option is what we call as 2-time point TDM for tuberculosis patients who are complicated TDM cases. And one sample is taken at 2 hours, another is taken at 6 hours. Because if we take only 2-hour sample, we fail to distinguish between problem of absorption and problem of malabsorption, So if we want to differentiate it, then we should take a 6-hour sample also, so that will at least abolish this particular problem. So 2 samples. Then third option obviously is 1 sample. And if I go into modern times, and I understand this facility is not available as far as India is concerned, this is known as DBSA. DBSA is dried blood spot analysis. You just take a filter paper, just a drop of blood, touch it, and by suitable methods, you can analyze the levels in no time. So if that facility is available, then the sampling part is gone. And I wish that tomorrow, when we become a little more modernistic in our approach, then we'll be having this facility, and this really can help the people who are having this program. Another very important information, this TDM per se, as far as tuberculosis is concerned, it has got very poor predictive value. If you want to see that there will be treatment failures, we cannot predict. There will be relapse, we cannot predict. So it's not a very good predictor. But then, as I said, in certain scenarios, it can be very, very helpful. And lastly, this golden message, I would say, in isolation, therapeutic drug monitoring of ATT really may not help. It has to be considered and studied along with the microbiological data, where the inputs of the microbiologist will be needed, and of course, clinician is the key person. So starting like that, the clinical scenario, coupled with that microbiological scenario, coupled with that therapeutic drug monitoring, so this is how it is going to help. One salient example I'd like to give you, which I came across in a study in the obese patients. They were put on INH and rifampicin, we know the protocol. So they were given this drug, and the drug levels were carried out. And you'll be surprised to know, in a person of 90 kg, when the drug levels were done, they were found to be subtherapeutic. So in such kind of cases, there is a great help which can be rendered by therapeutic drug monitoring. So that patient was recommended that if he's taking INH 300, it should be increased to 450. If he's taking rifampicin 600 milligram, this should be increased to 900 milligram, fine? So I think these are some of the factors which are important when we talk of therapeutic drug monitoring. And I still would be of the futuristic view that in coming years, maybe we have realized the importance of TDM, and we need to make these facilities available, specifically that blood drop. If we can do that kind of analysis, that really will aid the clinician. And in those patients specifically who have some complexities which are occurring during the treatment, which I have labeled as the complicated cases of tuberculosis. Thank you. Once again, thanks to the organizers, and have a great day.
So, on behalf of the participants, those who are from pulmonary as well as non-pulmonary, so we will be interested. We will be interested in these local site concentration of the drugs, say in the CSF, in the cavities, in the synovial fluid, in the pericardial fluid, and whether there is a possibility of the intrathecal, intrapleural, intrapericardial, that type of the things. They will be interested in that local penetration is there or not, there in the cavities or not. Now there is the solid lipid nanoparticles for the ethambutol valve. The local installation of these rifampicin and others were given in the cavity. So that type of the approach should also be highlighted. But Dr. Alpanam, please, your final comment.
So we are very thankful to Dr. Urvashi ma'am, who gave an updated review of all the diagnostic tests. So we are still very hopeful that yes, we can end TB. Thank you.
So since we are going late,
Sir,
so I will.
Sir,
Yes.
Dr. Urvashi is live right now, and she wants to answer a couple of questions and give a comment, if permitted.
So Dr. Urvashi, please.
And my apologies for not being able to join. And I agree with the previous comments made by the esteemed chairperson. Now, TDM is not for every patient. I only presented one study we did in retreatment patients. These patients were failing, and we did a study in these patients. We followed them up. In fact, some of them not only failed, some of them turned into MDR, like I talked about heteroresistance to begin with. They accumulated resistance, and they were difficult to treat. The point we wanted to make was with this study that treatment failures can be due to inherent PK/PD parameters of the drugs. The patients may not be absorbing, the patients may be metabolizing the drug faster. That was one reason. And in fact, it's not only in these patients, we've concluded three more studies rather. One in abdominal TB, which is under communication. Another is in meningeal TB. We have looked at, so this has never been done in the past, nowhere else. We have looked at drug levels in CSF and blood and compared as well in patients who are put on treatment for TB meningitis. The third study has been done by Dr. Anantmohan. Again, we are working together in pleural effusion patients. Now, the bottom line is, like the chairperson said, TDM is not for every pulmonary TB patient, especially till such time that we have the provision of doing it in an easy manner. We can offer it at the periphery. And so we will reach there, sir. But first and foremost is to modify our regimens. If our TDM studies can actually tell us the flaws in our regimen, we must make those changes. In our meningeal TB study, what we found was what is being given to them, the same regimen as is being given to the pulmonary TB patient. Is that the right thing to do? We are all aware that both RH do not penetrate after the blood-brain barrier recovers after the initial few months, but we still want to give the same treatment. That is where I appeal. We must look at a fresh regimen for diseases which can be fatal. TB meningitis, we know the high mortality it may actually lead to. So we must question the very fact that why pulmonary TB regimens are being offered for extrapulmonary TB disease, where the drug penetration at the site of disease may not be perfect. So TDM as a research mode, could help us question and answer the true regimens that may be effective in such patients. So like I said, we have done 3 such studies in various stages of publication, and we could actually disseminate that data, and we must come up with better regimens for severe killer TB extrapulmonary sites especially. The other point sir had raised was 2.3 point. Of course, those will be feasible. And the only data I brought in today because of lack of time was the 2-hour Cmax went best hand in hand with the outcome. So that was one way out that we do it at one particular point in time. But of course, the more than one sample can give us better answers. The other question was, Dr. Jayakishan sir had said something in the beginning. Sir, could I have the question again? There was something you had raised.
So we are running late. Thank you so much. I will be talking in person to you. Thank you.
CT. The important mimics of abdominal TB and how to differentiate. Eventually, how to treat these patients. We'll also talk about a very, very, very important thing, which is the diagnostic or the therapeutic trial of ATT and when we can, actually go ahead with that trial. What are the caveats, and then how do we follow these patients up? So as you can see that there are two most common patterns. One is the peritoneal involvement, which we largely see as formation of ascites, or a luminal form where you can have ulcerations. Then there could be lymph nodes, and you can see these blackish, rounded, necrotic lymph nodes. And then visceral TB, for example, this is a liver abscess, you could have a pancreatic disease or splenic involvement. But today we'll focus largely on peritoneal and luminal, that is the intestinal tuberculosis. So let's start with a case, a 42-year-old lady who came with abdominal distension and a weight loss of around 10 kg in spite of distension over 2 months, loss of appetite, and an ultrasound showing TO mass and ascites. So we tend to think of peritoneal TB as only equal to ascites, but there are a lot of other things which could happen. So there could be peritoneal nodules, there could be mesenteric involvement, there could be formation of a cocoon, there could be omental thickening which may happen, loculated ascites. So this means that there are different morphological patterns which could happen in peritoneal TB. The most frequently, almost 80 to 90%, what we see is the acidic form or the wet type, where the common presentation is with fever, abdominal distension, and less frequently with pain and obstruction. However, there are two other patterns which are often confused with one another, but they are the fibrotic or the dry type. And you can see here that you can have peritoneal thickening, some amount of loculated ascites, lot of omental changes, thickening, and nodularity. The difference is that these patients present more often with pain and can have, a significant number can have intestinal obstruction. Same is also true for dry plastic type, where the amount of ascites is much less. You can have caseous tubercles and adhesions and fibrosed peritoneum. Again, here also intestinal obstruction is more frequent. So therefore, there is a problem with classification and there is a lot of overlap. For a clinician, I think it is much more important to define how the patient is presenting, whether it is a distension dominant or a pain obstruction dominant phenotype, because the therapeutic strategy is based on these clinical presentations. So we go back to case 1, and you can see that on CT you have ascites, and what you also can see is a omental cake. We'll keep coming back to this case again and again. So one of the most important differential diagnoses when you see ascites, of course, one of the common causes is chronic liver disease, but that is easy to diagnose because the serum ascites albumin gradient in chronic liver disease is high. But more commonly confused with TB peritonitis is peritoneal carcinomatosis. And although I have listed some of the features which can discriminate, none of these is actually very specific. So you can have a regular or a smooth peritoneal thickening in TB, a smudge type of omental involvement and macronodules in mesentery. On the contrary, in peritoneal carcinomatosis, you have nodular smudge type of involvement of the peritoneum, which is irregular. Omentum may be thickened and there could be caking. But none of these, as I said, even visceral scalloping, which is supposed to be specific for carcinomatosis, has actually been reported with TBP. So what do we do? So the diagnosis rests on evaluation of the acidic fluid. We must, even when we are considering TB peritonitis, send workup for malignant cells. In TB, usually it's a lymphocyte predominant type of ascites. The serum ascites albumin gradient is usually less than 1.1 gram per deciliter, except in situations when TB peritonitis complicates underlying liver disease, when the SAG may be high. We must send for mycobacterial tests, and our cornerstone for diagnosis is adenosine deaminase. So in our patient, you can see that it was predominantly lymphocytic ascites. The SAG was low, the proteins were high. Yeah, so the SAG was low, the proteins were high. But the problem is that very often people will also do a CA125, and that is elevated. Now this complicates the picture. The problem is that CA125 in serum, as also in acidic fluid, gets elevated whatever be the cause of ascites. So this is a test which ideally should not be done. So ADA was elevated. So what is the role of various diagnostic tests? So I don't know why this is not moving. Okay. So AFB is hardly ever positive. So we hardly ever send for AFB stain. For Gene Expert, which is now available through the program, it is positive in 30% of the patients. If you compare to a comprehensive reference. If you compare to a culture, in 60%. Culture positivity is in around 35 to 50%. And the traditional PCR, which checks for IES6110, the positivity has been reported from 25 to 80% in different studies. The cornerstone for diagnosis is ADA with a sensitivity which is almost always reported to be more than 90. But we must be aware that this is a non-specific test. It could be false positive in lymphomatous ascites. We must not do ADA in purulent ascites. And it can be false positive even in malignant ascites. It can also be false negative even when the underlying condition is TB peritonitis, if it is an early stage and a neutrophil predominant type of ascites, or partially treated, or in patients with underlying cirrhosis who develop TB peritonitis. I think cancer biomarkers, I mentioned it only to discourage the use because they are costly and they cannot be a diagnostic criteria for even peritoneal carcinomatosis. And they may mislead and vitiate the clinical diagnosis. In our clinical practice, we send malignant cytology thrice if we are making a diagnosis of peritoneal TB only on the basis of ADA. So if it's a microbiologically negative case, we tend to send my malignant cytology thrice so that we are more sure of our diagnosis. So back to the case, malignant cells were negative, ADA was high, ATT was started, and there was resolution of ascites at 2 months. In cases where you cannot achieve a diagnosis or patients who don't improve, peritonioscopy is of value. And in fact, even visual inspection has been reported to be more than 90% sensitive in this study from All India Institute of Medical Sciences done long time back. And this is the cornerstone in patients where diagnosis is not clear. So to summarize peritoneal TB, if there is a clinical suspicion, if there is a clinical suspicion and ascites is present, ascites is a valuable fluid and that can be tested as I suggested for ADA cultures, and you could have a diagnosis of peritoneal TB. If ascites is absent, you need to target the peritoneal thickening or omental thickening, and that could yield the diagnosis. If the diagnosis is unclear, one can consider laparoscopy or peritonioscopy. Now we shift gears and go to the gastrointestinal TB, which is the luminal form of tuberculosis. So intestinal TB, the most frequent site is the ileocecal region, and as you go orally or anally, the frequency of involvement declines. Now, the pattern of involvement, it could be ulcerative, where dominantly it is ulcers, and some of these patients would present with diarrhea, hypertrophic or mass forming, where pain and obstruction are more common. Stricturing disease, again, pain and obstruction are common, but most often you have a combination of these. Now coming to clinical features, abdominal pain is most frequent, then is fever, loss of weight and loss of appetite, but a subset of patients may have bleeding per rectum, diarrhea, and a significant number also present with intestinal obstruction. Now, just like you had peritoneal carcinomatosis when we were talking about peritoneal TB, when we talk about intestinal TB, a very close mimic is Crohn's disease. And actually, we are now seeing a fairly good number of Crohn's disease in this region, in our region. So misdiagnosis is very common, and this is a study actually from South Korea, but even in South Korea, 20% of Crohn's disease are misdiagnosed as TB, and again, 10 to 12% of TB are misdiagnosed as Crohn's disease. So misdiagnosis happens even in regions where TB is not common, and here, at least till some time back, virtually all the patients we had of Crohn's disease first received ATT, and only later on a diagnosis of Crohn's disease was entertained. So let's again go to a case presenting with abdominal pain, a short history, 1 week, obstipation, some amount of tachycardia and abdominal distension and tenderness. And you can see multiple air fluid levels, and you can see our Ryle's tube has been placed because of obstruction. So at this stage, there could be multiple possibilities. Fortunately, with conservative measures, the patient improved, and we could do a colonoscopy around a week later. The rest of the workup was not very contributory: a normal X-ray, a negative MON2, and an elevated CRP. And a CT, you can see a thickening of the ileocecal region. This is the cecal thickening, and even you can see some amount of thickening in the terminal ileum. And this was a colonoscopy. You can see that this is a circumferential or a transverse ulcer, which is typical of tuberculosis. The biopsy, as we often see, was non-contributory, changes of chronic colitis, no granuloma, and the microbiological tests were negative. So, are there colonoscopic features which suggest the diagnosis of TB? So you can see this is the ileocecal valve, ulcerated. Here it is a gaping valve, cecal ulcers are there, multiple pseudopolyps with distorted cecum, ulcerated narrowing, and this was again from this same patient where there is a transverse ulcer. So these are findings we usually see in tuberculosis. In Crohn's disease, what we... Pointer, please. Pointer. So you can see these are more linear kind of ulcers, and then you can see cobblestoning in the last image. You can also see ileocecal involvement, one serpiginous ulcer. Pointer, can I have a pointer? This is not working. So these images are different from what we saw with tuberculosis, and these usually suggest a diagnosis of Crohn's disease, but none of these is specific. Now I wanted to show some of the CT images, and so you can see that cecum, this is a barium image, the first image, the cecum has gone up from the pelvis. So this is a pulled up cecum, very classical of tuberculosis. We don't do barium as often these days, and you can see that the terminal ileum is kind of narrowed. You see a homogeneous kind of enhancement of the cecal area, and here you can see these rounded lymph nodes, round lymph nodes, and you can see the necrotic center with an enhancing periphery, classical of tuberculosis. In Crohn's disease, on the contrary, you see here asymmetric involvement. So the mesenteric side is more thickened rather than the antimesenteric side, and you can see that some amount of vascular engorgement, what we call as the comb sign, that is visible, and these are skip areas. So some amount of bowel is here, then normal bowel, and some involvement again in the right side of the bowel. This is not again working, please. So again, you can see a very nice trilaminar pattern of enhancement in the bowel wall in the first image. I hope you can appreciate, and this is largely suggestive of Crohn's disease. And on the second, you can see a dilated small bowel with an enteroenteric and an entrovesical fistulae. So fistulae are more frequent with Crohn's disease. So just to summarize, if you have a shorter history, pulmonary symptoms, presence of ascites, that is largely TB. If you have diarrhea, hematochezia, more likely it is Crohn's disease. Imaging findings, if you have a necrotic lymph node, that is almost always TB, but other findings are less specific. I already showed the colonoscopy findings on histopathology. If you see larger granulomas, confluent granulomas, caseating necrosis, histiocytes lining the ulcer base that is largely suggestive of tuberculosis. Microgranulomas or sparse granulomas are largely suggestive of Crohn's disease. So coming to diagnostic tests, and this is a summary: AFB stain, hardly ever positive, less than 5%, gene expert in a quarter of patients. Of course, ADA is not applicable here. The standard PCR overall pooled sensitivity is 47%, cultures around 50%, and histology less than half of the patients. So if you combine histology and microbiology, a clear-cut diagnosis is possible only in half of the patients. And in the other half, you are still confused. What is the diagnosis? So how do we proceed? So we'll go to that, but before that, how long to treat? And this was a Cochrane review where Dr. Vineet from AIMS was a part of this Cochrane review. 3 randomized trials, 6 months versus longer duration of therapy. The clinical cure rates and the relapse rates were similar. So what I want to say here is that 6 months of therapy is usually adequate for most of the patients with intestinal or peritoneal tuberculosis. Now, as I said, that in half of the patients, the diagnosis will not be clear, whether it is TB or Crohn's. So in India, you can never virtually close your eyes to that possibility of the underlying disease being TB. So whenever we are not sure that this is Crohn's disease, we go ahead and start ATT. But this is not to be taken lightly. It is only after a complete, thorough evaluation has been done, and we need to follow these patients very, very closely. So how do we follow these patients up? So this was a landmark study again from AIMS, where what they did that they started doing colonoscopy at the end of ATT. So what they found that if there were ulcers, you can see the second image, the ulcers had healed. Now, they started using this as the gold standard. And if you look at the clinical responses, in Crohn's disease also, at 6 months, 1/3 of the patients have a clinical response. So you give ATT, patient says, I am all right. Even the CRP, we have shown declines with ATT in Crohn's disease. But when you start looking at the ulcers don't heal, and therefore the gold standard in these patients is a repeat colonoscopy. But the problem is that if you keep giving ATT, it is now very clearly known that ATT in patients with Crohn's disease has a fibrotic action. So the patients who develop stricture increases if they receive ATT with an underlying diagnosis of Crohn's disease. So we started doing, and this was early mucosal response at 2 months. And the ulcer healing could actually be seen at 2 months in most of the patients who had TB. And when you did not have ulcer healing, the diagnosis was either Crohn's disease, or in one patient it was actually a drug-resistant tuberculosis. Now a patient, you have started on ATT and has not clinically improved. That does not mean that it was not TB, because a significant number of them actually harbor strictures, and this was a meta-analysis we recently published. A quarter of patients with GI TB have underlying strictures, and 75% of them have a clinical response, but a quarter of them will continue to be symptomatic. And in fact, in our patient, which we were talking about, we had started ATT, and at 6 months you can see there is a stricture, and the patient was taken up for endoscopic balloon dilatation. So there is a subset who would need surgical intervention. This is if the strictures are far off, let's say in the small bowel. Now, of course, we have better modalities to deal with those strictures also. But if there's a relentless obstruction, non-responsive to endoscopic dilatation, upfront presentation as perforation or GI bleeding, these are candidates for surgical intervention in GI TB. So to summarize, abdominal tuberculosis has a heterogeneous presentation. There is a low yield of microbiological tests. As a clinician, we need to discriminate peritoneal TB from peritoneal carcinomatosis and intestinal TB from Crohn's disease. A therapeutic or a diagnostic trial of ATT must be taken with utmost seriousness only after a complete evaluation and ensuring a close follow-up in these patients. Sequelae like strictures could complicate management of these patients, and surgery is needed in a subset of these patients. Since I was also supposed to discuss ATT in the setting of liver dysfunction, but with limited time, I've just had one slide. Okay, so it's not here, but I'll just summarize that if you have, there are two situations. One is acute hepatitis, the other is cirrhosis, chronic liver disease. In acute hepatitis, you usually don't start ATT. But if you have to start, you start a liver-safe regimen if it is life-threatening. That is also true for ATT hepatitis. If you have ATT hepatitis and you need to continue ATT, it is a liver-safe. If something like lymph nodal TB, you stop, let the LFTs resolve, and then you start ATT. Now, the other situation is chronic liver disease. So you do a Child-Pugh scoring if it is a class A or a compensated form. Then you can give 2 hepatotoxic drugs. If it is child B, only 1 hepatotoxic drug, and child C, you try to avoid any hepatotoxic drug. Of course, if there are any questions on that, we can take. Thank you.
Thank you, Dr. Vishal, for an exhaustive and elaborative talk on the intestinal tuberculosis. And you have cleared this dilemma, tried to clear this dilemma between ITP and Crohn's. And I must say, you always justifies your job as far as the luminal gastroenterology is concerned. And but I feel that we will miss that part of the ATT in liver dysfunction because of the constraints over the time. There is one question from my side as far as the ATT and liver dysfunction is concerned. That if the patient at the time of onset of tuberculosis is having like SGOT and PT 200, 300, right? We are not sure whether it is a disseminated or whether something is going on. Then how to start with the ATT? Should we start with the first line ATT? Because if the granulomatous lesions are there, then it is going to be an impact on it. Or vice versa, it can have a deleterious effect if the ATT-induced hepatitis occurs on these patients. So what is your take on this point?
So this is a common clinical dilemma, and unfortunately, there are no clear guidelines, to really support a particular practice. But what I do that I can, probably say, if you have SGPT OT more than 2 to 3 times, it is better to start conservatively. If you have hyperbilirubinemia, jaundice, certainly, so for example, let's say there is a lymph node compressing the bile duct and you can have jaundice. So, although there is no liver dysfunction, but it is better not to start the standard ATT. If liver enzymes are aminotransferases are less than 3 times, it is okay to start standard ATT. If it is only alkaline phosphatase elevation, like granulomatous hepatitis, where the aminotransferases are just 2 to 3 times, or even less than that, there it is still okay to start the standard ATT. But of course, one has to be very careful with these patients. For the usual patients, the guidelines, our guidelines don't recommend a standard follow-up or LFT monitoring, but we tend to, in these patients, do a regular follow-up with LFT. Not really sure if that is helpful, but that's what we do.
Just a minute. Another question from my side. We are starting on this SCQ and regime and all these things. If we are not giving the standard ATT, right, this streptomycin, labetalol, and quinonols, we start with that, and the literature has shown that the efficacy only 70-75%, if I'm not wrong. Then should we keep continuing this regime, or if the hepatitis is resolved, then if we start introducing, then what is your take on reintroduction of this ATT, and which drug should be avoided at its best?
So reintroduction is a science and also an art. I mean, if the LFTs have improved and you are now ready to reintroduce, it is always better to reintroduce. Now, there are 3 strategies which have been described in literature. One is you start all the 3 drugs at the same time. One is you start 1 drug full dose, go to the 2nd drug full dose, and 3rd drug full dose. And then, of course, is the incremental approach, that 1 drug lower dose and then full dose and then 2nd drug lower dose. What we do is 1 drug at a time and full weight-based dose, so that is the dose you actually want to give over the long term. But you also want to identify if any drug is the culprit of the ATT hepatitis. So this is the strategy that we follow. It is always better to give the standard therapy. Introduction of rifampin or isoniazid first does not make a difference as far as incidence of ATT hepatitis is concerned. So that is a clinician's discretion what to do. In very severe forms of ATT-induced drug liver injury, we tend not to reintroduce pyrazinamide. You may call it a bias because there is no real hard data to support that kind of a practice, but that is what we do.
Sir, thank you so much for this excellent talk. I have just one question. Do you have any experience of using PET scan to differentiate peritoneal carcinomatosis versus TB peritonitis?
So we have not personal experience, but there is a published data and very elegant study which was published from China, which looked at PET CT. And what they found that a regular string of bead kind of appearance in the peritoneum rather than a smudged or clustered uptake suggests TB versus peritoneal carcinomatosis. Also the pattern of uptake, or so the sites of uptake. So you know that there is a continuous peristalsis or a movement of the fluid which keeps going on in the peritoneum. So there are certain areas where the cells get deposited or the malignant deposits are there, like the pelvis. And indeed, even on PET CT, the deposits were more likely in that pattern. So that is known as, I think there was a term called SAPI, which was used to describe that pattern of involvement on PET CT. So yes, PET could potentially be helpful, but there was a lot of overlap even in that study, none of these things being very, very specific.
Sir, you are not audio.
Patient of liver cirrhosis comes in terminal stage with massive ascites, tuberculosis AB positive, liver is nodular. So what treatment here you give? And second, you haven't touched about the lymph node TB in the abdomen. Whether there is a tissue culture is important, because after giving treatment of HRGD for 7 months, necrosis is still there. But if we stop the treatment, the lymph node remains same, necrosis is there is no sign and symptoms. My first question is, terminal stage of cirrhosis liver with massive ascites, with AIB positive, what treatment you start?
So I think this particular question has been addressed in the ICMR standard treatment workflow, which we had made for the ICMR. And I would like to state that this is one of the most difficult management issues. So what you are basically talking about is a child C cirrhosis, and in that you cannot use any of the 3 hepatotoxic drugs. So you can start, again, the problem is that thankfully you didn't also include HRS. So many of these patients will also have a renal failure, during the course, and then it becomes even more difficult. But
usually there is a better renal failure.
Dr. Manchanda, please keep it short.
Yeah, so that makes things even more difficult. But a prolonged duration of ATT, typically with 3 drugs, is recommended for these patients, and the treatment can go actually on for 18 months. The second question was. So the guidelines, so if you look at the standard treatment workflow, they talk about, one is of course levofloxacin, ethambutol, and also one being an injectable drug, which is a, yeah. The problem is, of course, if you have a renal failure, then you have to personalize or tailor make the therapy for that individual. Now the second question was the lymph node TB, and I didn't touch upon it,
I think I need Dr. Vishal. I think congratulations to Dr. Vishal. The topic has been very well received, as is indicated by the number of queries being put to you. I'm sure we are going to have a coffee or tea break at some point of time, and all the people who have so many curiosities, questions, they can personally interact because he's physically available. So I think, thank you once again, and we'll proceed further. All right, so it's a pleasure for me to invite now Dr. Dr. Gaurav Gupta, and he'll be talking of extended use of ethambutol, which is another important clinical issue. So, Dr. Gaurav Gupta, please.
Sir, Dr. Gaurav Gupta is virtual, so we have a recorded one which we will be presenting, and he will be talking about of the extended use of ethambutol, which has happened in the NTEP, and the problems which we are facing and encountering as a consequence of increased duration of ethambutol therapy.
Video nahi hai, sir.
Yeah.
This one?
A very good morning to all. Myself, Dr. Gaurav Gupta. I'll be speaking today on ethambutol-induced occupancy. At the outset, I would like to thank Department of Pulmonary Critical Medicine, PGMS Rohtak, especially Dr. Pavan Kumar Singh, to give me this opportunity to speak in front of you all. So, ethambutol is an anti-tubercular drug given to all patients with as per standard ATT schedule. And ethambutol use may lead to permanent vision loss by inducing a dose and duration dependent optic neuropathy. It is not an uncommon problem. And recently the guidelines of revised National Tuberculosis Control Program of India have been revised to allow for fixed dose and longer duration of ethambutol use. This is likely to result in an increase in vision-threatening adverse effects. So, what is the incidence of ethambutol-induced toxicity? How common it is? So, cumulative incidence of any visual impairment in all patients is 22.5 per 1,000 persons treated with ethambutol, and permanent impairment was found in 4.3 per 1,000 TB patients. And this incidence ranged from 1 to 2.5% at dose of 15 mg per kg, 5 to 6% for dose of 25 mg per kg, and 18 up to as high as 18% for dose of 35 mg per kg per day. So it is very much dependent upon the dose at which it is being given and for how long it has been given. The toxicity typically occurs between 3 to 5 months of uses, although there have been reports for toxicity report as early as 1 month and as late as 12 months of use. So, is it really a problem? What is the burden of this problem? Do we really need to know about it? As we all know that as per India TB report, India has an incidence of 192 cases per 1 lakh of population, and as per Indian population, almost 25 lakh people suffer from TB every year, and we go by the incidence of this problem. So almost 50,000 patients each year suffer from some form of visual impairment due to this drug, and so we need to know about it and how to detect this problem. So clinical presentation is very important. It is subacute, bilateral and painless symmetric loss of central vision. Though visual impairment involvement may be asymmetric or sequential, it is not necessary that both eyes need to be involved together, but usually both eyes are involved. Fundus examination is very important in these cases, and fundus examination often is normal in initial stages. Only small peripapillary hemorrhages or hyperemic disc may be observed, but in late stages there is temporal disc pallor, and in advanced stages there is complete optic atrophy, there is complete disc pallor. Color vision may be normal or may be abnormal in these cases, so color vision is not the only test. There is decrease in contrast sensitivity, so early detection is the key in these cases. So further we need to investigate these cases by, there are various ancillary investigations like OCT, that is ocular coherence tomography. So early changes can be easily picked upon in OCT. So what we see in these cases, we see temporal thinning, maybe sometime increase in temporal nerve fiber layer in early cases also. In advanced stages, there is thinning in temporal quadrant. Also, ganglion cell complex layer thickness is also decreased. And the classical thing is RNFL thinning in temporal region. And on follow-up, there is progressive damage due to this toxicity. So progressive thinning is very important. Here we can see these are the disc of right eye and left eye. Here you can easily appreciate this temporal pallor. This is a case of ethambutol-induced toxicity. This patient was on anti-tubercular drug for 9 months. And here this is an OCT images. Green here means normal, yellow means borderline, and red means abnormal. So if we can see the thinning in the T means temporal quadrant, there is a lot of thinning in both the eyes. And this is ganglion cell complex image, and here you can see it is in red, completely red. There is complete loss of ganglion cell layer complex. So these changes, not only ophthalmologists but all physicians should be able to interpret these tests, and these kinds of tests should always have a red flag sign that if the patient is on ATT and on ethambutol, then this can be an ocular toxicity due to ethambutol. Another thing is visual field or perimetry testing, which is very important, plays a key role, and it may also help in early detection in these cases. Mostly it is the central or centrocecal scotoma. As we have just shown, there is a temporal thinning. Why? Because there is a thinning in the papillomacular bundle, and whenever there is a loss in the papillomacular fibers, then we see this kind of central or centrocecal scotoma. And in advanced cases, there may be bitemporal hemianopia have also been reported. So how central scotoma see? So this is the visual field, this is a grayscale, this is a pattern deviation plot. We can see these scotomas, these are classical central scotomas. Another, we can see this is central and centrocecal scotomas. So if we see any visual field in which we see this kind of central scotoma and patient is on ethambutol, your ear should be up, then why it is happening. Another test which all neurologists can easily do is VEP, that is visually evoked potentials, and it may reveal abnormality in the amplitude or latency of P100 wave. So if there is a delay in VEP latency, then it is an early biomarker for ethambutol toxicity. So I would like to say that there is no one pathognomic ocular change of ethambutol toxicity. The whole clinical picture need to be kept in perspective while making the diagnosis. It's not just that we need to see that there is a decrease in vision or there is a decrease in contrast, because many times the patient do not have those. There are subclinical cases too. So OCT perimetry plays a key role in diagnosis. So it is a whole picture which matters, not the single test or single finding. So now coming to indicators for early detection, as we have seen that in advanced stage there is a decrease in vision. So we need to detect these cases early, and subclinical cases need to be detected if we want to treat them early. So what are the main markers? So change in the average RFN thickness, it may be increase or decrease in the early cases. GCC, that is ganglion cell complex thinning, as in OCT as shown. Reduction in VFI, visual field index. Presence of visual field defect in the pattern which is shown, and prolonged VP latency. These are the very early detection. So in all cases, these need to be looked for. So what are the risk factors? What are the cases in which we need to take special care, in whom the ethambutol toxicity occur more? So there are several risk factors, but few of them have been highlighted a lot, like the patient is of old age, patient is of pre-verbal age. We need to look them, because they will not be able to tell the decrease in vision. If the patient has renal disease, if the patient is low weight, already marasmic, or a patient has any coexisting diabetes mellitus, patient is a chronic tobacco or alcohol user, then these cases are very high risk cases. So now I'll be talking about this ethambutol toxicity expert panel consensus for the primary prevention, diagnosis, and management of ethambutol induced optic neuropathy. So a lot of expert panel consensus have been given, which suggests the screening guidelines for physician as well as ophthalmologist. So what this expert panel have given recommendation, that whenever a patient of TB comes to a physician, then we need to document the history of any pre-existing visual or ophthalmic complaint before starting the treatment. If we find any pre-existing visual or ophthalmic complaint, then we need to have an ophthalmic evaluation before initiation of the treatment. And any patient with high risk features, which I have already discussed, that is low weight, high age, tobacco, alcohol, diabetes mellitus, all those cases of having high risk for ethambutol toxicity, or those patients receiving combined therapy with linezolid, or those patients in which prolonged ethambutol therapy need to be given, have to be referred to an ophthalmologist for ophthalmic baseline evaluation at the start of the treatment. And for all patients which are already on ethambutol, the treating physician should ask for a complaint of a decrease in vision or change in the quality of vision, difficulty in reading on their routine follow vision. So all your notes should mention at least asking about the visual complaints. And ideally, the committee has given consensus that a physician who is routinely treating patient with TB should have a visual chart in his office and perform a quick vision assessment on each follow-up. So the similar screening guidelines for ophthalmologists have also been given, that for ophthalmologist, opportunistic screening of every patient on ethambutol treatment should be done even if they visit the ophthalmology department for an unrelated cause. And the baseline evaluation should include visual acuity, color vision, contrast sensitivity, and visual field test. If the facility is available, then a baseline OCT-RN perimetry and a BEP should be documented, because it is very important to in these cases, because subclinical cases otherwise can be missed very easily. The ophthalmologist should screen for possible risk factors of ethambutol toxicity and warn the patient, and should ensure a close follow-up on those patients. And the high-risk patient should have a baseline visual function test and must be followed up every 2 monthly. So the follow protocol should be every 2 months in these cases, and they need to explain the danger size like drop in vision or change in any quality of the vision also, which is very important in these cases. So now the question arises, we are very keen in diagnosis ocular ethambutol toxicity, but is it actually reversible? Can we treat those cases if there is a toxicity, if there is optic neuropathy? So yes, we can treat. So subclinical cases do not even progress to clinical level even after 1 month of continued therapy. So important thing is that we see a subclinical case, we do not need to stop ethambutol, but we need to have them on close follow-up. If it progresses, then we need to stop the ethambutol. And all the subclinical cases are completely reversible after cessation of the drug. There has been a study published in Journal of Clinical Neuro-Ophthalmology which have suggested that all subclinical cases are completely reversible. And in clinical cases also, in which there is a severe visual deficit due to ethambutol toxicity, 42.3% achieve a visual acuity better than 200 after an average follow-up of 8 months after stoppage of the drug. So in all clinical cases in which we see signs of ethambutol toxicity, the drug has to be stopped immediately, because otherwise there will be a permanent damage, and only 42% recovers to ambulatory vision and rest do not. So that is more than half of the patient will have a severe visual defect. So what is the treatment? We have stopped the drug. Now, is there a treatment possible? So till date, there is no effective treatment for ethambutol-induced toxic neuropathy other than stoppage of the drug. Some trials have been conducted which shows the role of some people give oral steroid, some people give IV methylprednisolone. But in those cases, there is no proven role of steroids also. Early detection of the disease and stopping of ethambutol may help in preventing further deterioration of vision function, and also some people improve. So recovery of vision function is most often partial and incomplete, though complete recovery has been shown in several cases when ethambutol was stopped early. So early cessation is the key. The patient may be started on cocktail of vitamins like methylcobalamin, thiamine, pyridoxine, because methylcobalamin have been proven to augment papillomacular bundle of eyes. So there have been mixed report. So the committee has decided that we can give methylcobalamin, thiamine, and pyridoxine in these cases because they may suggest some recovery. So with this, I would like to conclude this talk by saying that ethambutol toxicity is a cause for potentially permanent vision loss. So we need not to ignore these cases, and this is a real problem which need to be addressed in the current scenario of longer duration of its use under the new tuberculosis treatment guidelines in India. It is not something which is not known. We have known it since years. The impact of ethambutol on optic nerve and retina has been long known, but still no definite treatment has been found. Thus, prevention of the ocular toxicity, early detection, and management with early discontinuation of the ethambutol are the only effective strategies to address. So, we need to detect these cases early, we need to diagnose these cases early, and we need to stop ethambutol if diagnosed early. So that is the key, and that is the message from my side today. So thank you so much. I would have loved to attend this personally, but due to some personal commitment, I could not attend this session. But all your questions I would love, and these are welcome on my email ID, that is aishurehospitals@gmail.com, and thank you so much.
So, thank you, Dr. Gupta, for the elaborate discussion on the ethambutol extended use. All of you know that this is dose related and duration related. And initially there was a concern the use of the ethambutol may not lead to these optic neuritis, and children may miss this complication and may not have the permanent damage. But with the lower doses which are used in the NTEP, the ethambutol toxicity is not that common a thing. But here's that word of caution that many of the drugs are interacting with the ethambutol. They commonly use acetaminophen, clonophenol, the acetazolamide. They can increase the concentration of the ethambutol once they are used concomitantly. A patient is having some headache, some problem, pain. If you are giving this acetaminophen, it may increase. Because acetazolamide may be given in glaucoma and other conditions, it may increase. So the word of the caution is that if at all you want to give some analgesic, then this should not be out of these. You give the alternatives, and we should be monitoring these. We should be asking the patient for these ethambutol toxicities, and if it is continued to be given for a prolonged duration, the effect may be the permanent. So that is the word of the caution. And my comment.
I think we are going towards the conclusion, but before closing, just a final comment I'd like to make. See, our main aim should be, when we are specifically going for extended use of ethambutol, then safety becomes a concern. There are some new things which are being tried with a lot of success. One of such things is copper supplementation, because EDTA has been known to chelate copper and causes copper deficiency. 2 milligram per day of copper has been found to be very good. Second thing is that iron overload. In any situation, for any reason, you may be giving a lot of iron to the patient. This promotes ethambutol toxicity. So at all costs, please avoid iron overload. Third thing is that this may be the scenario where the role of pharmacologist comes, that we probably need to find out a drug delivery system which gives a provision of ethambutol giving through the agency of DPI. So if you can do that, this also probably can take some of the toxic potential of the drug. And lastly, in patients with CKD, again, it could be a problem. So here comes the role for therapeutic drug monitoring, that in a patient of CKD, if we want to prevent toxicity of ethambutol, maybe there is a role for TDM. So with this, I think we conclude this session. And I hope all of you have enjoyed it, and I could see from here your body language, your attentiveness, So I think all of you have enjoyed these sessions, and I wish that more sessions will be further benefiting you all. So I think pass on to the organizers for whatever the next activities. Thank you.
Thank you, everyone. Thank you, all the dignitaries, for such an informative session. Sir, I would like to invite Dr. M.C. Gupta for the token of appreciation to Dr. Jaikishan.
I think in positive times, अगर सारे इकट्ठे आ जाए तो कोई formality तो नहीं है ना. सर ये सबको हम individual देंगे, and this is what will be.
Please give a big round of applause.
Bear with us so to save some time. Thank you so much. Thank you. Correct. Okay.
We'll move forward for our next session. It's never complete without them, and it's always for them. They are our ultimate teachers. From them, we learn, we think, and we grow. To raise the awareness about the disease, let's give a round loud of applause for the TB champions.
For the same, I would like to invite Dr. Harpreet Singh, that is the ex-senior professor and unit head in charge of medicine, PGIMS Rohtak, Dr. Suman Vishwakarma, district TB officer, Bhiwani, Dr. Ankur Agarwal, pulmonologist, Holy Heart Hospital, and alumni of Department of Pulmonary and Critical Care Medicine. And Dr. Rajesh Raju, state TB officer.
Good morning, ladies and gentlemen. At the outset, it's my pleasant duty with my co-chairperson to thank the organizers to give us the dais. Since morning, we have been talking and we have made the sensitivities about what tests can be done, what drug should be done, what should be its level, how should we look for toxicity. But what goes on with the patient, we don't talk. Today, I invite Hardeep Singh. He is CEO India 7-Eleven company, who would give his perspective as a patient, that what goes on and how does a patient conquer the disease. Yes, the tests are required, they help us. The treatment is required, it helps us. But more important is the patient's acceptance, going for the challenge and then coming across and now being a role model. He is CEO India 7-Eleven company, and I invite Hardeep on the dais. Well, a brief account about Hardeep. Hardeep suffered from MDR in 2000. It was an infancy state. We did not have the DST levels at then. The getting testing was a problem. The formulations, the regimens were a challenge, very expensive, and it was more or less I would say, a set of 40 patients being challenged, they being given some response, and then based upon. So it was not something that now we have a formulated algorithms that we formulate upon. Hardeep today participates. He suffered from MDR, got treated by 2002. Presently, he is one of the regular marathon runners in Indian scene. And he doesn't see a disability with a fibrosed lung. And last word, Hardeep is my younger brother. I call him Kinu, as does Dhruv. Hardeep, please.
Thank you. It's a flashback for me over the last 20 years. It was 20 years back when on one day, the reports came out and I got to know that I suffer from this disease. And so I just wanted to share a few perspectives, having walked this journey and now 20 years hence, how do I look at it? First and foremost, yes, initially there is a setback, but I would, my personal experience was that it didn't last long. Very soon, probably by the next day, for some reason, maybe I was in very safe hands of Dr. Dhruv Chaudhary, Dr. Harpreet, but I think the very next day I knew it is treatable. So I know doctors always tell the patient it is treatable, but if this content is going to get used by patients, I just want to speak their language. Trust it, trust the process, it is treatable. I think there are very complex jargons was thrown and will continue to be thrown by doctors here, but continue to believe the process, continue to think that it is treatable. In my case, I now understand a very complex cocktail of drugs was created by Dhruv and Harpreet, but I think I took a course which lasted 18 months. It started including 75 days of injections, but never came a moment when I thought that it is not treatable. I think I can say with due modesty, I did not miss a single day of drug, because I started to look forward to life after it, and that pulled me off for those 18 months. Second, I would like to talk about importance of food, importance of diet, and I think Dr. Mahesh Gupta said there's no one size fit all. That's true for us, the patients or the ex-patients. Each of us have our own. People say ye khana chahiye, wo khana chahiye, ab ye khao, wo khao, but we know our body, and there is a fair range of food that's available which suits us, which you like. So for example, it's not mandatory to go, if people who are non-vegetarian, it's not mandatory to go very high on a meat or a fish or a chicken or something. For example, my personal experience was I'm fond of eggs. I went big on eggs. Big means, yeah, a regular intake of eggs, same way on choice of fruits. But yeah, diet goes hand in hand with the drugs, with the whole, the clinical part of it. Last but not the least, आप सब लोग बार बार दिखा रहे थे lungs के, some fairly complex photographs were shown and will continue to be shown. Like I've been raised in a family full of medicos, but I think a large part of TB sits here, and somewhere last but not the least, staying positive through it is so important. So surround yourself with people who talk positive about it. Look at positive statistics and not negative statistics. I come from a corporate world. Ye hoga to wo hoga, ye hoga to wo hoga. There is always a positive side of a statistics and a negative side of statistics. So especially to patients, I would like to share this personal belief that the positive statistics is far more believable, trustable, and that's what's going to pull you off. Harpreet mentioned the only side effect which I realized later was that I have this fibrosis in the right lung, and I think the last of the treatment ended somewhere in December 2003. I was told ye karna, dheere se start karna, fibrosis hua hai, but theek hai, suna, thoda man ka bhi suna, thoda doctors ka bhi suna, but dheere dheere kuch karna start kiya. So 2004 mein I participated in a dream run of Airtel in Delhi, and 2005 se I started marathon, and I have run 15 marathons, one every year. Somewhere वो दिमाग में आ जाता है कि ऐसे कैसे fibrosis से ये होता है वो होता है. I decided, so what, life moves on, and so these three things I wanted to share. But yeah, stay positive, trust the process, follow it blindly, and continue to take good food and count your blessings. Yeah. Thank you.
Hello. TB champions. In state, we have more than 200 TB champions to advocacy of the program. But the way he has stood and he has conveyed his feelings go beyond mind and touch the heart. Touch the heart of policymakers, doctors, paramedical staff, and even our patients. The prevalency survey showed that 63% of our patients were not either aware of their symptoms or they avoided to come to the health centers or any of the doctors or health-seeking behavior as they were negative about it. अगर TB हो गया तो क्या करेंगे? TB निकला तो क्या करेंगे? So TB champions can bridge that barrier, and we are going as state TB officer. I can assure that we are going far with the TB champions to utilize them to break this barrier, and they are our hope. As you said, you had faith in the doctors. We have faith in our TB champions, and a big round applause for all TB champions, including Hardeep. Thank you so much faith, hope, positive feelings, positive attitude, and take the disease face off. We'll face the difficulty together. That's the spirit. Thank you.
Thank you. Thanks a lot.
Just to add, he was one of them who was asymptomatic when he was detected. He was changing his job. Suddenly an X-ray flashed. He was asked not to join the job. He said, I'm asymptomatic. He sent X-rays to Dhruv and me. And we said, yeah, it makes no sense. But then his Mount 2 was negative. And then he had to take 6 months of ATT. But then Dr. Mishra used to be here as a radiologist. I still remember going to him at the Nurula Center. And he said, Kaka, TB to hai. Chahe tum isko thandi mano, chahe garm mano. And so he took the treatment. Now he was being followed up. And the second time when this MDR story came up, it was then he probably developed the symptoms.
Yeah.
And when me and Dhruv, we analyzed, what happened was that when he was on 4 drugs, his X-ray was showing a response. And when he completed, the company took him because the X-ray was showing just a marginal change of increase. But maybe those 4 months when he was without the 2 main drugs, paracetamol, ethambutol, which because he was taking asymptomatic and any individual would not take that. And then probably it recurred and it was slow in process since he's an active athlete, good in diet. Probably he was overlooking and then the symptoms overtook him. The second part is that it was not a journey without any side effects. He developed the worst of gouts that a patient can develop. His foot size is beyond the normal size and no shoe would fit, and one can imagine the great toe hurting him. And in a corporate world, he could not walk in chappals when he joined back. So those are some of the things that come back. But yes, Hardeep was positive because the anchor and the pillar was Dhruv, who was so positive. हमें बहुत बार कहा जाता था, we were in our young stage, 98, 2000, यार किसी बड़े को भी दिखा लो. And Dhruv said, नहीं भाई, stick to our mind and we'll do it. And Dhruv did it. Thank you, Dhruv.
Thank you.
I want to add, we are talking about TV champions, we want to send a positive message, one. But secondly, it is equally important what stress actually the carers were going through. I could see the stress, Harpreet can very talk about it, I think Hardeep can correlate with it. The family that went through the turmoil, it was easy now for us to retrospectively 20 years to talk about. But when the journey started, I remember Harpreet coming to my place, and if he permits me, and he doesn't get, he was in the tears. He went to it, washed his face. He said, this is what has come up. This is what I'm saying. And same, when I went, same was the father, of the mother, of the young wife. So these are the issues as the doctors we don't touch. I think these are very important that the support is not only to that, because most of the time, these issues again come up when you are a parent, when you are a bread earner, and that is what happens, sir. So these are the issues, these are the challenges. And why did I call him? Not that he's dear to me or family it's there. Because it's a stigma people don't want to come out with. He told me once, he said, if anything you do about TB, encouragement about it, call me, I am there to support and help the people to fight with the TB, with the stigma. And that is the reason, and we are so proud of you, Hardeep, the way you have, and you have been so open about it. Thank you so much.
A last word, time and again for the house, we always ask, get an HIV done. I'll quote you my family example. My bhabhi, because she was all stunned when she came to know that it is MDR +4 sputum. Now they were told to get an HIV. Now suddenly the faith of the wife to the husband suddenly goes down. You can imagine. Now I'll take you to the memory that she went to Siddhi Vinayak temple, took the lifafa on. She didn't open the lifafa, whether it was positive or negative, believing कि शायद आज HIV भी positive आएगा. तो वो सिद्धि विनायक में जाके उसने अपना लिफाफा खोला और उसने कहा, वहीं से कहा, भैया thank you, सिद्धि विनायक मंदिर ने मेरी बात सुन ली. My husband is HIV negative. That started the assurance. Because there is lack of faith in the patient, the family, and then it builds up. मैं उनको words में sum up नहीं कर सकता. It's an emotional journey, and it has been brought back. But why I'm emphasizing is, हम लिख देते हैं ELISA for HIV without talking, because the wife only reads not the sputum but the HIV status, and then he starts questioning. She starts questioning, and there are many more in the story. But important is, these are certain subtle points. Hello, Suman. It's the points which the patient looks forward to. And as a doctor, because I am in between, I was neither a doctor, I was an attendant then, but Dhruv made me a doctor at times, he made me an attendant at times. But thank you, Ardeep, for understanding the situation, bringing back, and he should be a hope, because he has brought a new concept in India, 7-11, which is almost, am I right now? 7-11, it is an American concept, and now he takes the country to another in case, by grace of God, and this would be one of the big chains in India as it's coming. It's supported by the Mukesh Ambani Group.
Yeah.
Thank you.
Thank you. Thanks a lot. And not just Dhruv and Harpreet, I think to many of these group, I'm still the chota bhai. So Sanjay, Dr. Mahesh Gupta, I can name quite a few of you who helped me through this journey, but I'm always available. Yeah. I don't at all wear it as a stigma. In fact, recovery to me is a medal bigger than a marathon medal. And happy to share my journey with anyone, happy to help in whatever little capacity I can be of any use. Do feel free to reach out to me, always available. Once again, thanks a lot for inviting me.
Over to Dr. Ankita.
She is a BTech student.
Okay.
Who has undergone
TB champion again. Yes. We welcome Madam Ankita, one more TB champion of Haryana, coming forward to alleviate the stigma and taboo attached with the disease. Over to Madam Ankita. आप कुछ बोलना चाहेंगे? ठीक है. Till Ankita takes over, a take of Dr. Suman regarding TB champions.
Good morning, one and all present here. I am Ankita Gupta, and I would like to thank Dr. Dhruv Chaudhary sir, जिन्होंने मुझे आज इस काबिल समझा कि मैं एज अ TB चैम्पियन यहाँ पे अपना एक्सपीरियंस शेयर कर सकूँ. So it can motivate other TB warriors and also strengthen them. Today I am a final year student of BTech, and I am suffering from lymph node and bone TB. आज भी मुझे क्लियरली याद है कि ये सब कैसे स्टार्ट हुआ था. सर्दियों के दिन थे, दिसंबर 2021 की बात है. मैं वैकेशंस पे नॉर्मली अपने घर आई थी, और पता नहीं कैसे अचानक से रात में पैरों में दर्द होने लगा. तो हमने सोचा हो सकता है ट्रैवलिंग की थकान होगी, इसलिए इग्नोर कर दिया, और मम्मी ने सुबह शाम मालिश करनी स्टार्ट की. पर वो दर्द कम होने की बजाय पैरों से हाथ में, हाथ से पूरी बॉडी में इस तरह फैल गया कि अपने पैरों पे चलना तो दूर था, खड़े होना भी मुश्किल हो गया. एक लाइट का बटन खोलने के लिए हाथ उठा के खोलने से अच्छा था कि मम्मी को आवाज़ लगा के बुला लूँ. पर जब डॉक्टर्स को दिखाया तो डायग्नोस हुआ कि लैक ऑफ हीमोग्लोबिन एंड वाइटामिन्स. तो फिर उसका ट्रीटमेंट चला. जब पेन थोड़ा सा कम हुआ तो रिपोर्ट्स चेक की, तो फिर उसमें ESR भी थोड़ा सा ज़्यादा था. और जब ESR की इंक्रीज़ होने का रीज़न चेक करने के लिए अल्ट्रासाउंड किया गया, तब उसके अंदर डाउट आया कि ट्यूबरक्लोसिस हो सकता है. अब ट्यूबरक्लोसिस इतना बड़ा टैबू है इंडिया में कि घर पे यकीन ही नहीं हुआ कि हाँ सच में ट्यूबरक्लोसिस हो सकता है, वो भी एक 19 साल की लड़की को. पर ट्यूबरक्लोसिस का डाउट तो था. अब उसको क्लियर करने के लिए हमने ऑर्थोलॉजिस्ट से स्विच किया मेडिसिन के डॉक्टर रवि मोहन सर के पास. उधर मेरा क्लियर हुआ कि लिम्फ नोड ट्यूबरक्लोसिस है. अब ATT स्टार्ट हो गई. ATT स्टार्ट हुए लगभग 1.5 महीने ही हुआ था कि पैरों में फिर से दर्द होने लगा, कमर पे जो थी पस आने लगी। उसके लिए फिर मैं 4 से 5 दिन की वैकेशंस लेके घर पे आई, तो पता लगा कि ये श्वास एब्सेस है। अब श्वास एब्सेस के लिए आगे कंटिन्यू करने के लिए रवि मोहन सर ने मुझे पॉजिट्रॉन में डॉक्टर जिले सिंह कुंडू सर के पास जो था रेफ़र किया कि आप यहाँ से आगे कंटिन्यू करवा लो। अब सर ने श्वास एब्सेस देखी, सारे टेस्ट देखे, तो उन्होंने कहा कि इसको सर्जरी के थ्रू ड्रेन करना अच्छा है। अभी तो ट्यूबरक्लोसिस का होना ही डाइजेस्ट नहीं हो रहा था घर पे कि इतने में सर्जरी। पर जो थी ये श्वास एब्सेस पैरालिसिस भी कॉज कर सकती थी और जो थी लाइफ थ्रेटनिंग तो थी ही, इसलिए घर पे लाइफ को ज़्यादा इम्पोर्टेंस मानते हुए सर्जरी का डिसीजन यस में ले लिया। लेकिन डाउट तो खुद भी थे मन में, इसलिए मैंने रात को रवि मोहन सर को फ़ोन किया और उन्होंने मेरे को ऑलमोस्ट 30 to 50 मिनट्स फ़ोन कॉल पे बात करके सारी बात अच्छे से क्लियरली समझाई और काफ़ी सपोर्ट किया। तब जो था थोड़ा थोड़ा डाउट कम होने लगा और कॉन्फिडेंस भी आने लगा। तो जब सर्जरी हुई उसके बाद मतलब मैं कहती हूँ कि शायद सारी लाइफ भी कम पड़ती ये सब सीखने के लिए जो उस एक सर्जरी ने मुझे सिखा दिया। उसमें पता लगा कि फैमिली के अलावा कोई भी पूरे लाइफ में वर्ल्ड में कहीं पे भी कोई ऐसा नहीं है जो फैमिली के अलावा तुम्हारे साथ हर वक्त हमेशा खड़ा होगा या तुम्हें सपोर्ट करेगा। तब जो था धीरे धीरे समझ आने लगी बाकी चीज़ें, सब्र भी आने लगा और पता नहीं लगा कब 1 महीने का बेड रेस्ट जो था 4 से 4.5 महीने के बेड रेस्ट में कन्वर्ट हो गया। जख्म इतने गंदे लगते थे देखने में कि उसे देखना तो दूर, मम्मी देखते ही उस पे जो थी रो पड़ती थी। पर ड्रेसिंग भी करनी थी तो फिर उसकी ड्रेसिंग मम्मी रेगुलरली 4 से 4.5 महीने तक रेगुलरली मम्मी ने किया है और छोटे भाई ने किया। अब ऑलमोस्ट 2.5 महीने हो चुके थे बेड रेस्ट को और सेमेस्टर के एग्ज़ाम्स आ गए थे। ना तो तैयारी की हुई थी, अब ना तैयारी करने की हिम्मत थी। पर वो टाइम भी मेरे छोटे भाई और उसके पीजी ऑनर के कारण काफ़ी इजीली निकल गया और धीरे धीरे कुछ कंडीशंस के साथ जो था बेड रेस्ट भी ख़त्म हो गया और मैं काफ़ी खुश थी कि चलो अब तो जो है सिर्फ मेडिसिन लेनी है और धीरे धीरे एटीटी भी ख़त्म हो जाएगी। लेकिन अभी तो खुशी पूरी नहीं हुई थी, इतने में नेक पे फिर से नोड निकल आई और वो काफ़ी स्वेल करने लगी, पस बनने लगी। तो फिर जो थी सर को फिर से मैंने रवि मोहन सर को कॉल की और कहा कि सर ऐसे ऐसे फिर से प्रॉब्लम आ रही है। तो सर ने मेरे स्टीरॉइड्स स्टार्ट कर दिए और साइड बाय साइड अगर हम देखें तो पर्सनल लाइफ भी कंटिन्यू करनी थी और इस टाइम मैं फाइनल ईयर में आ चुकी थी अपने बीटेक के। अगर कोई थोड़ा सा भी लिंक में होगा इंजीनियरिंग से तो उन्हें मालूम होगा कि इंजीनियरिंग के फाइनल ईयर में प्लेसमेंट्स स्टार्ट हो जाती हैं और 4 साल तो मेहनत भी इसी के लिए करते हैं कि प्लेसमेंट चाहिए अच्छी कंपनी में। तो मैंने क्या किया, टीपीपी में तो पहले ही इनरोल था, अब प्लेसमेंट्स में बैठना स्टार्ट कर दिया। और टीपीपी के जो हमारे कोऑर्डिनेटर्स होते हैं वो बोलते हैं अगर आप कोप कर सकते हो तभी रजिस्टर करो, अदरवाइज आप रजिस्टर ही मत करो। मैंने कहा चलो चांस लेते हैं, रिस्क उठाते हैं और रजिस्टर कर देते हैं। रजिस्टर किया तो फिर प्लेसमेंट्स भी कंटिन्यू करनी है। अब प्लेसमेंट्स कंटिन्यू कर रही हूँ पर जो था रोज़ का कैंपस में जाना, सुबह से रात भी हो जाती थी तब तक की सिटिंग देनी और फिर नेक्स्ट डे फिर सेम रूटीन फॉलो करना, पूरा दिन स्क्रीन पे जाना, बहुत हेक्टिक हो जाता था, बहुत थकान होती थी। पर मैंने कहा चलो देखी जाएगी। फिर जो थे स्टीरॉइड साइड बाय साइड चल रहे थे। अब सर आए, रवि मोहन सर वापस आ चुके थे और मैं उनके साथ उनके पास विज़िट के लिए जो थी वापस जो है अपने घर आई। घर आने के बाद सर ने सारे टेस्ट कराए और उसके बाद फिर कहा भाई कि आप क्या करो, इंजेक्शंस स्टार्ट कर दो। अब इंजेक्शंस भी स्टार्ट हुए और साथ के साथ उन्होंने मेरे को ध्रुव चौधरी सर के पास रेफ़र कर दिया कि आप आगे यहाँ से कंटिन्यू करा लो। अब मैं कहना चाहूँगी कि ध्रुव सर जो थे एक दूसरी स्ट्रेंथनिंग पिल थे जिन्होंने सच में बहुत सपोर्ट किया। मेरे तीनों डॉक्टर रवि मोहन सर, डॉक्टर जिले सिंह कुंडू और ध्रुव सर, तीनों इतने अच्छे हैं, इतने फ्रैंक हैं और इतने सपोर्टिव हैं कि कभी फील ही नहीं होता कि सच में प्रॉब्लम कितनी बड़ी है। तो अब जो था इंजेक्शन्स लग रहे थे, मतलब एक इंजेक्शन लेते हुए मैं हर रोज़ इतना डरती थी, इतना रोती थी, लेकिन अब तो धीरे धीरे करके आदत ही पड़ गई। तो इस इंजेक्शन्स की जर्नी में भी मेरे को जो थे अपने कॉलेज में एक और ऐसे पर्सन मिले जो हर रोज़ मेरे को मोटिवेट करते थे, और एटीटी की जर्नी उनके कारण भी काफ़ी ज़्यादा इजी और कह सकती हूँ भाई कि मतलब अच्छे से निकल गई वो एरा भी। अब इंजेक्शन्स ख़त्म होने का टाइम आ गया। मैंने सोचा भाई कि चलो अब तो इंजेक्शन्स भी हो चुके, इसके बाद क्या ही होगा। तो मेरे को लगा कि चलो ख़त्म हो जाएगी, अब तो जस्ट टैबलेट्स लेके कुछ टाइम का ख़त्म हो जाएगा। 9 मंथ का ट्रीटमेंट 1.5 से 2 साल तक पहुंच चुका था, पर अब इंजेक्शन्स का टाइम भी बस ख़त्म ही हुआ था, इतने में फिर दूसरी नोट जो थी नेक पे निकल आई। अब उस नोट में बार बार पस बनती और उसको काफ़ी बार ड्रेन करवाने के बाद भी वो अपने आप से फिर फट गई। अब मेरे को मन में डर था कि ये जो नोड है ये हमेशा दिखेगी, और पेरेंट्स को था कि कोई भी देखेगा तो पूछेगा, और ये होता भी है, कोई भी देखता है मेरे पास भी, पेरेंट्स के पास भी, तो पूछ लेते हैं कि ये क्या हुआ है, जिसको जवाब देने के लिए मेरे पास कुछ होता नहीं कि किसको क्या समझाऊं। तो फिर अब धीरे धीरे करके जैसे सर ने मेरे को सपोर्ट किया, ध्रुव सर ने काफ़ी सपोर्ट किया कि हो जाएगा ठीक, तो उन पे ट्रस्ट रखते हुए मेरे को था हो जाएगा ठीक। अब भी ये काफ़ी ठीक हो चुकी है। तो मैं यही कहना चाहूँगी कि अपने डॉक्टर्स पे ट्रस्ट रखो। अगर डॉक्टर्स पे ट्रस्ट है और वो कुछ कह रहे हैं तो फिर उस पर मान के चलो, चाहे रिजल्ट्स दिखें चाहे ना दिखें। रिजल्ट्स आ रहे हैं, दिखने ज़रूरी नहीं है। तो और सबसे इम्पोर्टेंट रहता है कि आपके पास सेल्फ कॉन्फिडेंस हो, डॉक्टर्स इतने अच्छे गाइडेंस में हो आप डॉक्टर्स के, और फैमिली का इतना अच्छा सपोर्ट है, तो आई डोंट थिंक कि ट्यूबरक्लोसिस कोई भी एक बड़ी प्रॉब्लम सामने हो सकती है। और मेरे को लगता है कि शायद जो है अब एटीटी की जर्नी एंड हो जाए, और लेकिन मतलब ऐसा नहीं था कि सबका सपोर्ट भी मिलता है लाइफ में। सोसाइटी में कुछ लोग ऐसे मिलते हैं कि नहीं करते सपोर्ट, ट्यूबरक्लोसिस नाम सुनते ही इग्नोर करना स्टार्ट कर देते हैं, कुछ फ़र्क ही नहीं पड़ता किसी को, और कुछ जो होते हैं काफ़ी सपोर्ट करते हैं, फैमिली की तरह ही सपोर्ट करते हैं। मेरा जो वेट था वो काफ़ी ज़्यादा लूज़ होके 40 kgs तक लूज़ हो चुका था, और गालों की तो हड्डी भी दिखने लगी थी। लोग भी काफ़ी मजाक उड़ाते हैं, और पतले होने के कारण ये तो बचपन से ही सुन रहे थे कि काफ़ी पतले हो, काफ़ी पतले हो, पर हर रोज़ दिन में 10-10 बार ये सुनना कि पतले हो, कुछ खाया पिया करो, रोज़ का मजाक, वो ज़्यादा थोड़ा सा इरिटेटिंग हो जाता है। पर मेरे को सबसे ज़्यादा जो डर लगता था वो डर लगता था कि कहीं ये कम्युनिकेबल तो नहीं है। तो मैं रवि मोहन सर से यही पूछती थी कि सर ये कम्युनिकेबल तो नहीं है, क्योंकि मुझसे ये बिल्कुल भी सहन नहीं होगा कि जो चीज़ मैं सफ़र कर रही हूँ वो मेरे कारण कोई और सफ़र करे। इसलिए सर मेरे को प्यार से समझाते कि नहीं है कम्युनिकेबल। अब घर में छोटा बेबी भी आने वाला था, उसके लिए सबसे ज़्यादा डर लगता था कि न्यूबॉर्न्स जो होते हैं बहुत ज़्यादा सेंसिटिव होते हैं, कहीं उनको ना कुछ इशू पड़ जाए मेरे कारण। पर तब भी मेरे को डॉक्टर्स ने काफ़ी समझाया कि नहीं है कम्युनिकेबल। तो फिर मैं यही सोचती हूँ कि दुनिया में सबको सब कुछ समझाना ज़रूरी नहीं है, ज़रूरी है तो वो है सेल्फ कॉन्फिडेंस, एंड जस्ट एक्सेप्ट द ट्रुथ एंड गो विद द फ्लो। थैंक यू।
थैंक यू अंकिता, आपने अपना जो एक्सपीरियंस शेयर किया। और मैं आपसे किसी में से कोई क्वेश्चन पूछना चाहें तो आपने ऑडियंस में से पूछ सकते हैं।
इसकी बच्चे की जो सबसे बड़ी बात था कि पेरेंट्स को था कि क्या मेरी लड़की की शादी हो सकती है, क्या वो एडजस्ट हो सकती है, क्या वो कैरियर में आगे जा सकती है। व्हाट आई वाज सरप्राइज वाज हर मदर इज आल्सो देयर। शी सेड डॉक्टर साहब बच्चा ज़रूरी है, शादी की ज़रूरत नहीं है। सिमिलरली हमने कई ऐसे इसलिए रखे कि यंगस्टर्स ये बच्चियाँ जो आ रही हैं, ख़ास तौर पे जब इनको कईयों को MDR के कारण जब क्लोफेज़ामिन मिल रही है, कलर चेंज हो रहा है। आई नो फैमिलीज़ where you have seen they have difficulties in these issues. So idea है कि हमारे जो साथी हैं वो sensitize हों, क्योंकि she has a very big mark of scrophloderma, and that was evident from a distance. That is what she was saying, and that was one of the major reasons. And she said, "Sir, I want to share my experience. मैंने सफ़र तो किया है, लेकिन आप सारे जो मेडिकल सिस्टम के सपोर्ट की कहानी है उसके साथ में मिलके इसको आगे शेयर करना चाहते हो." तो मुझे लगा कि एक 19 साल की बच्ची अगर हमारे साथ शेयर करना चाहती है, वॉलंटरी ऑफर कर रही है, तो क्यों ना हम इससे हम सबको सेंसिटाइज कराएं. आई होप ऑल ऑफ यू मस्ट हैव लाइक्ड इट, एंड ऑल्सो द जर्नी एक ही चीज़ निकल के आई, पॉजिटिविटी. एंड ऑल्सो हम लोगों को एज ए डॉक्टर मरीज और फैमिली को साथ में लेके, so we not only have to treat the disease but the patient having the disease, and also take the support and help of the family and move ahead with it. Thank you very much.
I think I'm just taking the opportunity that Ankita, she had a very tough and arduous journey, and yet she maintained her confidence and trust on the doctors. तो भाई एक बार सब तालियां बजाना चाहेंगे अंकिता के लिए. And secondly, इसने बड़ी एक इम्पॉर्टेंट तौर बताई, 3 डॉक्टर्स के नाम लिए जिन्होंने बहुत सपोर्ट किया, हर लेवल पे इसका कॉन्फिडेंस बढ़ाया. मेरा अपना मानना ये है कि शायद सारे डॉक्टर ऐसे ना होना चाहिए. तो मैं उन 3 डॉक्टर्स जिसको उसने अप्रिशिएट किया है, तालियां उनके नाम की भी बजनी चाहिए.
When she came to me, Dr. Kundu, she was almost 36, 38 kg, very cachectic, and I thought she will not be PAC fit, whether she will be able to tolerate the anesthesia. But family supported her, and I counseled her mother also. Her mother came with her, and then this was a very huge abscess in the Swas area, and it was on the verge of bursting. We just assisted the nature, and this was drained, and ultimately this area is healed very well. And she is doing very well, and I'm very happy to see the glow on her face. Thank you.
गुड आफ्टरनून. मैं खुद डॉक्टर हूँ, आई एम रेस्पिरेटरी फिजिशियन, और ये जो एक्सपीरियंस है, आई माई सेल्फ सफ़र फ्राम दिस हिप ट्यूबरकुलोसिस, एंड THR वॉज डन. मेरे लिए बहुत मुश्किल था. मैंने अपनी प्रैक्टिस स्टार्ट की थी भिवानी में, और मैं राउंड ले रहा था और मुझे हिप पेन हुआ, एंड इट वाज वेरी डिफ़िकल्ट. मुझे समझ नहीं आया क्या है. मैंने अपने औरतों के फ्रेंड से बात की, एंड देन लेटर ऑन आई वाज डायग्नोसिस जो था वो बन नहीं रहा था, एंड आई फाउंड लेटर ऑन कि मुझे ट्यूबरकुलोसिस हिप है. एंड फॉर 3 to 4 years मेरे लिए प्रॉब्लम था. डॉक्टर गुलेरिया के पास मैं गया, एंड ही वाज वेरी काइंड एनफ, और मैं 3 महीने उनके पास रहा एम्स में, एंड मेरा भी कॉन्फिडेंस एक बार शटर हो रहा था कि हो क्या रहा है. सो अल्टीमेटली द थिंग इज़ कॉन्फिडेंस एंड बिलीविंग इन योर डॉक्टर. दैट्स द वेरी इंपॉर्टेंट थिंग, एंड यू कैन.
Ankita courage is marvelous and immaculate. And now the medical part of it. The treatment is continued for about 2 years. What I think from our talk. Number one, once that pus was taken out, CBNet and LPA was performed or not, medical part of it, if you allow, not otherwise. And secondly, that in between she was given steroid while she was having frank pus from the lymph node. That these 2 questions need to be addressed by Dr. Dhruv.
Hello.
We have a paucity of a time, and आज डॉक्टर मैनी का भी है, तो कुछ को वहाँ भी पहुँचना है. So I think we will just quickly do it so that things are on time. We are already half an hour.
Yes, sir.
Thank you.
Just a few comments. Positivity, faith in the system, self-confidence, and believing that family is with me and family support. These are major pillars for this successful treatment, not only medicines. And the most important part, TB champions standing on the dais telling you that they faced such and such difficulties. Somewhere in our clinical practice, when we see 80 patients, 100 patients a day, are sensitive parts, the receptors which were sensitive to the emotions of patients, they somehow go into dormancy because of daily routine. But Ankita, Hardeep, and Sir Dr. Meja has brushed up those receptors again, and I think we'll be more receptive to their emotions and their queries and their doubts in future, right from this moment. Thank you all. Thank you, my TB champions. Thank you.
सर मैं भी ये बताना चाहूँगी कि जो टीबी चैम्पियंस की जो हमारी कंसेप्ट है प्रोग्राम के अंदर, वो बहुत ही मतलब जो हमारा एक सर स्टिग्मा है, जब भी हम देखते हैं ना तो पेशेंट्स में स्टिग्मा ज़रूर होता है कि अगर टीबी का डायग्नोसिस उसको बता दिया जाता है तो वो एकदम से एक्सेप्ट नहीं करता। जब अगर प्राइवेट का है तो सरकारी में जाता है, सरकारी का है तो प्राइवेट में। अगर 2-3 डॉक्टर से जब तक फाइनली कंसल्ट नहीं कर लेता, इतने उसको ये सेटिस्फेक्शन नहीं होती कि मुझे फाइनली टीबी ही है। और इसमें जो टीबी चैम्पियंस का रोल है, इसको डिस्क्रिमिनेशन को, स्टिग्मा को मिटाने में वो बहुत महत्वपूर्ण है। ये लड़की जो आगे आई है, इसने अपनी जो स्टोरी बताई है, मैं इसके लिए इसको बहुत बधाई देती हूँ कि आगे आई है। अदरवाइज़ मैं भी एक एक्सपीरियंस आपको सर शेयर करना चाहूँगी। हमारे पास, ठीक है सर, अब एक सर हमारी एक फीमेल थी प्रेग्नेंट लेडी जिसको हिप का पेन था, और उसको जो एक्सपीरियंस था, मतलब फिजिशियंस के पास बहुत गई, लेकिन उसका फाइनल डायग्नोसिस बनने में काफ़ी टाइम लगा, और उस टाइम में उसको और कॉम्प्लिकेशन होगी, जिसको मेनिंजाइटिस हो गया और आँखों से दिखना भी कम हो गया। तो मेरा एक यही है कि हम टीबी को भी एज ए डायग्नोसिस अपने उसमें रखें डिफरेंशियल में, और टीबी चैम्पियंस के रोल को और भी ज़्यादा सपोर्ट करें ताकि वो हमारा जो स्टिग्मा और डिस्क्रिमिनेशन है उसको हेल्पफुल रहें और प्रोग्राम में आगे हेल्प करें। थैंक यू वेरी मच। थैंक यू सर।
Thank you to the TB champions and for such an inspiring session. And I will hand over the dice to my fellow anchors, that is Dr. Sonal and Dr. Sushila, for the further.
I would like to thank Dr. Rajesh Raju and Dr. Suman Vishkarma. So there's some time, photographs ready हो रहे हैं, so we'll have that event later. एक बार थोड़ा time लगेगा sir, momentous ready होने में. So we'll start with the inaugural ceremony. I, Dr. Sonal.
I, Dr. Sushila, take this privilege to invite on stage our guest of honor for today, Dr. Ashok Garg, representative from
May I have the honor to invite on stage chief guest of today's occasion, Padam Dr. D. Behra, Professor Emeritus Pulmonary Medicine, PGI Chandigarh, and ex-chairman NTEP. I request Dr. Dhruv Chaudhary sir to felicitate Dr. D. Behra. And I request Dr. Dhruv Chaudhary sir to present bouquet to Dr. S.S. Lochab. Okay. Sir, please, Dr. Behra. Sir, it's an honor to have you here with us. A huge round of applause, please. We have such eminent personalities with us. Now I request Dr. Dhruv Chaudhary sir to present bouquet to Dr. S.S. Lochab, Director, Pandit B.D. Sharma, PGIMS Rohtak. I request Dr. Deepak Chen to give the floral welcome to Dr. Kuldeep Larar, Dean, Pandit Bhagwat Dayal Sharma, PGIMS Rohtak. Dr. Kumari Indu, DTO Rohtak, to please present flowers to Dr. Rajesh Raju, STO Haryana. तालियों की कमी नहीं होनी चाहिए, please, I request everyone. Dr. Prem Prakash for floral welcome of Dr. Jay Kishan, STF Chairman, Haryana. And Dr. Jyoti to present flowers to Dr. Ashok Garg, representative from Haryana Medical Council. Dr. Ashok Garg, if present in the... And we'd like to welcome Dr. Serene. Sir, please, I request Dr. Dhruv Chaudhary, sir, to please present the bouquet to Dr. Serene. And floral welcome to Dr. Pawan Goyal, President API Haryana Chapter, and Dr. Ajay Mahajan, President-elect IMA Haryana. Dr. Ashu Grover from ICMR. And Dr. Kamna? मेरे को नहीं पता था सही चीज़ It's a pleasure and honor to have so many eminent personalities under one roof.
Light symbolizes knowledge. It not only dispels darkness but illuminates our soul. I request our dignitaries present on stage, Dr. Sanjeev Kapoor, Dr. Pawan Goyal, and Dr. Ajay Mahajan to light up the auspicious lamp.
And all the dignitaries sitting in the front seat, please be there to light the lamp. Hanji.
Oh, sir. Suman? Suman?
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
The biggest mistake business
Hello. A true welcome is never complete without kind words and warm gestures. I request Dr. Dhruv Chaudhary sir on stage for welcoming the dignitaries.
Good morning. We have 15 minutes before it's noon. We are running half an hour late, so I will just keep it short and simple. Thank you very much to all of you. We thought of TB update. It was a spontaneous act when I discussed with Dr. Raju, and we wanted to do it on 24th actually. And then Honorable Prime Minister's program was there in Varanasi, so it got postponed from 26th and then to today. It has its own logistical challenges because of, it is a big, I can say we are on the cusp. New Year has started and all from the perspective of organization. Thank you so much, and I'm so honored that Professor Behera, who has been my revered teacher, and also of Pawan, one of backbones here, with whom I have been my colleague. Sir has been responsible for what we are today. And sir, thank you so much from my heart. And what the department we are seeing today has been having his blessings. And sir was the one who came as an inspector and allowed us, as a director, he was at LRSI, to start the course of DM Pulmonary and Critical Care Medicine in PGI Rohtak in 2011, before even All India Institute of Medical Sciences. So I will request all of you to give a big round of applause to Professor Behera sir. So what we are today, where we are today, without the blessings of him, we would not have been there. I also extend my warm welcome to my dear, sorry for using that word, but our Honorable Director, Dr. Lochab, my dear friend, brother, Dean, our Dr. Lalad. We all are, three of us are class fellows, so we work as a friend, we work as a team. We also ensure it, because Dr. Lochab, as I said, is a cardiothoracic surgeon, and we are the two sides of the thing. I am thoracic, and Dr. Lalad is cardiac. And it has been an uphill journey, but nevertheless a very fruitful one. Thank you so much. We thought that we are talking about big, big things. Let's talk about the thing which touches every day. And that is the reason we talked about it. And extremely grateful to all my learned faculty who have made it to this place. Thank you, Dr. Sareen. Thank you, Dr. Kabra. Thank you, Dr. Jain sir. Thank you, Ashu. She is one of us. And Dr. Anand Jaiswal sir, Ashutosh, Deepak. And the name, if I missed it, its fault is mine. Thank you so much.
Now I request Dr. S.S. Lochab, Director, Pandit B.D. Sharma, PGIMS Rohtak, to sir, please say a few words.
Good morning, everybody. It is my immense pleasure to be invited here in this tuberculosis update CME, organized by Department of PCCM in collaboration with Department of Respiratory Medicine, API, state, our state division, TB division, and National Academy of Medical Sciences, New Delhi. Tuberculosis is a very old disease, and we don't know exactly when it started. And the evidence comes from mummies from Egypt, where this bone tuberculosis was detected, and so on. This disease was considered as a very sort of lethal disease earlier, when it took life of so many celebrities or very, very important persons. It was, I think, John Keats, and in our country, Swami Vivekananda also. So this disease has been a social stigma also, and it was considered to be not treatable. But with the research and progress in understanding of the disease, in 1882, Robert Koch identified this bacterium. And then there came the discovery of this anti-tubercular drug, streptomycin. That was the first drug. But before this drug treatment came, the other important issues like nutrition, hygiene, and other things, and this disease was controlled in Europe, although it was quite common before that. So and so forth. Many new drugs have come, many new technology has come in the diagnosis and treatment of this disease, but still the prevention is the best one for any disease, and like tuberculosis. So all the eminent speakers and other experts in this field have come here. Why we, although this socio-economic progress happened in Europe, but in this part of country, Haryana, Punjab, where GDP is the highest one, the disease is still prevalent, and we should explore the various regions, why it is not being eliminated from this part of the country, specifically Haryana, Punjab. And we are the experts from whole of the state here, and I think we will think about it, we will discuss it and explore it, that what specific methods we can apply in this particular region. So I congratulate the Department of PCCM, particularly Dr. Dhruv, Dr. Pawan, and Department of Respiratory Medicine, Dr. Prem Prakash here, who have made this program feasible, and a very successful CME here. So I thank you again for inviting me here. Thank you.
Our Vice Chancellor, ma'am, Dr. Anita Saxena, ma'am, will not be able to attend CME, but we have recorded message. And may I have the message, please?
Namaskar and a very good morning. On behalf of the University of Health Sciences, Rohtak, as well as on my own behalf, I welcome you all to this update on tuberculosis. I welcome all the delegates as well as the expert faculty that have come over today to give their lectures. I am specifically thankful to Dr. Behera, who has agreed to be the guest of honor and has taken out time of his busy schedule. I would like to congratulate the Department of PCCM, Dr. Dhruv Chaudhary and his team, who along with collaboration with Department of Medicine, Department of Respiratory Medicine and the State Division of Tuberculosis of the Government of Haryana have decided to hold this event. I think we all know that tuberculosis remains very relevant for us in India and many other countries, and the problem specifically of MDR or multi-drug resistant tuberculosis is something that is worrying us all. I'm sure with the deliberation that you're going to have today, there will be some solutions to the problem of MDR that we are facing today. I once again welcome all the delegates, and I hope you enjoy the scientific feast that is for you today. I'm really sorry that I couldn't be with you in person because I had already committed to another conference in Cochin. However, I'm sure you're going to enjoy the day. Please interact with your colleagues. Please use this occasion to meet your old friends and acquaintances. And thank you once again for coming. Bye-bye.
Now I take this opportunity to request our distinguished chief guest, Dr. D. Behera, to address the delegates. Dr. D. Behera needs no introduction. He is well known for his work in the field of pulmonary medicine, tuberculosis and lung cancer. He received prestigious Padma Shri honor from the Government of India for his contribution in the field of medicine. He has held various vital positions in prestigious national and international bodies. Sir, please.
Thank you very much. The dignitaries on the dais, I could see many other stalwarts. I could see Dr. Jain, my colleague and a dear friend. We are working together in the National Academy. I could see Professor Sareen, who is one of the lead experts in the country as well as internationally. In fact, I think maybe he came back 2 days back. He was on assignment in a foreign country to help them to end TB in their country. And I could see Dr. Kabra, I could see Nivedita, I could see Dr. Jaiswal, my former colleague. And ladies and gentlemen, At the very outset, I am very thankful and quite happy that two super specialists of Rohtak, that is Dhruv and Pavan, हाँ पेपिट लगा दिया so they have taken interest and organized this one-day CME. Of course, unfortunately, nowadays the super specialist pulmonologists are taking less and less interest, but here these two gentlemen have started, had organized this one day, so I am very happy, Dhruv and Pavan, for that. So, we just, before that, we heard about tuberculosis. TB is a very, very old problem. It is there for a very long time, and I do not know how long it is going to stay. In the meantime, we have, the country has pledged to end TB by 2025. So what I'll try to do, I'm not going to give a straight answer that whether we are going to end TB by 2025 or not. I'll just try to give you my perspective about TB, what little bit I have learned, particularly I think I should say my gurus are Dr. Sareen, Dr. Jaiswal and the entire team of LRS Institute. So whatever little I know about TB, so I'll try to give my perspective about can India end TB by 2025 and what are the issues, and I'll just go to give you a brief outline. As I told you, tuberculosis. So now tuberculosis is the 13th major killer in the world today, and amongst all the infectious diseases following COVID, so this was the most common killer. It is the leading killer of the people with HIV, and it is the major killer related to antimicrobial resistance, that means the DRTB. You see, this is the overall picture of the global and the national magnitude of tuberculosis. We have got the global TB report of 2022, because the 23 report of the global TB report is not yet being released. It will be released sometimes in October. So I am giving you the estimates of TB burden. Out of the 10.6 million cases of TB in the world in the year 2021, the estimates was around 3 million. I will try to see how much we have notified. That is constituting about 28.3%. And again, see, of the 1.4 million deaths in 2021, the India's contribution was around 35%. Similarly, HIV TB, and particularly I will draw your attention about MDR TB. Of 4.5 lakh cases of MDR TB in 2021, India, it was estimated that it will be around 120,000 or 1,20,000 cases, with a range of 93,000 to 145,000 cases of MDR TB. That is again about 26.4% of the global burden. You see, we have got just a week back, the India TB report 2023 was released, and that gives an idea about the TB situation in our country. That is for the year 2022. You see, the same thing I have told you. You see, in 2022, if you see on the right hand side, out of an estimated case of 28 lakh cases, we reported around 24.2 lakhs of cases TB to the NICHA program, and that was an increase of about 13%. That was reported in the year 2021. That means there is an increase in the case detection rates. You see, so this is what is the TB notification to the NICHA for year 2022. You see, we reported about 87% of the estimated cases of TB in India, and then because still about 5 lakh cases or maybe sometimes 4 lakhs of cases of TB, still they could not be reported or they could not be diagnosed. That is one thing. The another important thing, please note, is the public sector. And from the private sector, the cases are also being reported now more and more commonly. This particular slide I have tried to show you. You see, this is the case notification for over the last 6 years or so. You see, the case notification rate was going on. We are, the notifying cases more and more, detecting cases more and more. But because of COVID, there was a dip in the year 2020, and again it started rising. And this is one of the things, the two things. What does it mean? These are just not figures. It tells us two things. One is our TB diagnosis and notification efforts are increasing. So therefore we are detecting more and more cases. So that means one positive point. But the negative point, if I see from a negative angle, I could see that still so many cases of TB are being detected every year, new cases in the country. That is what is the negative aspect of it, if I see it that way. But if I see it positive, I could see the program is detecting and reporting more and more cases over the years, except there is a slight dip as you see in the COVID time. And again, this is about as of 2022, as I said, it is for 2022. India is having about 1/4 of the global burden that I have told you. The another important thing to note, the three things, that is TB, MDR TB and TB HIV. India is one of the countries where we have got all these three problems together, which are important deterrents for TB control activities in the country. The global emergent TB was declared as a global emergency, as we know, in the year 1992-93. And then to fight against that, there are different strategies were adopted. In the very beginning, that is in 1994, the strategy was DOT strategy. And then there are 5 important components. I am not going to that. Where it was the direct observed therapy short course was the main focus. Then it was the stop TB strategy in the year 2006, where the main important emphasis was to pursue high quality DOTs, addressing TB, HIV, MDR TB and other challenges, and then health system strengthening, etc. Then from 2014 again the focus was shifted as the end TB strategy. I will tell that little later, which was the focus was, it was integrated patient-centered TB care and prevention, bold policies and supportive system. Of course, all the previous things will be continuing. So this is how the focus and strategy has changed over the years. The end TB strategy, the WHO end TB strategy, the main vision was the world free of TB with 0 deaths, disease and sufferings due to tuberculosis, and the goal is to end the global TB epidemic. And 3 important indicators were highlighted. One is the reducing the number of TB deaths compared to those figures in 2015. And then there are different milestones by 2020, 2025. And then what should be which year, what should be the reduction. And then the second component was reducing the TB incidence rates compared with again what was in 2015. Say for example, by 2030, it was said that should be reduced by 80% and by 35 by 90%. And then the third important component was that TB affected families facing catastrophic costs due to TB. So that should be 0, because no family should face any catastrophic cost. So these are the 3 important components, and in that they were based on 3 important pillars and components. As you can see, there are 4 important principles and 3 pillars. This next slide shows us that the 4 principles were the government stewardship, strong coalition with the civil society, and protection and promotion of human rights, and adoption of the strategy and the targets. And the main pillars were basically it is not possible to go into the details of each one. That is integrated patient-centered care and prevention, then bold policies and supportive systems with the political commitment, and then financing, etc., and then intensified research and innovation. So these were the strategies. I think this is a very important slide, and that is so if we have to end TB by 2025 or 2030 as it may be. So I think three important components we have to understand. One is the strengthening the TB services, accelerating case detection, and preventing TB. You see, in 2017, the current global trend of reducing the TB was around just 1.5% per year. Then somewhere now, the picture is around 6.5%. But actually, if we have to reach this NTB strategy, this graph is to be pushed, what we call the bending the curve. We have to bend the curve. Then if it only comes to the tune of about 17% per year, then only we will be achieving this one. So actually we are nowhere near that. And how we will achieve that, to bend this curve, is through those various three important strategies that starts with the case diagnosis, case detection, treatment with effective therapy, then prevention with the preventive therapy, vaccines, newer drugs, newer regimens, etc. So these are some of the strategies. If you want to, end TB, these are the strategies we have to adopt. So, again, WHO has told very clearly to implement these NTB strategies, there should be certain essential things. Say, for example, you see, you have already heard about the NTB strategy. There should be 80% reduction in TB incidence by 2030, and 90% reduction in the number of TB deaths by 2030, and no TB affected households will face the catastrophic cost that I have already told you. And then these are the top 10 priority indicators. They are not ranked, but they are the priority indicators for monitoring the implementation. So we need to monitor that way. Say, for example, the recommended target level will be the treatment coverage should be 90% or more. And then treatment success rate should be again 90% or more. And then percentage of TB affected household, as I told you already, they should be getting free. So it should not be catastrophic cost is not to be faced by the patient or family. Then the new and relapsed patients, they should be tested using the WHO recommended rapid tests, and the time of diagnosis again should be 90% or more than that. So these are some of the 10 important, parameters that has been, if we have to reach NTB strategy. So it is basically a 90-90-90 approach, or the 90-90-90 target. That means we have to reach at least 90% of all people with TB, and as part of this approach, reach at least 90% of the key populations which are the most vulnerable and underserved or at risk population, and then treatment success rate should be 90%, whether it is drug sensitive TB or drug resistant TB. So actually what is happening in the world, this is again the global picture. You see, we are far. You see, the target between 2015 and 2025, it should be 75%, but actually the reduction rate is just, we are not even 1/3 of that. Similarly, the TB incidence, it should be the 50% reduction by 2015-2025, but again the reduction is between 2015 to 2021, it is only 10%. Similarly, the preventive treatment, that means 30 million people should receive the preventive treatment by between 2018 and 2022, but what we have achieved is only 12.5 million. Similarly, those who are people living with HIV, so all these targets are fixed. I am not going to read everyone. That the TB treatment, say for example, between these 5 years, about 40 million people should have received the treatment, but again, only 66% of them have received this treatment. Similarly, the drug-resistant TB, only 43% of the people, they have received the treatment. Then again, and many other things, similar the research and all that. So we are actually far beyond than the expected targets. What in our country, what we did, we have also, this is the evolution of TB control in India. In the early 50s and 60s, we have got important TB research that was being done at the TRC at that time, TB Research Center at Chennai, and the National TB Institute. And then 62 onwards, we had got a program, but it was not a structured program. It was named as National TB Program or NTP. Then in 1992, the program was reviewed. And then at that time, very strangely, you see, when it was reviewed, it could be seen that only 30% of the patients could be diagnosed. Of these, only 30% could be treated successfully, and with 80% or 75% success rate, that means of the 100 patients of TB, only 9 could be treated successfully or they would be cured. So obviously we need to do something more. So then it was named as RNTCP, or the Revised National TB Control Program, and with those components which I have already told you. And then by 2006, the entire country was covered by the RNTCP. Again, to give the further thrust to the TB, the name now has been changed as the NTEP, or National TB Elimination Program, from 1st January 2021. So the country, and then over the years, there are various strategies that have been adopted. They are good, they are dynamic, and our TB control program is the world's largest and the fastest growing public health program. Like any other, it is even the entire world. So these are the positive aspects of our program. But then I think then another thing added up on the 13th March 2018, the Honorable Prime Minister declared, if you remember, I had told you the NTB strategy was 2030 was the year, but the Honorable Prime Minister declared that no, we should, our attempt should be to end TB 5 years ahead of the global target or the WHO target. So that is what is now the issue and the problem. But again, if we have to end TB by 2025, so what we should do, So let us see first what the program has achieved or is doing. So that, as I told you, it is one of the largest and fastest growing program. The dimension of TB control, just now you have heard about an hour ago, the TB is just not Mycobacterium TB positive and give treatment for 6 months or 2 years or XY months. That is just not like that. It has got many other dimensions you just heard, and 3 of them told us. And you see, from just not as a clinic, TB just not as a clinical problem, it has got also a public health component that needs patient support, engagement of all healthcare workers, and then the community empowerment is also very important, which is a multi-sectoral approach addressing the non-health determinants of TB. You see, then the program works through a system, and we have got both state and the central system, and we have got through the health system, delivery system of this country. We work through that, and then this is now the National TB Elimination Program. You see, since the inception of RNTCP on March 2006, the free diagnosis and treatments are provided under the program. More than 25 million TB patients are treated so far under the program, and more than 4 to 5 million additional lives have been saved. And then you see 1.4 million TB patients have been tested for drug-resistant TB. You see, just alone in 2022, you can see 1.4 crore sputum smear tests were done, and 58 lakhs of NAT test could be done in 2022. Again, you see so far 0.45 million drug-resistant TB patients, they are diagnosed. Most of them are MDR or rifampicin-resistant TB, around 15,000 XTR TB, and 58,000 mono or poly INH resistance cases. You can see more than 0.7 million TB patients are notified from the private sector, and we have expanded the horizon, as we say, beyond the, as I told, beyond the disease and the treatment, the beyond TB as a disease, like the Pradhan Mantri TB Mukta Bharat Abhiyan, then the Nikhya Mitras, and then Nikhya Poshan Yojana, that is what about nutrition, then integration of various ministries, TB Vijetas or the TB champions you just heard, and then the corporate social response. So this has gone beyond the disease. That means the entire society and the country, various ministries, they are being involved. You see, now it may be little depressing. You see, these are the trend of TB burden between these are the first one that shows the global, the global estimate, and then our in-country estimate. As you can see, over the year, if you start from 2015, it was 256 incidents was per 100,000 population, and by 2021 it is around 210, very slow decline. And in the India model, from 225 in 2015, so we have now come to around 192. So there is a decline, but it is not fast enough. Similarly, the mortality also as per the global estimate, so also our own in-house estimate. So it is not a very encouraging thing from 27. So we have come down to only 23 in 2022. And then this is what is the slope which I have shown. The upper one is the global, the down one is that is what the India estimate. Then what is the issue of case notification? All cases are not diagnosed, whether they are pulmonary or extrapulmonary TB. And then even if many patients are diagnosed, but they are not possibly notified to the NICHA system. So that is, I think, one issue we have to understand. So then the strategies, as I told you, from a passive case finding from the early years, we have gradually changed into intensified case finding, where it is provider initiated. The passive one, it was the patient initiated. If the patient had got the symptom, so the patient used to come to the health system to get the diagnosis. So now our strategy has changed from this passive to intensive to active case finding, which is again it is a provider initiated, that is done in the community setting. There is a systematic screening of the vulnerable population like migrants, slums, prisons, etc. Then I think from 2020 onwards, again our focus has shifted, and I should say rather added, that is the population based, that is the vulnerable mapping, like the periodic screening of the vulnerable population, which we will just see little while. So we have got a presumptive pulmonary TB, there is a definition, I think you all know that. Then this is how more and more groups of people are now included under the screening, so that we could detect the more and more cases. Sometimes in the years 18, 19, we are talking, there are the missing millions. We had a estimated number of cases, but our reporting cases was about less than a million, less than 10 lakhs. I think over the last 4 or 5 years, because of this approach, the gap is being certain. That means just now, as I showed you, from the 10 lakh missing cases, now our missing cases are only 3 to 4 lakhs. That means we are trying to close that gap, but not yet close the gap. Right? And so these are the various ways we do the screening for the TB diagnosis. Then coming to the second part, the diagnostic journey, it is an interesting story, and it is a success story. It is all over the world, newer and newer diagnostics. They were detected, they are discovered. The most important things are obviously the NAT or the nucleic acid amplification test, the cartridge-based test that have come, the liquid culture, and of course many more are coming. So this is a successful journey, I should say. And then obviously the genome sequencing that has come, although it is not yet widely used by the program, but genome sequencing is there. I think his institute is doing that, and then another 4 institutes are doing that. So you see, this is what is the NTP diagnostic network, you see, that has vastly expanded. Unfortunately, TB, even if it is TB was our old problem, very long problem, but I should say our medical colleges and institutions, we had failed. It is not even, we have got 645 medical colleges. Not every medical college even have got a good diagnostic TB culture laboratory. That is what is the fact, Dr. Jain. But that is, I think, one way we have failed. The country has failed. As medical teachers, we have failed. I have got no complaint with your MRIs, PET scans, and all those cath labs because they needed. But a simple culture lab we could not, or we had not established. But anyway, thanks to the program, you can see this is, I have shown you a pyramid. The top one, we have got 6 national reference laboratories, 34 intermediate reference laboratories, 56 culture and drug susceptibility testing laboratories. Particularly they are in medical colleges and private sector laboratories. And we have got nearly 5,000 NAT machines spread all over the country. The exact figure is 4,960 as per the 2023 TB report. And then designated microscopy centers are nearly 23,000. So this is how starting from the periphery to the top, the diagnostic network has gone. We have got a lot of, the NAT, I told you, the LPA, then the liquid culture and the liquid culture DST, and then other things, of course, the genome sequencing at 5 places, now they are available. So this is a vast expansion. So you can see that I was telling you the number of tests that have been done over the years, that is also gradually increasing. The people with the TB missing from the care, that gap has been diminishing. As I have told you, see, say for example, in 2012 the number which were missing, now that is gradually, that gap is coming down. So let us take now, everything is possibly not good, maybe neither, please, it should not be taken that I am trying to find out some criticism to somebody. It is not that, it is just a retrospection, what we have done, what we have achieved. The challenges what are the challenges then for the TB control is the persisting burden, although we are trying to, to shorten that gap, and then the stagnating case notifications, which is of course is increasing, and then the multi-drug resistance or the drug-resistant TB, HIV-associated TB, then the non-communicable diseases and TB comorbidities, many, then the TB treatment outcomes, weak health system, slow decline in incidence, I have shown you that slide, and then various underlying determinants. You see the underreporting and the uncertain care of TB patients in private sector, that was an issue. Of course, they are coming up now over the years. Then the unregulated private sector and healthcare delivery, any type and everybody is treating TB in this country. That is not good. We have got different types of system. And then reaching the unreached, there are marginalized and vulnerable population, the hilly areas, difficult areas, tribal population, then the drug-resistant TB, comorbidities like HIV, diabetes, undernutrition, overcrowding, and there is a wide geographical variation in the epidemic and many more. So you see, so when the patient comes to a hospital, to a busy hospital, so then somewhere he is missed. He comes with a symptom. Then over the time, by the time you see the last one, the small round one, which you see in a onion model, you can see when the patient comes for some treatment, but by the time he is sent here and there, the diagnosis, treatment, everything is lost. So ultimately, from the bigger circle, we come to the smaller circle. So, the huge risk factors, the diabetes capital, that is a risk factor. Then still 2.1 million live with HIV, various immunosuppressive drugs and immunosuppressive diseases, cancer, organ transplantation, malnutrition, low BMI, various occupations like silicosis, overcrowding, slums, prison, shelter homes. The central jails, you see, of the 134 central jails, the prisoners are, so many prisoners, so that is overcrowded jails. Then the urban Indians living in slum areas around 24% in different parts of the country, and of course the healthcare workers themselves. So these are the highly vulnerable group. You see the latent TB infection, we have got a huge burden. 1/3 of the world population is, of course, infected. So India, the latest figure shows 31% above the age of 31% above the age of 15 years. We are Mantu positive or the IGRA positive. That means that we have a huge latent TB infection burden. Any time there is ignition, so the infection will be converted into disease. I think that we have to, the other issue is I always feel, I think maybe many of us do not know about that. We all know that health is in the concurrent list. And as I told you, our program works through the center as well as the peripheral health delivery systems. So the finance which comes, it is a 60-40 ratio. I think nowadays we are all well trained for the political issues that is going on. That is 60% is given by the center, 40% is given by the states. And then there is a issue whether this 60-40, whatever is the budget, is it coming, is the flow very smooth? My answer is totally no. So there is a contribution and management through the state NRHM, because even if whatever program policies are done, they have to be implemented through the state delivery system, which is a big issue. And then of course, maybe if time permits, I'll show one slide about the human resource. Whatever human resource is sanctioned or given, we have got grossly inadequate human resource, and whatever is sanctioned, they are even not filled. Many posts remain unfulfilled. They are not filled. The finance, whatever is given, that is not being spent. No 100% spending. So these are some of the issues and these are some of the deterrents of the successful program. You see, I think recently we got the National TB Prevalence Survey, that opened the eye. But remember, I will just remind you, prevalence and incidence, they are two different things. They do not reflect the same thing, but it tells us something. If I tell you this National TB Prevalence Survey, remember it is prevalence again, I am trying to tell that. So that shows what it shows, just to see one line. The prevalence of TB in this country is around 316 per lakh population, with a variation between 290 to 342. You see here again, on an average it is 316, but you see from all this it is not uniform. States like Delhi, they have got the highest prevalence. It is around 534 per 100,000. And then of course Kerala, it is the less, but on an average it is 316. That is what I was telling you, the burden of TB. Again with the underlying thought that the prevalence and incidence is not the same, but it gives an idea that still we have got a huge burden of TB. The majority of symptomatic population did not seek healthcare services. I think Dr. Raju was telling in his remark. The reasons are ignoring the symptoms, not recognizing symptoms as TB, self-treatment, could not afford to seek care, still 2% of the people. So among the 36% survey participants who sought care of their symptoms, equal preference for government and private facilities. People still prefer to go to the private setup. You see the tribal population, there is a huge, the burden is on an average, it is even much beyond, it is almost double the national average. It is around 703 per 100,000 population, the prevalence. So here, then now coming to the second part, I was talking about TB treatment. You see, as per the 2022 report, 95% of the diagnosed cases, they could be put on treatment. That one still 5%, because of various reasons, they are not up for treatment. Then those who receive treatment, this treatment success rate is 85%. That is, of course, is increasing over the years. That means, again, I always see the negative, if I see the negative side, that still 15% of the 100 cases of TB, they are not cured. So those 15% are still left out. So again, if you see, remember, I have told the end-TB strategy that says at least the cure rate should be 90% or more. So if we have got, so there is something wrong somewhere. I am not going to analyze that, but you see, still 15% of the cases, we are diagnosing them, but the treatment success is not there because of whatever reason it comes. That is a big issue. So we have got a national strategic plan to control TB between 2017 to 25. The one of the other deterrents is the drug-resistant TB, MDR or the RRTB. I have already told you, the India has got about 120 or 1,20,000 cases. But I think this may be my last slide. I'll try to tell you. You see, I always say there are two sides of the coin. You see, the diagnosis of MDR and RRTB is going up and up. That is from 2007, we started our PMDT program. Right? So the diagnosis is going up. Say, for example, in 2022, we diagnosed 63,000 cases of MDR or RRTB. But you remember one thing I have told you, what is the incidence? That means how many cases of RR or MDR TB should be there? It was 1,20,000. So how many we have diagnosed? It is 60,000. So what is the percent? Divide these two things, it is coming around 50%. So that means we are still leaving out 50% of the cases of MDR or RRTB. Fortunately, the number is not very big, but still 50% of our cases we are still not able to diagnose, despite our so many expansion of the diagnostic facilities, so many NATs. So there is a gap somewhere, there is a missing link somewhere. So we have to, rise up to that. And then the left side showing the so many machines, so many facilities, but still 50% are not diagnosed. And still a small minority of them, it is not very big, I should say, there will be issues, they are not put on treatment. So I think that is another area we should be worried about. Even if we are saying, we are proud that we are diagnosing more and more cases, but we are still missing a larger chunk of these patients. So obviously this is again great evolution of milestones of the PMDT in India, and there are various strategies we have done. We have to diagnose them, we have to treat them, we are doing so many things for them. But again, this is a very which Mr. Hardeep was telling you, the type of treatment he was receiving. Even all these things, the older regimen at that time, what was the success rate? Success rate is only less than 50%. Even with those so-called CAT4 treatment. And then for the XTR-TB, the success rate was only, you can see, around 30-32%. So that was the issue previously. But again, with the newer drugs, they have come, newer regimens, I am sure you will hear it from Dr. Sareen. We have got now the standard drug-resistant TB regimens, like we have got for the INH resistance, the shorter all-oral regimens and longer all-oral regimens. And then you see, these are the success stories. As you can see from the early years, it was only less than for the MDR-TB, this is for XTR-TB. The success is going up. It is around now more than 60%, roughly 65, 66%. For the INH resistance, it is again still high, it is more than 80%. So I think things are improving, but the question is, not everybody is treated. With this rate, again if I tell you, if 100 MDR or RRTB patients, that is 50% you are not diagnosing. The remaining 50 patients, if you get success rate of 60% or 65 or 70%, so out of 100 patients of MDR or RRTB, so how many patients we are curing? So you can calculate that figure. So that is again the deterrence. So but fortunately there are now new regimens coming up. You must have heard about the BPAL regimen. The success rate for them is around 90%. So maybe the country, Dr. Sareen, he is the person who decides, he is the chairman of the National Technical Group. So I am sure they are going to decide very soon whether we will be, going to adopt this one or not. And then there are new things, but again the worry point is the bidaquilin resistance is gradually coming up. Even we are very happy that we got some drug, but still the countries from South Africa, Pakistan, China, India, Brazil and many of these countries, we are now seeing the drug resistant to the tune of 2 to 3% for bedaquiline. So again, that is a warning sign. And then there are newer regimens we have from the next TB trial, Genex trial, etc. So newer and newer drugs are coming. So maybe the regimens are coming down, like BPAL-M regime, which now the WHO is propagating. That is a BPAL along with moxifloxacin and also clofazimine. These are the new trials where the treatment duration will be for the MDR and RRTB. The treatment duration can be reduced to about, say for 6 months or 24 weeks. I do not know when the country is going to take a call. So I am sure the country is very seriously thinking about it. Then at the end, I will just end, ladies and gentlemen. You see, my take, the one more word about the TB preventive therapy. I think prevention is one of the important issues. We have got 2 regimens now, the 6 months INH, and then the 3 months or the 12-dose regimen. That will be more acceptable. But still, our TB preventive therapy coverage is around 30%. Still, we have not yet covered. So, a long way to go. So, my take about NTB strategy by 2025, I think we may have to redate it. We may have to shift it. Number 2, I should say, or I will say, the science has never failed anybody. I think we have failed the science. So, but still, I am hopeful. Still, we should be hopeful. The country, the Prime Minister's message had given a impetus. I think that is what is more important. I am sure the Honorable Prime Minister also knows about it. The 2025 may not, we may not, meet that end, but I think he has given a good impetus and for all of us to work. And apart from that, which is again I will like to re-emphasize, and I like that the TB champions were presented here. So TB is a disease which is not, again I re-emphasize, just not MTB positive, negative, drug resistance, and you give INH, ethambutol, pyrazinamide or rifampicin, but it is something beyond that. But many of these things are now picked up by the program. But again, I should say our attention should not be diverted more towards that. The DBT, the Poshan Yojana, they are required and they are very good things, but our attention should not be diverted there. Our human resource utilization, the financial support is very, very essential. That should be continued. Another last point is the research and innovation. You see, very emphatically, the NTB strategy WHO that says that research and innovation are very important. But again, I am very clear about that. I am not very happy with the program that they are doing little, very little about the research component. But in any case, whether the program does it or not, the ICMR is doing that, taking up that job. We have got a ICMR TB Research Consortium. So we have got many, they have got therapeutic areas, they have got implementation research, they have got many other things. I think 2 vaccine trials that is ongoing in this country. Many of you might not be knowing that. I think both Dr. Sareen and myself, we are involved in that. This is the 4th year. 2 new vaccines. One is made in India. So that is ongoing. So let us wait for the result. 18 centers, 12,000 people are undergoing this trial. And just last week, the the ICMR DG chaired a meeting. Dhruv is also part of that. That is the revaccination of BCG in adults. So that is also going to start in a big way. So I mean, many things are going on, but maybe we may not see the results immediately. We may not, implement it. I do not know whether they will be successful or not. So, but these are the things we are also doing. India is also what I am trying to say. Although the program is not doing that, but somebody at least is doing some research. So, ladies and gentlemen, so this is a overall perspective that I understand about the program. I tried to share with you. So maybe sometimes I may be, looking as if I have got a little negative approach, but that is not a negative approach. It is just a self-introspection. I believe that we have to see ourselves, where do we fault, where where is the mistake and how we should improve it. So with these few words, thank you very much for your kind attention.
Sir, please. Thank you, sir, for such an insightful session. Now I would request Director, sir, Dr. Lochab, Dean, sir, Dr. Lalar, and Dr. Dhruv Chaudhary, sir, to please present a token of gratitude to Dr. D. Behra.
Thank you, sir. Take it, sir. This is also for Dr. Lochab and Dr. Sir, I...
And with that, we are concluded with our inaugural session. It is the same bacillus, same drug, but yet it is different. And with the same, we are moving forward with our next session, that is, how do I manage? It's a case-based discussion.
As the moderator of the session, I invite Dr. Deepak Jain, Professor of Medicine, PGIMS, Rohtak. As for the chairpersons, I invite Dr. Sanjay Marwa, Senior Professor, Surgery, PGIMS, Rohtak. Dr. Surekha Dabla, Senior Professor, Neurology, PGIMS, Rohtak. And Dr. Roop Singh, Senior Professor, Department of Orthopedics, PGIMS, Rohtak. Over to you, sir. Dr. Deepak Jain.
Thank you, organizers. And thank you, organizers, for organizing such a CME. We all have seen that tuberculosis has a very huge burden, and as in India, we are getting around 1/4 of a global burden, and as far as the mortality is concerned, is around about 1/3. As far as going for extra tuberculosis, extra pulmonary tuberculosis, again, it becomes more challenging because then we need, we get more diagnostic challenge as well as a therapeutic challenge. So we have a session here for more of a extra tubercular manifestations, and we have a
three speakers. First of all, we have a session on musculoskeletal tuberculosis, where I request Dr. Anil Jain to please start his procedure.
नेक्स्ट ये है DSTB, ये ट्यूबरकुलोसिस।
Thanks, Honorable Chairman, sir. And friends, I think it was a very exhaustive talk by Dr. Behra, and we understood many things about the program, which each one of us will be benefited. I think now I will be talking about. Could you put this slide? नहीं कनेक्टर प्रॉब्लम नहीं है आई डोंट नो व्हाट इज What is मेल तो बहुत देर लगेगी पेन ड्राइव तो फिर मेरा बैग में पेन ड्राइव ला दे खुल गया तेरा खुल गया सर आप हमारा लैपटॉप यूज़ कर लीजिए पेन ड्राइव में स्लाइड रहेगी हाँ हाँ ठीक है आप इसमें डाल वही तो डाल रहा हूँ इन्हीं की पेन ड्राइव में डाल रहा हूँ कहाँ है पेन ड्राइव तुम्हारे खुली कहाँ इट्स नॉट ओपनिंग Friends, so sorry for that. When we talk about musculoskeletal tuberculosis, I mean, there are a lot number of bones in the body, lot number of joints in the body, and the clinical presentations of each segment and each bone and each joint is a little different. So, and that poses diagnostic challenge and evaluation challenge. So what I'm doing is that since it involves bone, joint, spine, muscular lesion, a combined lesions, so what I'm doing is that I'm since 50% constitute spinal tuberculosis, and whatever is true for spinal tuberculosis, I'll keeping that as a base information to discuss, to put my views. Now here, besides disease diagnosis and drug treatment, there is a mechanical damage to the limb or to the spine. And besides the disease, we have to treat the mechanical damage as well. And that is why when we come in terms of outcome, we have to find out, evaluate disease outcome as far as the healing of lesion is concerned, and then we have to look after the mechanical consideration, mechanical damage to the segment of spine or segment of the bone as well. Now, spinal tuberculosis has a recorded history as old as human civilization. It has been observed in Egyptian mummies, and the diagnosis was ascertained from the lesions in the mummies by genomic studies. Thus, there is a significant change in the treatment have taken place from 1950 onward till 2023, and it's still further we are moving it. So, we'll discuss spinal tuberculosis in terms of what is our presumptive case to suspect, what imaging to do, how to arrive at tissue diagnosis, treatment offered, surgical treatment if any, and treatment of sequelae. So the issues are diagnosis, clinico-radiological and imaging or MRI, how to ascertain that diagnosis. There are some atypical presentations in the disease, and is the biopsy mandatory for all cases? What is the ATT protocol and when to stop ATT? And that is a big challenge in the musculoskeletal tuberculosis. If you suspect a drug resistance, then when to suspect drug resistance and how to ascertain, how to prove drug resistance and how to treat them. There are surgical indications, options, regional diseases, different segment of spine. In children, it's not as the disease of the adult. It is altogether a different disease in children. And heel deformity issues if the patients develop paraplegia with a heel lesion. So the most common complication in active diseases are neurological complication, be it maybe an active disease or a heel disease. A spinal deformity is a bigger challenge. Persistent abscess on the continuing on the treatment as Ankita discussed that, and failure to show healing response. So there are various complications which we encountered. Now these two cases, they present with persistent localized pain for 6 weeks, and they had a constitutional symptom. And if on X-rays one gets these subtle changes, not much findings, except little straightening of spine, then to our mind, we take them as a presumptive case. And we take them for an MRI immediately, because MRI is considered nowadays a gold standard to assess, to diagnose a lesion in inflammatory stage of the disease. So that becomes our presumptive case with a persistent localized pain because we are endemic zone. So 6 weeks or more with persistent localized pain, it's an indication we should suspect and we should put these patients for evaluation. Now, if we miss at that point of time, then they start getting some pain in the segment of spine, and which you or which we clinician may get some tenderness in some segment of spine, as in this case in mid-dorsal spine, and maybe slight prominence of some of the spinal processes, and that is what we call as knuckle deformity. But at this time, neural deficit has not come. And we may see on X-rays this kind of a classical X-ray finding with the regional osteoporosis, obliteration of disc spaces, loss of anterior bony height. Now these, in an endemic zone, these are radiological signs to make a diagnosis of tuberculosis of spine. However, these findings can be there in any granulomatous disease, and that is why we are not sure about it, and hence MRI is mandatory. we must do MRI also, because the MRI findings, contiguous vertebral body involvement, intact disc spaces, low signal in T1 which turns bright in T2, prevertebral collections, low signal in T1, bright in T2, intraosseous destruction, abscess, and epidural involvement. We considered these findings as diagnostic of a spinal tuberculosis lesion. And as in this patient, even this stage was missed, so patient started getting exaggeration of reflexes, and that is what this lesion, and patient had, besides all local finding, had a reflex exaggerated. So some neural signs have started coming up, and then MRI again ascertained almost the similar finding, contiguous vertebral body involvement, relative preservation of disc spaces, prevertebral collection which is low signal T1, bright in T2, prevertebral collections which is septated, intraosseous destruction, and epidural involvement. So we are more or less sure that we are dealing with a case of TB spine, and I think these findings, almost in 90% instances, we are able to make a confident diagnosis of TB spine to treating. And since these diagnoses were described by us 10 years ago, in this classical example, contiguous vertebral body involvement, preservation of disc height, prevertebral collection, T1, bright in T2, septate paravertebral collections, intraosseous abscesses, and epidural involvement, we are able to make diagnosis confidently in 90% instances. Well, this is one example I can show you. Similar X-ray finding, similar clinical presentation, and could see the MRI finding. It is sure, but then at that time, as a part of study, we did CT-guided biopsy, and that ascertains on CBNAT and culture. So that is how these observations now is more or less, we are very consistent about diagnosing TB spine. However, if someone has this patient, 20-year male, diffuse back pain, constitutional symptom present, weight loss 15 kg in 3 months, no neural deficit. And look at this MR picture. MR picture shows this body involved with intervening normal. And there is a heterogeneous signal. It's not classical, those 7 findings which I just described. Then it means it is not suggested. It may be tuberculosis, but it could be many more things, like it could be lymphoma, myelomas. They all present in a similar MR picture. And that is why we label this MRI finding as diagnostic dilemma or diagnostic uncertainty. Biopsy must be done to ascertain the diagnosis by all means. There is no place for empiric treatment. Now, this is another patient, a 6-month symptomatology and tender lumbosacral junction, and you could see this X-rays and CT scan or MRI just shows a subtle lesion in the S1. Now, no way one can diagnose clinico-imaging this patient. You have to take a tissue to ascertain the diagnosis of tuberculosis. So, biopsy, CT-guided biopsy or an open biopsy or a debridement becomes an important tool in our armamentarium to make a confident diagnosis. And that is why the bigger second challenge is ascertaining a diagnosis of TB spine, but it must be ascertained at all cost, confidently. So whenever we do a biopsy, whether open, percutaneous, whatever way, tissue must be submitted for all, AFP smear, TB culture, molecular test, CBNAT, LPA, or histopathology and cytology, whatever is possible. Because sensitivity of each test in a paucibacillary bone sample is variable. It is not 100%. However, in tandem, this percentage improves. I think my message to all, that tissue, giving a reasonable tissue to a laboratory is the responsibility of a treating person. They must divide the tissue in good amount to all segments, and the tissue must be, and this tissue must be without a preservative, should be immediately transferred to the lab and should not lie onto the shelf of your outpatient or shelf of your operation theater, because in this hot weather, the yield will be further low. However, if for some reason you are not able to transport the sample immediately, we recommend that it should be put in the refrigerator between 2 to 6 degrees for maximum 7 days. But once you have taken the trouble of taking the tissue out, you must ensure that tissue reaches the laboratory in optimum volume and in optimum conditions. Now, as I said, the diagnostic accuracy for tuberculosis by various methods is variable. Best of the tuberculosis culture, 30 to 50%. Best of the lab, 50%. Low standard lab, 30%. Molecular, 90%. AFB smear, 10 to 30%. And histological, 60% for sure, because granuloma is seen, and remaining 35 is suggestive, because you see some cells, some epithelioid cells or something, with which in matching with your clinical and imaging finding, you make the diagnosis tuberculosis. But even the histology is not 100%, it is 95%. And one could see how low these indicators are. So we have to ascertain the diagnosis in almost all cases. Well, when we were framing index TB guidelines, at that time there was no data available for molecular testing. So we took an operational research on molecular testing. But by putting all these simultaneously, diagnosis will be ascertained if it is done in tandem in 100% instances. And these were the 3 studies. I think I fully concur with Professor Behra that it is pity that all medical colleges, they do not have best of microbiological lab for the tuberculosis. And I think we had to do lot of efforts to get it done from LRS or National Institute of Tuberculosis to conduct these studies. So in this 176 consecutive cases, diagnosis was ascertained in 100% instances. 1 study is already published, 2 studies, they are in different stages of review. Now, there are situations when tissue is less. Then we recommend that it should be chosen to give it for histology and CBNet. Even that can ascertain diagnosis of tuberculosis in 100% instances, as has been observed in 99 sample of these 2 studies. So friend, the bottom line is musculoskeletal or spinal tuberculosis diagnostic has to be ascertained, whether by confident imaging observation or a tissue diagnosis, so that we treat it well, treat it early in an inflammatory stage before a deformity or neural complication develop, because these 2 have a very bigger consequence as far as the patient life is concerned. Now, when we start treatment, the core treatment is a drug treatment. Surgery is for specified indication. Now, you have started ATT, how to follow these patients. What we believe is that in immediate post-op, it is the pre-treatment X-rays, and 6 weeks after ATT. It is the responding case, and you could see the density has improved and the border has become sharpened. So this is a very early response of a good treatment only on X-rays. No other investigation. It is wrong to get an MRI to evaluate the lesion in 6 weeks, 8 weeks, and for 6 months. Because MRI are inflammation, it is going to show more severe imaging signs than the... So X-ray, plain X-ray is the best modality in immediate post-treatment, whether the lesion is showing a response or not a response. Now, when to stop ATT is still a big question for spinal surgeons and orthopedic surgeons for a spinal lesions or a peripheral lesion. I think we did 2 studies in that also, that in one of them we took by MRI-based observation. And what we found, that 60% achieved healed status, MR-based healed status at 12 months and 19% at 18 months. So we concluded that it is unscientific to stop ATT by fixed time schedule of 8 months, 10 months, 12 months. We have to see that lesion has attained the healed status. Well, then we took PET scan also in another study, and what we found, yes, PET scan is able to show us some of those patients which MRI shows only contrast enhancement. In that case, PET scan was very useful to show us that healed status has been achieved or not. But then again, it also concluded the same thing, that it gave a variable duration of healed status. Now, so what we generally try to follow, although there is no sound evidence as yet. And probably this is one area where therapeutic drug monitoring has to be studied. So what we do is that if we are treating on a culture-sensitive report, we can consider stopping at fixed regimen, provided there is no abscess. However, when you are treating without culture, ensure lesion has attained healed status on contrast MRI or PET scan. And this is the example I'm going to put forward. I just show this X-ray as a diagnostic MRI findings. And here it was treated by CT-guided biopsy. After CT-guided biopsy, which was ascertained sensitivity for rifampicin and INH on line probe and CB0. And after 15 months of ATT, one could see this lesion has little improved, but patient was symptomatic, local area was tender. So we got in contrast MRI, and one could see here enhanced intraosseous abscesses. So these are enhancing intraosseous abscesses. We again did a CT-guided biopsy, and that shows an active granuloma. So in spite of culture sensitivity report, we treated this patient. So this question still bothers musculoskeletal surgeons, that when to stop ATT. This question is still needs an operational research. Now surgery, when to do surgery? We operate on some specified indication, be it maybe a neurological deficit, paraplegia or quadriplegia, or when patient doesn't show response and we suspect a drug resistance, or there are large abscesses producing complications, or multifocal diseases which are diagnostic dilemma, intraspinal diseases, that is granulomatous lesion presenting as a paraplegia, but there is no gross vertebral lesion. Kyphotic deformity, a patient has already a deformity, and that consideration we do operate. Junctional area and late onset disease or recurrence of disease, which I'll be just talking in few of the examples. So for neural deficit, either we decompress the spinal cord, or we, besides decompression, we do instrumented stabilization. I think there are various situations where we do one or other. But we are very keen to know whether spine is unstable, that is instability is there. In that case, we ensure that instrumented stabilization is to be done. And I think that you can understand by this example. This patient reported to us with developing paraplegia on ATT. And this is the kyphotic deformities. Now, he was carrying this X-rays. And if you look at this X-ray shows there is an eccentric height loss on this segment. So there is some scoliosis, and we could see that we are not able to see this pedicle shadow. And here on a lateral view, this proximal spine is translating on the distal spine. So this is primarily an unstable disease where body as well as the posterior complex, that is facets, they are also diseased. So the mechanical forces are going to add the paraplegia and increase in the kyphotic deformity, as happened here. And look at this MRI, which patient, this is again June. Patient was carrying this MRI, and here you could see that this all abscesses, anterior disease, besides the facet destruction. So probably this is the cause. At initial instance, it was missed, and that is why the surgery changed from decompression to instrumented stabilization as well. So both the things were done. So that is how we decide whether we are decompressing it or we are just doing a instrumented stabilization. And this is the granuloma was removed lying over the spinal cord. Now, there are various situations sometimes. One could see such a long segment disease. And here, there is a patient has a paraplegia, compression onto the spinal cord. So we have to take a call that only decompression may not work, but we may have to stabilize the spine as well. And that is what is being done. Or these are again an atypical situation. Two lesions in the same spine, neural deficit, paraplegia matching here. So now we need to decompress both. We need to stabilize the whole segment of spine. So that is how surgical strategy changes case by case. Now, when patients reports with deformity. Now here you see 1 deformity, 2 deformity, and 3 deformity. These are deformity where these patients were treated 20 years ago. These are healed deformity, and they are living with it. Now, these are the one which are active disease, and they are reported with the deformity. So we do not want that they should live the whole life like this. So here the deformity correction consideration will come besides the disease treatment in the surgeon's mind. And that is because we know deformity correction are easier and safer with less complication in active disease, not in hair. Here it is a very big challenge and a very grave risk of developing complete paraplegia after surgery. So here it is easier and simpler. And these are various studies been done in last 10-15 years. Which deformity should we correct? Should we correct 5-degree deformity? Should we correct 30-degree deformity? How this deformity is going to behave if we do not treat by surgery? While this 15-degree is going to end up 25-degree, or 50-degree is going to end up 80-degree. So these all kind of studies, they have given us an idea that how should we plan to correct spinal deformity. And I'll give you one example. Lumbosacral lesion reported 6 months after ATT. And you could see such a severe kyphotic deformity at lumbosacral. So we put the patient on traction and it opened a bit. And then we took it for surgical correction to correct this kyphotic deformity from here to here. So that is kind of planning comes in our mind besides the care of disease. This is what another example. Now, junctional disease, occipitocervical, cervicodorsal lesion, lumbosacral lesion, are they the same lesion or as the mid-dorsal spine or mid-lumbar spine? No, they are almost different altogether, a different cup of tea. This 7-year-old child, C1, C2 disease, one could see on MRI, treated with ATT, become painless in about 3 months or 4 months' time. And there is no signs, no local tenderness, but when we take the patient's X-ray in flexion extension, we could document that C1 and C2 are unstable. It is moving with the flexion, and then surgery will come that we need to add fusion to C1 and C2 so that spine becomes stable. Similarly, this cervicodorsal junction, and you can imagine that this kyphosis will enter into thoracic kyphosis. How difficult is this? We cannot leave this deformity like this, because this, with the continuous loading, this will further increase. So in all cases, we have to correct it. And now, while we need to correct it, our consideration would be, could we do it from the neck, or do we have to cut the thorax? So that kind of a evaluation is to be done. And here we did from the neck itself, just from an incision in the neck, while here we had to cut the manubrium sterni as well. So that is how our consideration besides the disease changes case to case. Now, as Ankita said, persistent abscess or presentation of a psoas abscess. This L3-4 disease, taken 12 months ATT at periphery. Patient was persistently low back pain and pain and swelling right lower abdomen. When reported, now this X-ray, this MRI patient was carrying shows a huge abscess in the psoas at that time itself. And now when we reported to us, we got a contrast MRI and we showed that there is an enhancement of this abscess. So it's a huge psoas abscess. So we need to intervene for this abscess, and that is what has been done. And one could see here, this thick pus is a sign of an active disease. If it's a sterile abscess, they become watery. So this is an active disease, so it has to go into all those kind of investigation protocol, what we do it for a suspected drug resistance cases, and then treat accordingly. Another one, again 6 months later, came with this abscess. We aspirated, CB0, rifampicin sensitive, culture, all sensitive organism. So what we did a repeated aspiration of the abscess till the sauce stops collecting. And
excuse me, sir. Please sum up.
oh yes, I'll take 2 minutes, just not more than that. So this persistent abscess is a big challenge for orthopedic surgeon, because we all do not know, because this has completed 12 months regimen, but there is a continued enhancement of the abscess. So that is still an unanswered question. Now the bigger question is, you start ATT here, and at 9 months, one could see that one more vertebral body is destroyed. So it means the drugs are not responding. We need to suspect, and then we define the definition of what is a presumptive, a suspective drug resistance case in spinal TB. In that case, our concern is if our diagnosis is not correct, are we dealing with any other granulomatous disease? So we need to ascertain diagnosis. If diagnosis is right, whether it is drug resistance or paradoxical reaction. Generally, paradoxical reactions, they come early phase of the treatment. So our line of action remains debridement of the lesion, submitting it for all investigation so that we are able to ascertain the diagnosis. Now, even after submitting all, we get from the presumptive drug resistance cases, we get two types of outcome. Proven drug resistance, one can treat accordingly. But there are always some cases with, in spite of best efforts, in spite of best laboratories, we have not been able to prove the drug resistance, so they are treated with a clinical drug resistance, as a clinical drug resistance, because histology positive for granulomatous tubercular disease, but then we are not able to demonstrate drug resistance. Now, new dimension has come, a primary drug resistance, as in these two last study which we did with a national LRS or National Institute of Tuberculosis, we did find that in 52 cases, 13 patients has some one or other drug resistance. So I think this question still needs to be looked into it. Now, as I said, TB spine in children is not the same as in adult, because these bone, they disappears, melts, because they are cartilage. So the deformity appears faster and severe deformity. And you could see here, when this reported, in 3 months' time,
Excuse me, sir,
this patient has...
Short of time, please wind up quickly. Yeah? Please.
Okay, I'm just moving on to... So friends, I have tried to talk about diagnosis in an inflammatory stage, that is what we do it, to advanced stage with complication, rationalization of drug therapy alone, and indication of surgery, how we monitor on ATT, what are the treatment of these complications, deformity and paraplegia, what are the special situations, TBS in children, drug resistance, junctional area, and that is how we treat these patients, and these are our consideration besides the treatment of disease per se, that is tuberculosis, which drug, for how long. Thank you very much indeed, and happy to answer any question.
So, sir.
As I said, I think I made it very clear that generally in my practice, generally I am happy with the classical science on MRI, and I start ATT. And if those are not there, in that case, we have to take a tissue and biopsy. So generally, if you take 100 cases, almost 15 to 20% cases will require a biopsy.
If we start ATT, is it wrong medico-legally?
No, it is absolutely not wrong.
Okay, thank you.
So we thank Professor Anil Jain to bring out the aspects about the musculoskeletal tuberculosis. It's almost different from the other type of tuberculosis like pulmonary or abdominal tuberculosis. And in those cases, we have a certain guidelines when to stop anti-tuber treatment. But in musculoskeletal tuberculosis, as shown by Professor Anil Jain, we have to you can say we have to individualize the treatment of each patient suffering from musculoskeletal tuberculosis, not by fixed like 6 months or 8 months. This is if I think the audience gets a message that it's not a fixed drug protocol, the fixed duration protocol. It depends. Treatment has to be individualized, and especially I want to, because it has already been highlighted. Most of the musculoskeletal tuberculosis are not being reported, and now it has been mandated that we have to, again, like pulmonary and abdominal tuberculosis, we have to, you can say, get them reported for our national programs. Thank you.
I would like to invite Dr. Deepak Jain to present a token of gratitude to Dr. Anil Jain.
There is a one change in a schedule. Now we have one session on DSTB shorter regime by Dr. Rohit Sareen. So I request Dr. Sareen sir to start his lecture.
Sir, pointer. The slide is not coming on the screen.
Well, very good afternoon to all of you, and at the outset, I'd like to congratulate Dhruv on organizing this particular program exclusively on tuberculosis. So congratulations, Dhruv, to you and your team. And you see, Dhruv has been very closely associated with the TB program and also with this disease. And he is really bringing out certain issues which at times, the program may overlook because of his clinician, I would say his clinical expertise. So, respected chairs and the audience, my topic primarily is going to be something which is the newer thinking. And can we really talk of a shorter treatment than what we already have? What we today call short course chemotherapy is still really not short. 6 months, I think the experience from our champions very clearly stated that yes, it was a journey of ordeal. They got all the support, but yes, it was difficult. With antibiotic era, you see most of the infectious diseases really are managed within days. Some may take a few weeks, but that is it, you see. And tuberculosis really is an outlier. Dr. Behra very clearly traced the journey of this particular illness, and we started with a treatment of 18 months, and Dr. Jain also said that even today we are working in that direction as far as certain types of TB is concerned. Then we shortened it to a year, and any treatment less than 1 year, we said it is short course chemotherapy. I mean, that was really the thought, because the earlier treatments were 1 year plus, so they said anything less than a year will be short course. But is it really short? That is the question. I mean, it's maybe short as per definition, but for the patient it is definitely not short. And you see, even when we are patients for some common infections, even taking antibiotics for a week's time becomes a task, right? And because of that, there are loss to follow-ups. Because of that, there are treatment failures. Patients will stop treatment in between, land on to relapses, and maybe drug resistance. So this is really, I would say, the outcome of this, so to say, short course chemotherapy. When we think of shortening this, we really have to look towards the treatment strengths. And that actually implies that, well, the treatment should be such that we should bring about an early conversion. That means transmission risk should reduce. We should have a treatment which cures the disease at the end of treatment. It should lead to lesser deaths in the patients, fewer adverse reactions. The treatment should be acceptable to the patient. It is not that, you see, as a doctor, we'll say that, okay, you take treatment this treatment, patient continues to say, I am having pain here, my hair are falling, I am having a lot of vomiting, but you say, no, you continue treatment. So that is really not the approach. We have to give something which is acceptable to the patient also. And of course, last but not the least, this treatment should have a sustained action. There is no point in giving a treatment and after 6 months you have another relapse. After a year you develop drug resistance. So we'll have to think of something, a treatment option wherein there are no relapses or at least minimal relapses. So many efforts have been made, with this particular thought. Researchers have gone into different treatment options, different regimens, and question has always been, is it possible really? Well, I would say that because there is a concept wherein in TB we have something that, okay, the sputum converts, and it converts pretty early in the treatment. And then we were taught, and we continue to teach, that the longer duration is actually not for that particular illness or that particular disease at that point of time, but the longer duration is to protect this individual from relapses, which may happen, may not also happen. So that gives a thinking that, okay, can we have a stratified approach? Can we have a situation that for most of my patients, I give this shorter treatment of a few weeks, and I identify that group which has a greater probability of relapse, and then give them the usual 6-month treatment that we talk of, which is the standard of care currently. Or the alternative approach is, can I use the newer drugs? Dr. Behra listed a lot of newer drugs. Can I use these drugs to give to all my patients and shorten the treatment duration from 6 months to maybe a couple of weeks? So, that is the current thinking which is going on amongst the TB experts globally. Well, sad to say that most of the earlier trials did not prove that this shortening of treatment would be useful. Even the Cochrane review as late as 2019 suggested that present evidence does not support the use of shortened ATT regimens in adults with newly diagnosed drug-sensitive pulmonary TB. Whether it was the Remox trial, whether it was the Oflotube, Rifaquin, all these, they contained a different combination of drugs, but none of them really proved that we could shorten the treatment, So essentially, you see, when the quinolones came up, we thought we got a miracle drug. People said, oh, you convert so fast. Like today we talk of, bedaquiline, that isme to jadoo wali dawai hai, ye to ekdam theek ho jata hai. So like that, they thought the quinolone has come. And then the thinking started. I remember Soumya Swaminathan, she'd come to us, we were discussing, and then she said, no, Dr. Sareen, I think I have got a conversion so rapid that we can support a shorter treatment. I said, okay, let's see, go ahead. So ICMR did that trial. The trial was, showing some progress. But then the larger trial, which is the Remox trial, did not show much of a benefit, And the moxifloxacin containing regimens, they showed that, okay, in terms of deaths, in terms of treatment failures, probably the regimens that use moxifloxacin for 4 months, were non-inferior to the standard 6-month therapy. But the relapse rates were very high. They were unacceptable. And the same was true with the gatifloxacin containing regimens. So the forest plot, very clearly illustrates this, that the relapse outcome, the relative risk of relapse is 3 times higher with a moxifloxacin 4-month regimen as compared to the standard treatment of 6 months. And the same was true for gatifloxacin. The risk was about 2 times higher. So the conclusion was that yes, no difference in cure, That means it is not inferior to the standard regimen in terms of cure or the adverse events, but higher relapse rates, and hence it was not recommended. Recent studies are more promising, Recent studies, we have a number of studies here, trials, and now WHO recommendations have also come up based on these trials. And first of these trials I'd like to mention here, this is the TBTC study 31, in which you see the hypothesis was that if we give a more potent regimen with an improved rifamycin, what is that improved rifamycin? It is rifampicin. So they said that if in a regimen we contain rifampicin, probably we can reduce the risk of these relapses and all that, So let's try that particular regimen and show that this 4-month regimen is non-inferior. So this was a randomized open label trial. The control arm was the 6-month arm and the intervention arm was 4 months. They divided the intervention also into two. One which contained only rifampicin and other which contained rifampicin plus moxifloxacin. Because you see, moxifloxacin had proven its efficacy as an anti-TB drug, very well established by that time. So they said that, okay, in one we will just give rifampicin, the other we'll give the two. And the primary efficacy outcome was TB-free survival at the end of the year after randomization, and of course the safety was also to be addressed. So results were very encouraging, that the arm which contained both rifampicin and moxifloxacin was non-inferior. So that was something which was remarkable. It was a huge sample size, as you've seen, over 2,500 individuals were taken in. It was multicentric, different parts of the world, and they showed the similar thing. The arm which contained only rifampicin, of course, was not really good enough, and hence, you see, the recommendation from this, the study concluded that yes, it is non-inferior in terms of efficacy, safety, and premature discontinuation when we give rifampicin and moxifloxacin, and then this is the basis of the WHO recommendation in 2022. However, it's a conditional recommendation, and they said there's a moderate certainty of evidence at that point of time, because this was probably, though it was a very large study, but it was the only study which had shown this at that point of time. It's a new recommendation. And why it is conditional? Because it can be used. When they did the subgroup analysis, they said that, okay, in this particular subgroup, we have certain persons and we don't have others. Therefore, we cannot say that this particular regimen will be useful even for others, because we don't have that evidence right now. Where it can be used was people living with HIV, people having diabetes, extensive pulmonary disease, not extrapulmonary disease, right? Then they found that it could not be used in children less than 12 years because that was not the enrollment criteria. Could not be used in extrapulmonary TB. Sir, not for the musculoskeletal TB also, we can't go for this shorter regimen of 4 months. And in case the CD4 count is less than 100 cells, it could not be used. Then for pregnancy, breastfeeding, postpartum women, also it is not recommended. So this is the conditions under which it could be recommended. But then the issue is that, okay, now we have a regimen for, well, adults. Simultaneously, researchers were working on regimens for children. We have Professor Kabra here, a known pediatrician from AIIMS, Delhi. And I think he would be very familiar with this, the SHINE trial which is there. We've discussed it very often, Kabra, in our national technical guideline groups, and we are still groping whether to adopt, whether not to adopt this. And here they said that if the child had, you see, minimal disease, that is, they call non-severe disease, it could be treated with 4-month therapy, same drugs, but just given for 4 months and not for 6 months. And of course, the efficacy outcome was whether it is unfavorable status, which is a composite of treatment failure, loss to follow-up, and death by 72 weeks. as compared to the standard of care, which is the 6-month therapy. Conclusions was that, well, the 4-month of anti-TB treatment was non-inferior to the 6-month, and hence in children with drug-susceptible, non-severe, smear-negative TB. Children, by and large, you see, we are not able to demonstrate bacteria in most cases, but in some we do. So for those, this will not be applicable. But yes, it would be applicable to those who are smear-negative. And what is this non-severe? What exactly do we mean by non-severe? Well, if only a peripheral node is involved, cervical lymphadenopathy is very common. Even if there is mediastinal lymphadenopathy, one could give it, one would consider it, provided it is not causing any airway obstruction. Then pleural effusion was also declared as non-severe, and non-cavitatory disease confined to one lobe of the lung. This was the criteria which was used. Ethambutol they did use in children here, wherein you see, because it was a multicentric trial, India also participated in that trial, and we have a high prevalence of H resistance, so therefore E was used. So I would say that this particular now SHINE trial, that gave the basis for WHO's second recommendation. Here, of course, the recommendation was very strong, with a moderate certainty of evidence. And they said that yes, in non-severe cases for children, one could give treatment only for 4 months. Believe me that there are countries in the world who have adopted this, and they are going ahead as national program. We in India are still working on it, right? And then came, you see, this newer thinking strategy. And what is that strategy? That strategy is that, well, we may not give longer treatment to all. We give shorter treatment. And then let's see what happens. That's called the truncate TB strategy. And we at our institute were fortunate to be part of this. We're the only site in India who did this trial. And the aim was to see that if giving treatment for this shorter treatment that we talk of, which was really 8 weeks of treatment, that is just 2 months of treatment, give treatment only for 2 months, follow up the patient. If a patient relapses, give the standard of care. But it could be used only for drug-sensitive TB. So there were, we divided it into 5 groups of drugs. In certain groups, the dose of rifampicin, as far as the drug combinations, was on the higher side. In certain arms, we added additional drug, linezolid, which is one of the newer repurposed drugs. In certain, we added clofazimine. Then we added, in another arm, group D, we added rifampicin along with linezolid and levo. And the last arm, we did not give rifampicin. We said that, okay, let's do it without rifampicin, because rifampicin resistance is also an issue. Sometimes we are not able to ascertain yes or no, and we replaced it with bedaquiline. The trial is completed, the results are out, and they are published also. They are published in the New England Journal of Medicine. It came up just this year. So, in a way, I would say that when any article is published in a journal of this standard, it shows it has some standing, it has some meaning. It gives rise to newer researches, and that is what is happening now. So, the results showed that of all the 5 different treatment options which I have suggested, probably the last one, the bedaquiline linezolid containing arm, that met the non-inferiority of primary outcome. And you see, the mean treatment duration even in that context was slightly more, because here you see one aspect of the strategy was that if at the end of 2 months we found that patient is not really clinically as well as we want the patient to be, we could extend it by another month. But that was all. We could not go beyond 3 months, right? Otherwise, we would have had to declare a treatment failure and shift on to the standard of care. So, apparently, strategy is feasible, it's effective and safe, and could be the strategy for the future. This is what, as authors, I will say, we are suggesting and thinking of. Then this is another trial, RIFA short clinical trial. This is also recently, in October, we got this particular conclusion of that trial. It was presented in the Union conference. But it had just, you see, the dose of rifampicin here was on the higher side, 1200 milligram in one arm and 1800 in the other. It did not show any non-inferiority to the control. So this again is a failed regimen, I would put it. So to conclude, I will just say, friends, that shorter treatment regimens for drug-sensitive pulmonary TB are also a reality. You know, we have always been talking of shortening treatment in drug-resistant TB, but here for drug-sensitive TB also, it's a reality. You could work towards shortening the treatment. There are different treatment regimens, and now with the newer drugs, we could still explore further. And there are different treatment strategies, like the truncate TB strategy, right? Thank you so much for your hearing. If there is any question.
Thank you, Sarin sir. Actually, as you shown in truncate TB trial, sir, the dose of rifampicin, I think that is 35 milligram per kg. But generally, we don't use that much of high dose. So what is your take on this?
Okay. You see, first of all, high dose rifampicin, in terms of safety, there was another research which has been done, it's published also now, that the dosage at which we are giving rifampicin is really an underdosage. And that study showed us that we should really give maybe double that dose. That means 20 milligram per kg rather than 10 milligram per kg. Okay? In that study, NITRD was part of that study also. We did it with the usual 10 milligram, then 25, and then 35. And then there were some ADRs, so we reduced it slightly. So 25 became 20. And then, you see, we conducted the study. Of course, in terms of its efficacy, nothing happened. But in terms of ADRs, we found that these higher doses, we did not get the ADRs, even with this 25 milligrams. So here we use 35 with the thought that maybe it makes the regimen more potent. That was the idea. Because we were giving it only for 8 weeks, thought was maybe higher dose makes it more potent. And that is the basis even for the RIFA short regimen that I talked of, you know, wherein they gave even still higher. 1800 milligram of rifampicin. So you can imagine, right? So I hope I have been able to clarify your doubt. Right.
Thank you, sir, for your elaborative talk. Because of paucity, we may have a question and answer session in the lunch. And we move on to...
Sir, उसने बड़ी देर से हाथ खड़ा किया हुआ था. We can permit his last question, sir. Sir, please, बोलें, sir.
But in somehow we cannot give rifampicin, like Stevens-Johnson syndrome, hemolysis. Here, what you give, rifampicin is out.
ऐसा नहीं है सर. देखिए बात ये है कि what the idea of this presentation? Idea is कि just to stimulate thought. कि देखिए ये चीज़ पॉसिबल है. तभी आप देखोगे मैंने कंक्लूजन में यही चीज़ डाली है कि भाई इट कुड बी अ रियलिटी. पहले हम सोचते थे कि 6 months से कम नहीं कर सकते हैं.
No, I'm talking about 6 months only at present, which we are giving. Patient develops Stevens-Johnson syndrome. After 15 days, he develops severe hemolysis. One of my patients developed 1 gram of
Okay,
hemoglobin.
so you are now talking of a situation wherein individual is not able to tolerate rifampicin.
Yeah.
What treatment should we give? That is your question.
That's my question.
Okay, it is not, of course, related to my presentation.
Manchanda sir, we can discuss, you can discuss with sir in lunch time.
We can.
आप लोग तो बोल रहे थे, तो 1 मिनट हमें बोलने दो.
नहीं नहीं ठीक है, तो इसमें सिर्फ यही है जी कि we have to give a regimen which does not contain rifampicin, so we will treat it as a RR resistant case and give the treatment accordingly. Currently there is no treatment regimen which is a standard treatment regimen less than 1 year without rifampicin. Okay,
Then
so
can we start the MDR treatment here?
well, without rifampicin, if you have to give, the program is recommending a 1-year treatment, SHE, 2 SHE followed by HE. That's a time-tested old treatment that the program is recommending.
So can I
But
start
yes,
MDR?
you could think of starting the 9-month shorter regimen without rifampicin that we have for TB.
Thank you, sir.
Wait, Dhruv, this is a very novel idea. I like to. और इतनी जल्दी तुम पता नहीं कैसे कर लेते हो, but you take advantage of technology.
So we will move on to our next topic, that is CNS tuberculosis. And our presenter is Dr. Manish Modi. And he is a professor in neurology in PGIMR, Chandigarh. And Dr. Modi has interest in tropical neurology, that is CNS, this tuberculosis and neurocystic sarcosis. And he has various affiliation and various membership in his, and he has more than 200 publications in his account. So I welcome Dr. Manish Modi to please, sir, since we are running short of time, please stick on.
I'll try to.
Thank you.
So thank you, Dr. Dhruv, and thank you, Professor Sareen, for these stimulations which I received. Probably I'll cut short some of my talk and probably focus on the stimulation which Dr. Sareen has given. So everybody is exhausted. I'm sure everybody knows who I'm showing. This is Dr. Robert Cox. 150 years down the lane, still we are fighting with a bug which was discovered 150 years back. And the fight will continue. And it will not be 2025, it may be 2035. But I don't think that we'll be able to win ever this bug. So I divided my talk into various forms of CNS tuberculosis, the leptomeningitis, tuberculoma, cerebritis, encephalitis, myelitis, and the complications. But I'll be focusing on some of the challenges which we as clinicians are facing in our day-to-day practice. So looking at this MRI, I think most of us can diagnose tuberculous meningitis from a distance. Very easy. There are basal exudates which are classically taught in histopathology, in medicine, in MD medicine, and in DM neurology. But then, why did it develop? Why so much of thick exudates and so much of severe disease? Why? Because we wasted a lot of time diagnosing these patients. Look at the picture. Very good classical book picture of TBM, but very bad for the patient. He's losing his eyes, he's developing infarcts, he's bedbound for the rest of his life. Why? Because we diagnosed him late. Another patient, he has some pictures suggestive of tuberculosis, but the diagnosis is late. Another patient, again basal exudates with encasement of the blood vessel, producing cerebral infarcts, again producing a severe disease. So showing you the classical TBM picture, a book picture, will not suffice the purpose of this talk today. So it is probably more thought-provoking why we reached this stage. Look at the degree of exudates this patient had at the time of presentation. And then on autopsy, we find that there were thick exudates which had to be cut with a saw. What is the idea of diagnosing these patients? We are already losing these patients, right? This is another beautiful example of a right third nerve palsy in a patient with tuberculous meningitis, diagnosed in early stages. Easy to diagnose and easy to treat if we are vigilant about it. Another patient, again, death is written on his MRI, a very severe case of CNS tuberculosis with thick exudates and all the complications we could see. And we could see the thick exudates and tuberculomas at the base of the brain. So the problem of tuberculous meningitis is that, one, it's the most serious form of tuberculosis. Death is almost imminent if the diagnosis is delayed. And the complications have, they are life-threatening. They produce a lot of morbidity and morbidity. That is why I'm here, to discuss not all these complications. But if we understand, what is the mortality of stage 3 tuberculous meningitis? We have 3 stages. I'll come to that. It is more than 40%. And some series says close to 80%. So that is the kind of, severe disease which we in tertiary care institutes commonly see, and which probably could have been diagnosed much earlier at the first point of contact, when the patient actually reached a stage when he reached PGH Chandigarh and was almost in a comatose state. So that is why this lecture is for diagnosing tuberculous meningitis much earlier. So this is the stage. When stage 1, it's a mild disease with no focal signs. The index of suspicion has to be very, very high to diagnose these patients. Then comes the second stage, where still, it is manageable. You have altered sensorium, but the patient is not comatose. We have moderate deficits which can improve. But when it comes to stage 3, the patient is having a very severe disease with hydrocephalus, exudates, lot of infarcts, and things like that, and completely paraplegic, where the outcome in terms of mortality as well as morbidity, both are really poor. So this is the kind of mortality we are talking about in stage 3. In the prognosis and mortality, of course, for me, the most important remains the delay in the diagnosis. That probably is the single most common factor for the fatality in patients of tuberculous meningitis. Of course, the immune response in some subgroup of patients do produce complications. The virulence of organism like MDR tuberculosis, the HIV co-infection, all these definitely contribute to the mortality. But for me, the most common single cause for high fatality and mortality in TBM is the delay in diagnosis. Why delay in the diagnosis? This is what our paper also told. The patients who were having very stage 3 disease, hydrocephalus, exudates, longer duration of illness, altered sensorium, they definitely had a higher mortality compared to a patient who is coming early and not diagnosed in time. So the problem areas in CNS tuberculosis, to my mind, is that early diagnosis remains a challenge. Probably we are not that sensitized to, thinking of it early, proving it in time, and starting the ATT with the earliest suspicion. Then, as Sir has told, the duration of ATT for pulmonary tuberculosis is 6 months, but when it comes to CNS tuberculosis, it is 1 year or even more. That is as per the national guidelines. So the compliance always remains a challenge because of the duration of treatment and the toxicity of the drugs thereof. Then in CNS, we have these challenges of, because it's a closed compartment, persisting and paradoxically worsening lesions. So then comes the role of the high dose of steroids and some other immunomodulator drugs when you are sure that you are not dealing with MDR tuberculosis and you are dealing with the immune-mediated responses in a closed environment of CNS tuberculosis. So for me, the most important challenge means how to diagnose TBM early. If we look at how do we diagnose TBM, how do we suspect TBM? So it is mainly the clinical criteria. What clinical criteria? Fever of, some say 5 days duration, some say 7 days duration. But in our setup, if I say it is more than 2 weeks duration fever which is persisting with headaches and patient is going into altered sensorium, probably that is the time to actually suspect. Any patient with fever and headaches merit the suspicion of tuberculosis rather than most of the time being labeled as enteric encephalopathy. Given quinolones, as sir has said, they are beautiful drugs, but they suppress your tuberculosis. So don't just empirically treat based on as typhoid treaters and make the disease too advanced that it leads to a lot of morbidity and mortality. That is what we commonly see. A duration of 2 months, 3 months, 4 months, going to different places, always labeled as enteric fever, and then they finally succumb to this illness, this deadly illness. So the clinical criteria is simple: fever, headache, vomitings, altered sensorium. There had been always a focus of infection elsewhere in the body. If your suspicion is high, your decision is taking time, try to find out evidence of tuberculosis elsewhere. In our study, close to 95% of CNS tuberculosis had extracranial tuberculosis lurking somewhere in the body, which was possibly the source of infection in the CNS. So one has to, first the index of suspicion has to be high, your threshold for CSF analysis has to be low, and your aggressive approach to find out extracranial site of active tuberculosis should be very aggressive, right? We should, of course, try to look for alternative diagnosis. Cryptococcosis, as you all know, especially in HIV setting, is a great mimicker. It mimics TBM like anything, and it has to be ruled out, of course, in any suspected CNS tuberculosis patient. Right. So this is how we make the diagnosis. The probable tuberculous meningitis by a combination of clinical features of fever, headache, vomiting, neck stiffness, altered sensorium, seizures, focal neurological deficits, CSF with the cells of more than 20, lymphocytic pleocytosis, proteins raised, sugars low, and a negative gram stain, India ink, and VDRL wherever required. This was relevant way back in 1994, but probably cryptococcosis remains a common differentials. Then CECT showing exudates, as I already discussed, signs of active extraneural tuberculosis. Of course, clinical response to ATT always is a good pointer, but because we start steroids and we get the effects immediately within 5 or 6 days in the form of clinical improvement. So for me, that probably is not the point in favor of diagnosing tuberculous meningitis. Of course, we know the sensitivity, it's a paucibacillary disease. The sensitivity of smear examination is almost 0. The culture takes 4 to 8 weeks. Of course, MGITs has reduced that burden, but it is positive in only 1/3 of patients. Not of any good. Of course, it is important. And then ADA was used earlier, should not be quoted, and it is not used nowadays because of its false positivity. And the PCR when it came earlier, so I'm quoting previous paper, the PCR when it was, earlier came into picture, the sensitivity was close to 90%, but in various series, what we have seen that the sensitivity of Gene Expert or Gene Expert Ultra is close to 60 to 70%. That means it is able to diagnose 60 to 70% cases of TBM, but cannot rule out 30%, in good 30% of the patients where you are having a strong clinical suspicion of tuberculous meningitis. So that's the irony of situation. So we in our institute keep on trying, newer techniques and less costly techniques, like we are trying to do LAMP analysis, which is a very simple and can be done without any sophisticated instruments and can give results within 2 hours, but it doesn't give you any idea about the rifampicin resistance. So, but for diagnosis, to prove the diagnosis of TBM, these are alternative, some of the methods which we are trying to standardize in PGH Chandigarh. But as of now, as per WHO, Gene Expert Ultra remains the point of care test to rule in, but not to rule out. Mind my words, it is to rule in, not to rule out. And that doesn't mean we should not start ATT if it is negative. So that is the common problem with the residents, and if they are here, so the index of suspicion is high, the clinical radiological picture is high, the CSF is suggested, start them on ATT, irrespective of CBNet, irrespective of any other positive investigation. That will save lives and that will save many complications. So as regards challenge 2, the most important challenge, the treatment and the regime and the duration. If I am talking of this stage 3 disease, these patients need 18 months, even 2 years of treatment. The patient with stage 1 may recover within 9 months, but we hardly come across those patients, at least in our institute. And of course, those regimes are good for stage 1 disease. So if we look at the ATT journey, as everybody had already told, it started in 1944, then 52, parazinamide 54, ethambutol 61, and the combination therapy used to be 18 months, which we are still following even in 2023. But after the advent of rifampicin in 1963, and with the addition in parazinamide, the pulmonary people could manage to cure their patients within 6 months, but that is not true in CNS tuberculosis. And unfortunate part is that there is not even a single large multicentric randomized controlled trial in tuberculous meningitis which can actually tell you the duration of treatment. That's the unfortunate part of it. And if taking the lead from Dr. Sareen's lecture, time is high, that probably we need more aggressive approach in treating rather than, laying arms to CNS tuberculosis by giving 18 months regime and facing all the complications. Maybe it is time now that probably newer drug regimes with linezolid, with bedaquiline, with ethionamide, and with the quinolones, maybe we are able to kill these bacilli faster in the first 2 months when the disease is most aggressive and leads to the maximum mortality, and probably will be able to reduce the duration of treatment also with lesser complications. So let us see how the international community wakes up to these calls by the pulmonary specialists who have used all these regimes with all their ethical clearances in shortening the duration of pulmonary tuberculosis. I understand it is not a public health problem. It's not a contagious disease. And it's just 1% of the total disease burden. Hence, it always gets a stepmotherly treatment. But I think looking at the gravity of situation, the high mortality, and the burden which we are seeing in India, probably it is high time that we need really, good trials for TBM-specific complications to, improve the morbidity as well as mortality in this deadly disease. Now I will skip a couple of my slides. So we all know all these 4 drugs. Some people prefer streptomycin, some people prefer ethambutol. Here in CNS tuberculosis, because there is a strong optochiasmatic or basal exudates, which always compromise the vision. So we are on the side of giving streptomycin in the first 2 months rather than ethambutol. And probably somebody must have discussed about the complications of or ethambutol toxicity, which we are now encountering with increasing the duration of ethambutol to over 6 months or 9 months in the continuation phase in managing tuberculosis in general. And for tuberculous meningitis, I have to give ethambutol for 1 year. I'm bound to get lot of optic neuritis and optic neuropathies because of ethambutol toxicity. So we prefer to use rifampicin and isoniazid if it is a lighter disease, and parazinamide if it is a severe disease. So I just wanted from the audience which has got the best CNS penetrability. You will be astonished to know the first line, the primary drug, the rifampicin is not that efficacious. It's just 10 to 20% which goes to CNS. It's mainly the INH or pyrazinamide, close to 100% of the CNS bioavailability. And same is true for even quinolones also, close to 60 to 75%. So that is the kind of drugs actually we need. So that is why I'm saying there is no randomized controlled trial to, actually tell us about the efficacy of the standard pulmonary specialist-driven regimes which have been extrapolated to CNS tuberculosis, and the duration has been increased empirically. And how empirically? Where are the guidelines? Not adequately addressed. The CDC says give it for 6 months, WHO say give it for 9 months, UK say give it for 12 months, American Academy say give it for 9 to 12 months. And what does the standard care for TB in India says? The duration can be extended from 3 to 6 months depending upon the physician's, discretion for the neurological involvement and tuberculosis. So the intensive phase as per the index TB guidelines remains 2 months of RHZE, and in the continuation phase is RHE, which many of the neurologists all across India are strongly against because of the long-term problems faced by ethambutol, but there is no published papers or scientific data, so I am not refuting it. I'm just, as Sir has said, I'm just enlightening you, I'm just telling you the problems which we as neurologists, which you as physicians are going to face when you are going to treat these complicated cases of tuberculous meningitis. And the duration is not just stopping at 12 months. If you see, you get an MRI, the patients of stage 3, which I have shown you, they are bound to have that disease lurking in their CNS because we have got drugs which have got a poor penetration and which are ineffective or less effective, and they are in a protected CNS environment, and hence the desired results are not, we are not getting the desired results. So this is just a thought provocation. I'm not against the national regime. We are thankful that at least it has been made daily regime, but there are problems, and there needs to be some groups which have to come together to, actually define some newer regimes to treat this deadly disease. I think so there had been only 1 or 2 regimes. One was with moxifloxacin and high dose of rifampicin IV, when they found that they had a lesser mortality and better outcome. But the same in a larger trial could not prove it to be that effective. So the use of quinolones had always been a question mark in the treatment of tuberculous meningitis, though many people love to give it, but then it has its own problems. We in PGI had found that in our latest series, close to 20% of the CSF samples which we could isolate, close to 20% had levofloxacin and moxifloxacin resistance, which is very high, possibly because of the overuse or abuse of quinolones.
Dr. Modi, please sum up.
I'm summing up. So I'm not talking about the MDR tuberculosis. There is a full session, and every day, I won't say every day, every few months we are getting very good new oral and injectable regimes. So we will not be discussing too much about the second line treatment. The only other problems which I wanted to show and discuss with you was the persistence of disease in the form of new lesions or increase in size of lesions, especially in CNS tuberculosis, tuberculomas. It's a big topic in itself. So my point here to just emphasize you is that if a patient on ATT has increase in size of lesion, that doesn't mean it is MDR tuberculosis, and that doesn't lower your threshold to start second line ATT. This may be a paradoxical response, and these patients don't need a change of ATT, they need more of immunomodulation. So maybe a high dose of steroids, at times even methylprednisolone, and we in PGI are using an immunomodulator called thalidomide, and then there are certain centers which are using infliximab in these patients. So the threshold to label a patient of MDR in a patient with paradoxical tuberculosis should be low, should be high, and it is better to treat with immunomodulation. That is another point I wanted to emphasize for CNS tuberculosis. The other are the problems of extensive arachnoiditis or optochiasmatic arachnoiditis. Like in this patient, we started therapy, and after 3 months, we are seeing there are a lot of exudates and optic neuropathy. So despite on ATT and despite on steroids, so some people may, go towards second line therapy. The answer actually remains that this is a paradoxical response and we need immunomodulation. So we gave him high dose steroids along with, I will not say thalidomide is the drug of choice, but we gave thalidomide and we could get the complete resolution of these lesions, right? So the key messages are that there is no gold standard of diagnosis as yet. Still, we are still looking at 60 or 70% of rule and diagnostic tests. Still, we cannot rule out in every patient. And the guidelines are important even in the best evidence, as we have already seen. No answer for what and how long. Prolonged treatment is always preferable, especially in a disease like CNS tuberculosis, which can be highly fatal. And early diagnosis, initiation of ATT and compliance are the key to good outcome. And probably I would say in stage 1 or stage 2, 2 months of intensive therapy and 10 months of, as we are using pyrazimide, may be probably an adequate regime, but it may extend up to 18 months. And it is always better to, go for culture sensitivity and a gene expert ultra to at least find out the RIF resistance or MDR tuberculosis. And more data is actually needed for poor responders. And most important is that usually we stop steroids very early. If we are getting a patient with stage 2 or stage 3, then 2 to 3 months of steroids are indicated, and it should not be just stopped in 2 weeks. Even in stage 1, it is indicated for at least 6 weeks and slowly tapered off. That's the take-home message from my side. So we can end TB, but probably that needs a lot of time, and probably 2025 is not our target. We have to improve our drug regimes and our diagnostic armamentarium to reach this goal. Thank you very much for your kind attention.
Slide.
There was one more session on lymph node tuberculosis, but the speaker could not join us because of some health issues. So that won't be covered now. So with that, we complete the session and hand over the mic to the dais to the organizers. Thank you.
TV Rohtak, no, sorry.
Our next session for the event is Challenges in Tuberculosis. And for this session, I would like to invite Dr. Prem Prakash Gupta, Senior Professor of Respiratory Medicine, PGIMS Rohtak, as the moderator of the session. Please give a huge round of applause for him. Chairperson, Dr. Kundan Mittal, Senior Professor Pediatrics, PGIMS Rohtak. Dr. Ajay Mahajan, President of Indian Medical Association, Haryana. Dr. Pawan Goyal, President of Association of Pulmonologists of India. Dr. Rajesh Gupta, Professor of Department of Respiratory Medicine, PGIMS Rohtak.
Good afternoon to all respected delegates and my senior faculty. This is a very important session. Every day we are treating tuberculosis and facing various challenges from day-to-day life. And I know this is a very difficult time of the day. All of you are waiting for the lunch, but we will be having a very nice session this thing. We would like to keep on the time, please. So, my co-chairperson.
Please.
Firstly, I would like to invite Dr. Sushil Kabra for Please give a big round of applause for him.
Respected chairpersons and friends, in next 18 or 19 minutes, I'll take you through the pediatric tuberculosis. What are the challenges in diagnosis and management? Most of our guidelines are similar to that of any adult patient. I'll try to highlight what are the difference in the pediatric patients. So one is important aspect is sampling, other is treatment regime doses, and then when to suspect drug-resistant tuberculosis. So I'll try to explain it by one of the case, like this 6-year-old girl, fever, cough, weight loss for 3 months, and TST or MAN2 test is 22 millimeter, gene expert positive on gastric aspirate, rifampicin resistant not detected, and diagnosis was made and started on the treatment. On the other side, this 8-year-old boy who presented with fever, cough, gaining weight 4 weeks, no contact with TB patient, TST is 12 millimeter, gastric aspirate is negative, and he was given antibiotics for 7 days. There was no change in the X-ray, which was showing a non-specific infiltrates, and diagnosis of pulmonary TB was made and treatment was started. So these are the two representative cases of pulmonary TB, how we make in the childhood. So one was microbiologically confirmed and another was probable based on the radiology and clinical features. So the question arises, reasons for not able to have a microbiologically confirmed TB in the second case, and we send samples. So a resident may say that my consultant asked me to send the sample and I send it in the morning, gastric aspirate, but I hardly find any positive case by a gene expert. So then the other person may ask that if diagnosis of TB is based on a clinical radiology in children more than 50%, then what is the need for sending samples for all? So questions are valid. Answers are that TB, pediatric TB is a possibacillary, as you had seen in the musculoskeletal as well as CNS tuberculosis, though the sensitivity of all these tests are lesser. Results of lab tests will depend on type of TB, as I'll be showing you in the next, that if only a hilar node, a consolidation or a cavity, and how samples were collected, whether we have taken a pains to collect appropriate sample and sending it for appropriate diagnosis. So proper sampling will improve the yield and we are able to identify DRTB in the first beginning itself. That's why it is useful that we should try to send the samples for each and every case. Then what can we do? So one is sampling. Say I ask a resident to do a gastric aspirate, he puts a tube, he takes out some sample. Most of the time he'll say I was not able to get this appropriate sample, and then that's it. And then we make a diagnosis by a clinical radiological. So it is important that we understand and do the gastric aspirate properly. If we are not able to get a sample of 10 milliliter, then put the child in a lateral position, try the other measures, take the gastric aspirate as well as, if less than 10 milliliter, then put a 10 milliliter saline and collect it back and send it to the laboratory. Then other methods are that you do a bronchoscopy if it is available. Then you can find on the spot that there is a cageation in the bronchus and you make a diagnosis. You can take a sample if take from the bronchoscopic brush and then take a sample and send it for the microbiological test. And even in adult patients, IBUS is being done routinely, but even it can be done in children or EUS even as young as 1.5 or 2 years of age. So important thing here is that we should try to do sampling as much as possible, try to document AFB, and it is possible that we may be able to identify many more cases who are microbiologically confirmed. So this is a study carried out almost a decade ago, and this is just to say that if you do an appropriate gastric aspirate, even on an ambulatory basis, it is not required to be kept in the hospital. Then you may find that smear is positive in 10.4% in the pulmonary TB who are ambulatory. But it increases significantly to 33% yield if you send a MGIT culture. So it is important that we send a culture, because even in the national program guideline, it is suggested that you do a culture for all precious sample, and in pediatric patients, all samples are precious, whether it is a gastric aspirate or induced sputum. So you can see that if it is just a simple lymph node, primary pulmonary complex, you can identify in 18%, but if it is a consolidation cavity or miliary TB, it may go up to 42%. So it is important that we do sampling in all appropriately and use your currently available molecular diagnostic test. And if you use a molecular diagnostic test, how much is the, in how many you may be able to confirm the diagnosis. So from our studies, it is suggested that if you take 100 children with a pulmonary TB, you may be able to identify 34 in the first go when you have done a gene expert or CB-NAT. When you do, this is negative in the beginning, if you do a bronchoscopic lavage with the pretest probability of probable tuberculosis very high, then another 35 patients may be added and the total, it becomes 69. And if you have only a lymph node and you can do a lymph node sampling, provided that you have the facility, then you can increase it to 75. So it becomes almost similar to that of an adult, provided that you are using all the methods and all the technology available as of now. So as of now, how to go about the diagnosis of TB in children? So one is that if persistent unremitting fever, unremitting cough for more than 2 weeks, weight loss of 5% or no weight gain, and there is a contact of tuberculosis patient, upfront go for a X-ray chest. So this is a major shift in the diagnostic workup of pediatric tuberculosis, specifically pulmonary, that you are going for a X-ray in the beginning itself. If X-ray is suggestive, that is indicated by a lymph node cavity or fibrocavitary tuberculosis, send the sample, NAT, whatever is available, and if it is positive, microbiologically confirmed, it may be rifampicin sensitive, it may be rifampicin resistant, and start the treatment. But if it is negative and X-ray is highly suggestive, then again, as I had shown you, try all your methods and technology to document that yes, it may be tuberculosis. If it comes positive, then you are able to start the treatment. But if it is negative and alternative diagnosis is removed, or it is unlikely, in that case you are making a diagnosis of probable tuberculosis. So I would also urge all the physicians also that instead of saying empirical anti-TB drug, it is your probable diagnosis rather than empirical TB. Because that will put a lot of pressure on you that you have ruled out other causes, and it is not something like I'll start on anti-TB drug and let us see whether he responds. So we should remove this thing from the TB, this thing nomenclature, that there is an empirical treatment for anti-TB drugs. So this 2-year-old girl presented with low-grade fever, not gaining weight for 2 months, X-ray consolidation, hilar adenopathy suggestive of TB, TST is positive, mother was diagnosed as tuberculosis, diagnosed as a pulmonary TB, and pediatrician referred the child to the DOT center to start appropriate regime. Mother directly went to DOT center. She was asked to come on Monday morning because it was already 4 o'clock. And DOT center was closed. On Monday morning, she was asked to get all her papers, Aadhaar card, generation of NIC required for a NICSHA ID. She was not aware about the Aadhaar card, and father had gone for work. So family was confused and not sure what to do. Father took leave from the job. So he has lost the 1-day salary. And he went to the OPD. And then OPD suggested that you come on Saturday because your day is Saturday. So family took the child to the nearby practitioner, which is RMP, started on treatment, and family was very happy that, of course, at least lastly, the treatment has been started and continued to follow up with the RMP. So what is my responsibility as a physician? NTP document is very comprehensive, but we should realize our own responsibility. The physician, NTP, suggests that do a screening for all family members once you have made a diagnosis. So mother was diagnosed 4 months ago, and at that time it was the responsibility, or it is the responsibility of all the physicians to screen the family, identify if there is active tuberculosis, start on treatment, identify that if there is no active TB, start them on a TPT, that is a prophylaxis. And as Dr. Behra has already said in the morning, that this is one of the important mainstay of our program, that if you can identify, you can reduce the pool of your TB infection or LTB. Pediatricians, he should be making a diagnosis of writing all these things that it is a TB, probable, confirmed. Then what, instead of mentioning only regime, that what medications are to be given as per the program. And then we need to treat them aggressively. So another important thing which has come is that there is an upward revision of anti-TB drugs doses, specifically in pediatric patients. So this is based on many pharmacokinetic studies. This study was done almost a few years ago at AIMS, and it shows that if INH is given in doses of 5 milligram per kilo, none of the 41 patients had a adequate normal serum level of more than 2 microgram at 2 hours. Rifampicin, again, majority. Pyrazinamide, of course, because it was slightly higher doses, so they were achieving normal dose, levels MIC. And in Ethambutol, again, it was the same thing. So now the doses has been revised upward, and that is 10 milligram isoniazid, rifampicin 15 milligram, ethambutol 20, and pyrazinamide 35. So it should be known. And so there is only a single regime, that is 2 months of intensive phase, followed by 4 months of continuation phase with 3 drugs. And in osteoarticular and CNS, it is 12 months. Majority of our day-to-day clinical practice, we should be sticking to that guideline that we should be giving it for the suggested duration, because it has been decided after a lot of discussion, not empirically increasing or decreasing the duration, though there is a need for decreasing the duration. And we should be aware that what are the drug combinations, FDC, and how much it should be given. If we are not able to remember, if you are treating children, keep this with, on your table, and that is like in the next talk, STW, that provides us that how to treat these patients. This is, we should be aware about newer regime which has been suggested, and Dr. Sareen also suggested, SIGN TB trial. That suggests that you give only for 4 months, 2 months of intensive phase followed by 2 months of maintenance phase. And because of challenges in the diagnosis and mimickers, it has been decided by the NTEP that for time being we are not adopting it, but this is a good direction that there is a possibility that we can reduce the duration, and which is always welcome. Similarly, for the CNS TB, WHO suggests that you can give a 6 months of anti-TB drug, that is isoniazid, rifampicin, pyrazinamide, and ethionamide, 6 months. But again, because of other reasons, and we need to have more data before we say that we can start 6 months of CNS TB treatment. So, but there is a direction that yes, we may be able to have it over a period of time. So another thing which is very important to know is that there is a significant sequelae of the tuberculosis which needs to be monitored while we are treating them. And there will be a full lecture by Dr. Anant Mohan on the sequelae. But I'll show you a child who was treated but responded, but at the end of therapy, there is a complete collapse of the lung, and microscopy, bronchoscopy suggests that this is a critical narrowing, and it may require some treatment. And if it is left, then there may be a lung damage or complete destruction of the lung. So these should be identified on time. When to suspect drug-resistant tuberculosis? Once you have given the treatment, because microbiology is very difficult to prove in our country. So in children specifically. So if there is a history of treatment in last 6 to 12 months, close contact with MDR TB patient, close contact with the person died of TB, failed TB treatment to non-adherent to ATT, failure to improve clinically after first line anti-TB drug, after 4 weeks if there is no improvement, think of drug-resistant tuberculosis, and no extension of intensive phase. And use molecular diagnostic test. Very important thing is, consider if there is a patient in a household with a positive pulmonary TB, investigate all household members, whether it is a pediatrician or whether it is a physician, identify those who are having active tuberculosis, treat them, those who are not having active tuberculosis, start them on a TPT. That is isoniazid, 6 months of isoniazid for prophylaxis, so that we can reduce the pool of your LTBI or TB infection. So to summarize, childhood TB, try to document AFB by microbiology method, molecular methods, by gastric aspirate, induced sputum, bronchial lavage, by using a CB NAT. And drug doses have already been revised. Regimes are same as that of an adult, and we are worried that you are giving a ethambutol for extended period of time. Be careful that you monitor them. Formulations are dispersible. Monitoring should be child-specific, and pediatric formulation, we should be aware that what is the combination and how many doses, how many FDCs are to be given. If there is a history of treatment within fast 6 to 12 months, close contact with MDR TB patient, close contact with person died of TB, failed TB treatment or non-adherent, consider a child may be having a drug-resistant tuberculosis. And if there is a failure to improve clinically in 1 month, consider that it may be a drug-resistant tuberculosis. And again, I re-emphasize that this is our moral responsibility to contribute towards elimination of TB from our country, that whenever I am making a diagnosis of tuberculosis, screen all the family members. If active tuberculosis, treat them. And if it is not active, then give them a TPT. Thank you very much.
Role of drug monitoring for tuberculosis?
As it has been discussed and it is desirable, I generally say that if we are doing a drug monitoring for refractory seizure, why not to do it with the tuberculosis? So there is a need for development of, one is that we document it by doing a culture, MGIT, for all cases of tuberculosis. If you do it for the UTI, then why not to do for a tuberculosis also? And second thing is, if it is a failing, can we do a therapeutic drug monitoring?
Thank you. Thank you, sir. So, Dr. Kavra, please stay. Well,
अनंत मोहन ना
Thank you, sir. Continuing with the next talk of the session, post-tubercular lung disease. I invite respected Dr. Anand Mohan, sir, Senior Professor, Pulmonary Disorders and Sleep Disorders Department, AIIMS, Delhi.
now check on okay.
Sir is the stalwart of the respiratory medicine. We have been so many, we have learned so much from sir, and he has been source of inspiration to learn more and more. Please, Dr. Mohan, sir.
Thank you very much, dear chairpersons, and thank you, Dr. Dhruv, Dr. Pavan, and the entire team for having me here. Since morning, we have heard some excellent deliberations regarding the diagnosis and management of various aspects of TB, pulmonary and extrapulmonary. And rightly so, the focus has been on the diagnosis and management of active TB, which is obviously the case when we want to fulfill our goals, national goals. Having said that, at the same time, we must also realize that now we'll be seeing, and we are seeing, and probably we shall be seeing more and more post-TB complications also. And these include, and I'll be talking about the pulmonary complications. So we should be aware of the various post-TB sequelae, post-TB pulmonary complications, and how to deal with them also, because we'll see more often than not, they are wrongly labeled as relapsed TB or not responders of tuberculosis. They are treated again and again with ATT. Again, that is not the correct approach. So we should know that there is a wide spectrum now of post-TB lung diseases, and that we'll see in the next 12 to 15 minutes. Basically, I'll just be going over it with the help of some case examples, and all of these are basically just, for example, this patient, the case A, again sputum positive, drug sensitive tuberculosis, responded to therapy, he was declared cured. After 6 months, he came with exertional dyspnea for 4 months, some dry cough, no fever or loss of appetite, and that was relieved with the symptoms got better with nebulization. Another patient on the right side, again a similar type of patient who was also sputum positive drug sensitive TB, responded to therapy. After 1 year came with cough and dyspnea, low grade fever, some loss of appetite as well. But on initial examination and investigation, there was no evidence of active TB. And he was also actually started empirically on ATT, as a presumptive therapy, but there was no response. So we'll see later what these all may turn out to be. Another third case, another young lady who had pulmonary tuberculosis. Again, she was treated with sputum positive TB. The symptoms were relieved with ATT, became sputum negative, and later came with again exertional dyspnea, nebulization giving some minimal symptomatic relief, spirometry and X-ray are here. We'll come back to that later as well. Why to talk of post-TB sequelae now? Why is it necessary? Because again, like I said, rightly so, the focus is on identifying and treating active TB disease. But we know now that there is a high burden of residual morbidity and mortality amongst tuberculosis survivors, even after apparently completing the full course successfully. And even in high-income countries, the observed mortality rates of tuberculosis survivors has been found to be many-fold higher as compared to those of the general population. So that means there is something going on even after so-called successful completion of anti-tubercular therapy. And if we look at the research, we find that when a large screening is done of databases including PubMed and Embase, out of more than 200 guidelines, more than 3,000 articles, after screening it was found that only 3 international TB guidelines actually mentioned TB sequelae. None of them really described properly how to identify or define these conditions. So now that those experts also, they recommended that one should actually try to find out the burden of post-tubercular lung disease. This should be included and they should be recognized and they should be discussed more at various forums. And this is what actually happens in TB. If we liken TB to a house on fire and ATT to the water dousing it, then what is remaining over here is the post-TB sequelae, the charred remains. So many times this happens despite therapy. TB does leave quite a bit of substantial damage after that. And generally, just to see pictorially what are the various aspects of TB which can be, which can lead to physiological disturbances. It can be either obstructive or restrictive in the lung. And again, on obstructive, as you can see, it may be either mostly because of inflammation, may lead to airway narrowing, and a various, all spectrum of disorders may be there, leading right from pulmonary cavitation, endobronchial or bronchogenic spread, or bronchiectasis, that is destruction of the airways. All of them leading to decrease in the pulmonary functions here. On the other hand, excessive fibrosis may occur, leading to restriction. There is stiffening of the lung parenchyma, fibrosis, bronchovascular distortion, pleural thickening, all of this leading to a generalized kind of fibrotic or a trapped kind of a lung. There is some data from India as well, and this from the Rajan Babu and the Patel Chest Institute, in which they looked at more than 400 new cases of pulmonary, pleural or mediastinal TB, out of which after successful therapy completion, they found that radiological resolution was there in only around 59 to 60% of the cases. Almost all the others had some or the other residual lesions. These included parenchymal, pleural and mediastinal in different proportions. When they dissected and did sub-analysis, they found that out of the sputum positive cases, there was a much higher proportion which had the residual lesions as compared to the sputum negative cases. But even the sputum negative cases, as you can see, around 28% had some residual radiological lesions, thereby showing that pulmonary TB does have more residual lesions compared to the EPTB. This just tells us that just treating TB may not be the end of the story in every case per se. This shows generally the various type of post-TB disorders that may happen after successful treatment also, involving almost every compartment of the thoracic cavity, from the airways, parenchyma, the vessels, the mediastinum and the pleura. Almost every type of disorder may be involved and almost every type of disease may occur somewhere down the line because of tuberculosis in some way or the other. And we will see some of them. For example, tracheobronchial stenosis, bronchiectasis is very, very common. So is obstructive airway disease. Here we know all the restrictive problems, the aspergillomas we are well aware. In the mediastinum, there may be persistent lymphadenopathy. Fibrosing mediastinitis also very rarely recognized, but a very, very morbid kind of a condition for which there is no real therapy available at this point of time. And we have actually lost a couple of patients because of this, because there is nothing really we could do. And then a host of pleural problems that all of you are aware: empyema, fibrothorax, pneumothorax, thickened pleura, and bronchopleural fistulas. Let us recall the case A, the first one, who after successful treatment being declared cured had exertional dyspnea, which was relieved by nebulization, and the PFT you can see over here is showing a typical obstructive defect, as you can see the scalloping and the scooping. And in the X-ray also you can see there is some evidence of hyperinflation, there are some fibrotic bands, but at the same time you can see there is a lot of emphysematous changes also inside. So how do we label this condition? Do we call it as a COPD? It is not the patient is not a smoker, mind you. Do we call it as a tuberculosis associated obstructive pulmonary disease or a post-TB chronic lung disorder? So we know that TB and COPD also have some things in common. You know, there is a kind of a comorbid condition. The history of TB increases the odds of COPD again by as much as 3 times. There are some shared risk factors between the two, which may be smoking, exposure to biomass fuel smoke, diabetes, and malnutrition. These are some common risk factors for both of them. So there is definitely some kind of, liaison, or one predisposes to the other. Also, if we see the spectrum of spirometric abnormalities after tuberculosis, here we can see out of 500 cases unselected after at least receiving 5 months of therapy and microbiologically declared cured. When spirometry was done, you can see that only around 1/4 were actually fully normal. In around 40% they had obstructive disease. Among the obstructive disease, around 20% actually had severe obstruction. Among those with restrictive disease, almost 27% had severe restriction. So this just shows that just doing a spirometry can identify many cases having significant abnormalities on spirometry even after being declared microbiologically cured. So what are the diagnostic criteria for TOPD, that is a tuberculosis associated obstructive pulmonary disease? So far there is no definite criteria or consensus, but obviously there are some obvious features. We have to demonstrate obstruction on spirometry. History of PTB has to be there. There should not be any current active PTB. There should be no bronchodilator reversibility, and mostly the onset of symptoms should be after, say completion of ATT, within 6 months after completion of ATT, more often than not, although these are not hard and fast guidelines. And of course, we have to rule out other actual disorders like bronchial asthma, actual COPD, and other airway diseases. In this case, patient was diagnosed as TOPD, started on the standard inhaled bronchodilators, enrolled in rehab, and there was substantial improvement with this. So this was one case which was not a relapsed TB, it was an obstructive pulmonary disease after tuberculosis. Another important airway disease after TB is a post-TB bronchiectasis that all of you must be really seeing very commonly. A very common finding may occur because of bronchial stenosis, scarring, or external compression of the bronchi by nodes, thereby leading to retention of secretions, and ultimately in the long term due to causing destruction and dilatation of the airways and of the lung parenchyma. Now in this also, on the left side is an international study, on the right is the Indian one. The international study also shows that among all the cases of post-tuberculosis, when they phenotyped bronchiectasis, they found that the tuberculosis comprised the major chunk of all the bronchiectasis, as you can see the red one over here. On the right side is the Embark India one, the registry which was published a couple of years back. Here also they found that the most frequent etiology of bronchiectasis was post-tubercular at around 35%. And then there were certain other conditions as well. So again, post-tubercular bronchiectasis or TB as a cause of bronchiectasis is fairly common. Management, won't go into that in detail. It is similar to bronchiectasis in any other situation with antibiotics, airway clearance, anti-inflammatory therapy, and when there is hemoptysis, either BAE or surgery, oxygen, or lung transplant can be considered. Now let us recall our case B. This was also having recovered from tuberculosis. He had fever, constitutional symptoms, started on ATT in spite of being gene expert negative, and there was no response. And you can see the X-ray over here post the ATT initially, and this is the current one. There is significant worsening. You can see all these kind of fibrocavitary lesions, extensive fibrosis. Then the Aspergillus specific IgG was done, which turned out to be positive. And this is a CT scan of that same. You can see the multiple fibrocavitary lesions. You can see the aspergillomas and the fungal ball in multiple cavities over here. BAL was also done to rule out active TB, and that was also negative basically, but that did grow. The fungal culture again growed Aspergillus fumigatus. So this situation can be compatible with a condition chronic pulmonary aspergillosis. This is something which occurs in a pre-existing structural lung disease where Aspergillus causes a chronic infection of the parenchyma with parenchymal destruction. So CPA is further characterized into 5 or 6 different types, either a simple aspergilloma, CCPA, CFPA, just a simple Aspergillus nodule, or an invasive type of aspergillosis. So we just need to keep all these conditions in mind. We are not going to talk about them in detail right now, but just the important thing is the top one here, that we need to have a patient having symptoms for at least 3 months. It is not just on-the-spot diagnosis. He has to have persistent symptoms where other causes are ruled out. Symptoms must be constitutional: weight loss, anorexia, malaise, fatigue, etc. Respiratory symptoms must also be there and persistent. And then when we work up, we can, if we find any of these that we have just described, then we can classify as a chronic pulmonary aspergillosis.
Now, aspergilloma. In 2 minutes, sir, please.
Yeah, I'll finish off. So in a simple aspergilloma, we just know that there is nothing much to do. In CCPA, what we have is multiple cavities. In CFPA, we have much more extensive fibrotic destruction of the lung. And in invasive aspergillus, we have to demonstrate the aspergillus in a biopsy or a lavage. Treatment is by itraconazole, voriconazole, or posaconazole in the doses as have been mentioned, and we have reasonably good quality of evidence for the same. Now, the third patient that we talked about, this is the one in which this is the X-ray 2 months before presentation, and then we can see a complete whiteout lung on the right side. And the CT is also showing complete lung collapse on the right side with significant tracheal and mediastinal shift. On bronchoscopy, there was significant right main bronchus stenosis. So this is a right lung collapse with the right main bronchial stenosis following tuberculosis. Now, endobronchial stenosis is also pretty common. Now we are seeing more and more of that. The estimated incidence of endobronchial TB is also very variable, but we don't know because we don't do bronchoscopy in every pulmonary TB. So we don't know how many of them have endobronchial. But in this study, almost 20 to 21% of the patients of tuberculosis had some evidence of bronchostenosis even after treatment. The treatment would be with a balloon dilatation with the variable success rate, or we can put in a stent, or we can try various ablative modalities, try topical mitomycin or segmental resection. And this, you can see the patient improved after the balloon dilatation. This was the balloon, and there was significant improvement over here. Another complication is of an end-stage lung destruction and extensive kind of destroyed lung that we call it, and that also has to be recognized. It may lead to respiratory failure, cor pulmonale, and pulmonary hypertension. So these are some serious conditions. Last part is the pleural complications. Again, just listing them out, maybe empyema, BPF, secondary infections, empyema necessitans, which may extend through the facial planes, or a fibrothorax where there is a concentric pleural thickening with calcification. And these are a couple of images to show the same. See the extensive calcification over here, complete trapped lung, kind of organized empyema over here, and this is the empyema coming out through the chest wall. So last 2 slides. So what was the purpose of showing all of these? The purpose is that although now we know more and more post-TB lung complications, we still don't have clinical standards for their assessment, management, and rehabilitation. So now people are saying that every patient, even after having completed a TB course, should be assessed. And at least these things should be done in all the patients over a period of time. History, symptoms, chest X-ray, if possible a spirometry, saturation, and a 6-minute walk test. And maybe some quality of life questionnaires must be done in these patients just to see that they don't, progress on to end-stage fibrotic or other kind of chronic pulmonary sequelae. So I'll conclude that long-term pulmonary sequelae is being increasingly recognized now, which may include the airway, parenchyma, pleura, mediastinum, or the chest wall. Unfortunately, unrecognized chronic lung sequelae are still very commonly misdiagnosed and treated as either relapse or a drug-resistant TB, because we see patients coming with 2 or 3 full courses of ATT they have taken, because the same X-ray is shown to the different physician, they start ATT, but it is not TB, it may be something else. Hence, there is an urgent need for comprehensive recommendation and guidelines so that we are able to diagnose and manage even these post-TB chronic lung disorders instead of just treating them as recurrent TB again and again, which may again cause further delays in diagnosis. Thank you very much for a patient hearing.
Thank you, sir. I have a question, sir. Do you recommend PFT before starting treatment, after treatment, or when to follow up? What are the symptoms they should do, or when should we follow up? You said they should come with these. In the last slide, you shown that these tests should be done when they should report to you.
Yeah, so again, these are recommendations. Of course, one usually does not do a spirometry when the patient is sputum positive during the active phase, but it is only after completion when he is declared microbiologically cured or at least clinically cured and radiologically cured. After that, it would be a reasonably good idea to keep them under follow-up for at least, see, the chances of relapse are highest in the first 1 to 2 years after treatment. So for symptoms for at least 2 years, one should do a clinical follow-up. Spirometry depends upon whatever facilities are available and if the patient is symptomatic. If he is not symptomatic, one may not do it. But, you know, it all depends upon facilities and the symptoms. Thank you.
I would like to invite Dr. Ashu Grover as our next speaker, scientist of ICMR for standard treatment workflow on tuberculosis.
Ashu Grover. नेट चलेगा
इससे आगे कुछ स्लाइड्स
पॉइंटर सेंटर वाला
इसी ये तो पॉइंटर है जिसे आप पॉइंटर रखोगे ये स्लाइड आगे पीछे
Good afternoon, everyone, and it's good evening as well. I think thank you for being so late for the session, and at the last session before we break for the lunch, I assume that. As explained by the chairperson, first of all, I would like to thank the organizers, Dr. Dhruv and his team, who are here to invited me for a very important presentation, which is on the standard treatment workflows. Since morning, we had been listening that there is a various kinds of patterns for management, for diagnosis, advanced level, and at peripheral level, medical college level. So many facilities are existing at various facility level, but we need to really cater upon that what is there for us, that because tuberculosis is such a public health condition, it can be diagnosed very easily at a primary healthcare setting level. So it is not only for tuberculosis, we came up with the presentation and development of the standard treatment workflow. We all know that we had been listening that AIMS has a protocol, PGI has a protocol, international agencies have a protocol, Central TB Division also has their own methods to diagnose and treatment, and this management and diagnosis of treatment keeps changing over a period of time. Various associations have the different guidelines. So there was a need that there should be some simplified approach, some summary approach, some algorithmic kind of an approach for the management of the tuberculosis patients. And there was some international scenario also that we have so many lengthy pages, 60 pages, 200 pages guidelines. I'll be just running very quickly because of the paucity of the time, but I just need to tell them in important information that how ICMR and Ministry of Health and giving some importance for its early diagnosis. So we all know that we are a very rush of the patients at the primary healthcare setting, even at the medical college setting level also, we have huge number of patient load. So in that scenario, it becomes far more important that we have a very elucidative approach for management of not only TB but all the cases. I will take you to the goal and objectives for standard treatment workflow which have been prepared by ICMR. It started in 2018. So far we have developed around 122 standard treatment workflow in various conditions, and one of the important feature of STW is that it is an additional arm, it is a facilitatory arm to the Ayushman Bharat scheme of National Health Authority. This is the entire process. I will not go much in detail of this process because that is something which experts, Dr. Kabra and Dr. Dhruv, had been chairing the committees of these two tuberculosis workflows. This is the entire thing how we start up and we'll end up in developing the workflow. These are the books on which these STWs have been published, and this is the second volume, volume 2, which has the standard treatment workflows for the tuberculosis. If we go to the entire page workup of this volume, this shows that, yeah, this has been in a partner with the Central TB Division of Ministry of Health and Family Welfare, and these are the conditions on which we have developed. So we have taken 3 important domains. One is the pediatric tuberculosis, another is the adult extrapulmonary tuberculosis, and third is the investigation and treatment approach. This pediatric tuberculosis, we have covered 5 topics: abdominal, intrathoracic, lymph node, osteoarticular and tubercular meningitis. And adult, another 10 topics have been covered. Another 3 topics what have been covered so far is the microbiological workup. We are, giving more attention that there is a lot of emphasis on how much sample to be taken up, how these sample to be transported from primary care setting to the tertiary care setting, even from the collection points to the microbiological setting, and then what are the different drug dosages and side effects of the anti-tuberculosis drugs. Then we have the whole workflow. I will not take much in detail. I'll straight away come to my presentation back. So this is the volume 2, and this can be easily downloadable from the ICMR website. So these are the conditions on which we have developed. Now this is the entire thing. How does it look like that? One taken from the pediatric lymph node, another is the microbiological workup, and this is the adult. These are the 3 different versions of the standard treatment workflow. This one document is complete in itself. So if you see that the whole lymph node workup for the pediatric lymph node tuberculosis, how to suspect, when to suspect, what are the essential and desirable investigation we should do. These are very, very important things for a primary healthcare physician to know about it, that how easily and how quickly and in a one-pager document he can put it. So these are some of the investigation diagnostic. We tried to put the books into a one-pager document which can be easily given to the doctors treating at a primary care level, secondary, as well as at the medical college setting level also. So this is the entire thing, then how to give the treatment. It's a bullet point. It is in the form of a, app-based also, and one paragraph on the BCG vaccine and lymphadenitis has also been mentioned into this workflow. So this is how this one workflow goes on to it. And the second workflow is on the microbiological workup. As I had said, that how to transfer, what are the logistics involved, because our physicians, even the tuberculosis, those who make the slides are not aware that how much slide to make it, how much sample to be transported from. So these are some of the logistics which involved in biological or this sample collection and the transportation, rejection of sample, how it happens, guidance for those who are collecting the samples, how much amount, 3 to 5 ml for the CSF acid, pleural fluid, and these things are not known to the primary healthcare workers and even for those who are collecting the samples. Some of the procedures which could be mentioned. So overall, what I just wanted to tell to all the audience over here, because they all are experts into that, but the message should go down to the level of the primary healthcare physician that this is something which is existing and which can be helpful. I'll not open this adult tuberculosis meningitis. It has been spoken a lot, but whatever has been spoken by my experts previous to my presentation, the whole thing is mentioned into this one-pager document. And this is the experts. I would like to just show that who all have contributed into the development of the standard treatment workflows, and simultaneously I can show you the website. This is the ministry website, ICMR website, DHR website, and we have the workflows in cardiology, CTVS, and coming to the contributors in pediatric tuberculosis. These are the experts who have contributed. We have Dr. Kabra sitting over here. We have many other experts who have contributed into Dr. Amber Kumar, Dr. Goel, Dr. Matthew, Dr. Jat. So these are all the stalwarts who have worked in this area. So I will not go again in detail, but these things are downloadable. Please, I'll ask you, and this one last thing what I would like to tell, that Central TB Division has again prepared a module based on the standard treatment workflow, as such adopted it and going to percolate down for the treatment or for the training of the medical officers. So these are the other conditions on which we have prepared the standard treatment workflow. If you are interested, you can go down to that. And again, like epilepsy, depression, heavy menstrual bleeding, so these are all common conditions. So this is how it was released. So again, the key feature, it is app-based, it is one-pager, there is no legal binding, it is a guidance document, it is image-based, and they are being disseminated through these conferences so that there is more and more usage of the standard treatment workflow. Those who are sitting here, you can go to the site and you can download it into your mobile application. So this is there on the Google as well as on the iOS app-based store as well. And Parliament Standing Committee on Rajya Sabha has given a note on standard treatment workflow. It needs to be practiced, disseminated among the medical officers as much as possible and get a feedback on it. You can, scan the QR code and it is available on your mobile app. We are again doing the webinars. We have the one webinar with Dr. Kabra and other experts, and these are available on our website. You can go to these webinars, listen to it for 1 hour duration. You will come to know that how these workflows are going to be benefited, and this is how it will be available. So far, you see that as the number of the STWs are more number of downloads are there. So after this meeting, I think the number of downloads in pediatric tuberculosis and other related pulmonary tuberculosis will go definitely high. And there are not only India, we are getting the download hits from other countries as well, because this is something very, very unique to guidance document that, nowhere we have the one-pager, single simplified approach for management and guidance document for the doctors. It is only for the doctors because there are some drugs, side effects, and all those things have been mentioned into it. So I have been very running to it. Thank you so much.
Thank you, Dr. Grover, for a very, very rapid race through that how the guidelines are transferred into treatment at the basic level, and you have made it technology based so that everyone can use it. I just wanted to know that how do you ensure that it is used only by the doctors?
No, so far it is available on the website, right? So anybody can go and see to it. One last thing, last week we met the Additional Secretary and Mission Director NHM. She said that we are making it ensure that it is available on the Sashakt portal for training of the medical officers. So we are starting the training of 35,000 doctors across the country, and then it will be locked that only the doctors can view those, STWs. So we are partnering with the National Health Mission, National Health Authority, and a E section of the ministry as well.
Thank you, ma'am. This shows that how much of an effort goes for from the guidelines and bringing the treatment to you. Thank you, ma'am.
See, I just want to make a comment. I think Dr. Kabra did a pediatrics along with Dr. Virendra Singh, sir. And these are the copies which we have got it done. You can have a look at it, but it was expensive in terms of color. So we didn't have that much of a budget. One copy we have done it. And in this, how much investigation, how to take sample, everything is there. So probably if we put it in our own working places, depending upon the specialities, plus the one which are actually the general purpose use, I think it is not only pediatrics. Like I was sharing the exceptional along with Dr. Ashutosh, which was a great help to us. And trust me, if you see it, sir, one of the maximum downloaded actually is around 70,000 is in EPTB. And it's not an easy thing. So that's why we requested Dr. Ashu, who is one of our own, who is a graduate of this college and has been looking after STW formation in the ICMR. Sir, I think we must have spent, Dr. Ashutosh is also around here, is around 50 to 60 hours actually sitting over, maybe more actually, I'm telling a little less.
I think maybe more because we had around 10 to 15 CTs per day, and how many days we can't count, but I think thank you, Dr. Dhruv, thank you, Dr. Kabra.
I think we need to do it. for all of us.
And it was not an easy task to fill the entire bookish knowledge into one-pager document. The entire wisdom of the experts had gone into it for development of these.
And it used to be a lot of heated exchanges in terms what to put, what are the facilities available, primary level, secondary level. So one has tried to look at the real time, how it has happened and how the evidence has been there, so that there is no delusion as far as evidence is concerned.
Before wrapping up for the lunch, we have two quick 2-minute presentations. One is on AI-based cough diagnosis for the cause of the cough, and one is by the IDDS team, which has been conducting the HISAR model, and to show that how the HISAR model has been there and how is it progressed in the diagnosis and treatment of the patient. 2 quick minutes, please. 2 minutes only.
ये डॉक्टर नेम डॉक्टर नेम एक सेकंड
Dr. Sanjeev Saini from USAID IDDS division. Please be quick. Everyone is waiting for the lunch, so please be quick.
Thank you, chairs. Thank you, everyone, acknowledging the presence of so many stalwarts here in this room and all the dignitaries here in this room. So I am Sanjeev Saini. I am the country team lead for a USAID project that we call IDDS, Infectious Disease Detection and Surveillance. This is a global project, and I am leading the country team here. This is all about the one-stop TB and resistant TB diagnostic solution model. This model is all about to demonstrate the strategic purchase of TB lab services from a NTP certified private sector laboratory for end-to-end operations. End-to-end means starting from specimen collection from the remotest area, from the mapped collection point in HISAR, which are more than 70 centers, transporting to the testing facility in Gurgaon for gene expert. And then once MTB is diagnosed in this model, then sample is transported to Mumbai for LPA and LCDST services, which are certified by the Central TB Division, and reporting the results back to the health facility and to the clinicians, even in the private sector, through Nikshay, through WhatsApp, and through email also. Without taking much time here, an intent here is to complement the existing diagnostic services in the public sector without disturbing the existing setup, so that it is there to complement the district setup. I'll skip here, won't take much time. Already we know in the program we have more than 80 state-of-the-art TB culture and DST labs equipped with WHO recommended rapid diagnostics. But in spite of that, there are a lot of challenges in maintaining those labs, building new labs. Intent was here to build versus buy. Whether we should build new labs over 80 or we should procure the services from the private sector labs. Then in consultation with Central TB Division, we State TCL Haryana, we selected the HISAR district to demonstrate an approach where we will engage this private lab and demonstrate end-to-end solutions. And at the same time, private sector labs were also certified by the Central TB Division with the same standards which are for the public sector labs. And we are grateful we have 2 labs in Haryana. One is RL Rohtak, another is Karnal. This intent was here to see the feasibility of collecting 2 samples upfront from the presumptive TB patients, testing as per the NTB diagnostic algorithm up to LCDST, starting from the either NET, Gene Expert, LPA, FLSL-LPA, and LCDST. Second was the when they can return the result within the target time frame defined by NTP. Gene Expert within 2 to 4 days, sample collection to transport. LPA defined time is 3 to 6 days. And LCDST whenever culture is positive. This model has demonstrated that Gene Expert results are reported within 24 hours for 90% of the samples starting from collection to transport, and all samples within 2 days from the collection. For Gene Expert, then sample went for LPA. LPA results were returned within 3 days and maximum 5 days. LCDST whenever culture was positive. So this is the entire flow. The samples, when collected by the health staff at the mapped health facility, which are more than 70 centers in the entire HISAR district, collected by the runners, brought into the HISAR, and then transported to Gurgaon and subsequent to the Mumbai. Isar district, all we know, this having 2 million population and then having a population of urban, semi-urban, rural populations. I'll skip the flow. This is the summary. So runners have collected the sample from the periphery and they have the game changer here who demonstrated without missing in a single day. They collected all the samples. In this model, more than 11,000 samples are tested in the last 9 months. 2,500 TB patients were diagnosed and all patients were completed the sequential testing within the target time frame defined by NTP. The results were returned back to the health facilities, and I believe Dr. Mahajan is here, who is from the private sector, who is taking care of. Dr. Vinod Goyal, Dr. Satyapal, they are here, so they can tell the entire journey of the T patient, what is the trust they have built with the patient and clinicians also. And as a clinician, sir, you are looking for the treatment as early as possible and quick treatment, accurate treatment. This model has demonstrated the same, but I believe I'll stop here without wasting much time and my next friend who will come here. So thank you very much.
Just a second, sir. As Dr. Sani was saying, I have been associated with this project from the very beginning. And their main stay has been the timely reporting of the lab reports. So today we give the sample, by the day after morning we get the report back whether the patient is positive and whether he is rifampicin resistant or sensitive. And then the first line LPA, that is also available within 3 days. And if the patient is resistant, then the second line LPA is available between 5 to 7 days. So it has been very effective. As Dr. Vera was saying, that 50% of the patients they report to the private sector and 50% to the public sector. In Haryana, I have been seeing since 2018 for the last 5 years, and always we have found that the private sector contribution has been less because of the less reporting and everything. But Hisar, I am proud to say that we have achieved a private sector percentage of about 45 to 50%. And this year with this project coming, this year it is 58% reporting from the private sector and 42 only from the public sector. So this has been the impact of this project, that the timely reports are coming, the patients are getting treated in time without wasting time. Patient is admitted with you, the next morning itself, if you call up, they give you the report. No, sir, this was a pilot project only in Hisar, and it has now finished on 31st of March. So now they are compiling the reports and going to do it. Thank you, Dr. Sani.
Thank you, sir.
Very much. May I request for the next print?
Myself, Dr. Sandeep Mishra. I am head programs for Wadhwani Institute for Artificial Intelligence. Actually, we have developed one solution for prediction of LFU and mortality, and that too we can predict these things on the first day of registration of patient itself. So I will congratulate State TB Officer Dr. Rajesh Raju over here, because Haryana is going to be the first state to implement that pilot as a whole throughout the state. Otherwise, we have done some studies in Surat in one district and Mumbai only 24 NTP units. But Haryana is going to be the first state to implement for whole state as such. So I will not speak much about it because we are just going to initiate this activity from today itself, and it will be an official launch, which we just thought because state is celebrating this World TB Day celebration over here. So I will not speak much about it. But I will congratulate the whole state, because during this, and as I'm standing over here in Medical College campus, I should say that this study is going to be a pilot study. We will see the journey of patients registered in 1 quarter, and we'll follow those patients for entire 1 year. This will be one project, and another project that it would be continued support from our side to the state of Haryana with the support of Central TB Division. Thank you.
Thank you, Dr. Dhruv. Lunch is already served. Dr. Dhruv, कितने बजे वापस आना?
जल्दी खा तो 3:30 बजे we will like to start the session. So running lunch has been there. We had opened it up, but we start the session at 3:30. Thank you, sir.
Excuse me. सर आपने खाना खा लिया? इनके नाम तो नहीं पता डॉक्टर पीपीटी में नाम होगा ना, पीपीटी में नाम नहीं लिखते, नाम नहीं लिखते।
Welcome back after the lunch session. We'll proceed with our further sessions. Next session is a debate on drug-resistant tuberculosis. All patients of MDR should receive short-term regimen. For chairing the session, I invite Padma Shri Professor Dr. Behra to the stage. I invite Dr. Anand Jaiswal from Medanta Hospital to speak for the motion.
So very good evening to all of you. So I think part of my talk has been made easy by Dr. Behra and Dr. Sareen in the sense that the newer regimens with the newer randomized controlled trials are now knocking at the doors of the various national bodies to evaluate and to take it to the program level so that they can benefit the patients. So I would request Deepak not to be as harsh as this on me. So most of the debate like this happens in news channels, so we won't be that harsh with each other. We'll just lay our facts. So Deepak, you tend to agree. You won't strike me this hard. So to start with, all my life, during my TB hospital stay, I was treating these patients with 24 months of regimen. And some of you might be remembering 9 months of injectables and then continuous dosage of ethionamide, cycloserine, parazinamide, and for months and months. And how many people know we sat and told them really that we will make you deaf or you have to die? And we made them agree to that sometimes on paper, writing that, this is okay for me if I die, if I become deaf rather than die. So that was the scenario with the older regimens. They had a lot of side effects, and we were really scared to see those reports. And I remember myself telling patients that I cannot take this patient now. I already have 15 patients who are regular visitor. I cannot help him emotionally also. So this was the scenario till we were there, and I'm very happy today to share the experiences also from those two young boys who had MDR TB and they had some solution to the drugs, but they also underwent through 18 to 20 months and they had their own suffering to say in the morning. We have now shorter courses regimen for MDR TB, and that happened with the injectable short course, and that happened with an oral short course MDR regimen. And we had a rescue. Whenever these two regimens would not help us or we are cornered, then we had an option of going now on a longer oral MDR or XDR treatment regimen. So with this, the D point has now come. There are at least 2021, 22, and 23 has been golden period, I must say, for these patients, because now we have regimens and most of the trials are enlisted in NEJM, clinical infectious disease hospitals. They were so well designed and the results are so astounding that they have seen NEJM also. And now we have at least out of 4 trials have published their results, and the 5th trial result is going to be coming soon in 2023. That is the NTB trial. And these have proved that, we can come down to 6 months beyond doubt. So this was the basis for the 9-month regimen. It emerged from the Bangladesh TB program, where they just started with the 9 months regimen, which had an injectable kanamycin and the usual drugs. And they showed us that, 24 months of treatment, which all over world and in India we were following, is not justified because they had a 89% relapse-free cure by 9 months regimen. And this was the first study which just changed our perception and made us think what we are doing and what we should have done rather than Bangladesh. So this was one program data, and then there was a randomized control trial, a well-designed. They graded the severity of the patients in terms of X-rays, in sputum positivity. They also studied weekly cultures, how fast whether the patient converts and whether it translates into the relapse-free cure. So this was the randomized, again, stream 1 study, which proved that Bangladesh study has a scientific basis in a randomized way, and they also struck to 80% cure rate. And this regimen was then all over flashed, and we started using this in our own program. Now, the only problem with this regimen was still that 4 to 6 months of injectables were causing another issue, and especially in pregnant and young children and patients who were having complications. So the idea was whether we can switch to oral regimen. So this concept was started, and in between, I would like to just point out why this bacteria is special and different, and why it is so slow and we need a longer regimen. So the basic difference lies in the DNA of this bacteria. It has a very low ribosomal messenger RNA coding in the DNA. So it does not produce, it is a very lazy, slow bacteria. It does not have that DNA and ribosomal RNA content to rapidly multiply. And therefore, we needed something new to attack. We cannot attack the cell wall. We cannot attack the DNA. It does not replicate. So people were looking at the other way around, and we were lucky that we struck at another new molecule which was looking at the energy source, that is the ATP of the bacteria, and if we can deplete ATP, that was the idea. And then there was nitric oxide, oxygen, and hydroxyl radicals. They were drugs which were producing, which would just damage anything, whether it is multiplying or not multiplying. So therein, lies the hope, and with the newer drugs like bedaquiline, delaminate, pretonemate, clofazimine, repurposed drugs, and the newer drugs came in, and they helped us in kind of shortening this period and catching this bacteria, even if it is not multiplying. So bedaquiline went through a rigorous randomized control trial where it proved that it can give you a benefit of 20% and a very fast sputum culture conversion, and therefore it was built up into the regimen. Similarly, delaminate, because of its nitric oxide radical, it also stood the test of time, and it was also being put into the regimen, and it was believed that adding of delaminate would help. Some of the trials later proved that with different regimen it did not work that well, and therefore it was enlisted later. The repurposed drug, linezolid, was again meta-analyzed, and it was found that it is a wonderful drug, and it is to be listed next only to levofloxacin and bedaquiline in its efficacy in terms of its action. Similarly, the repurposed drug of clofazimine was found because of increased oxygen and nitric oxide radical besides its action on cell membrane. And then, people all over the world sat down as to what to do with this new molecule, how to fit in, and whether they are of use in making a regimen and shortening the regimen. And this analysis went over, and the McGill group, which is the Cochrane group, collected the data of more than 10,000 patients, all those who were being treated individually in case reports, case cohort studies, or program condition, and they analyzed the data. Methodologically, method was adopted as per Cochrane method, and they said, yes, these drugs are beautiful, and their odds of success and odds of deaths favored using them. And then they did the priority grouping, and each drug, within this group was analyzed. But if a regimen had bedaquiline, what was the success rate versus a regimen which did not have bedaquiline? And this led with each one drug at one time, and then they construed this table, and this table had a basis which was done by the Cochrane meta-analysis, and they found that yes, there is a good enlisting of drug which is to their efficacy. And they thought that injection could be bypassed. So again, now there's the same group now started studying the regimens, and they divided the regimens into 4 groups. What are the longer conventional regimen, that injectable 9 months plus total 24 months, short course injectable, short course bedaquiline, and long course bedaquiline regimen. And they finally could filter out 987, 891 patient who had complete data set to finally give us the result as to which regimen would be better. So now coming to the fully oral shorter course of regimen. So this data set compared the short course bedaquiline, that is 891 patient with short course injectable. As I said, short course injectable proved itself in Bangladesh as well as the Stream 1 trial, and it was sealed that it is a gold standard for treatment of MDR for 9 months. Now, when they compared with this, they found that this short course oral, all oral bedaquiline regimen is better than the injectable 9 months, and they had a success rate of 73%, and on all front it was better. The odds favored the bedaquiline short course chemotherapy regimen. So there were certain trial limitations, and these limitations were put up that since the trial did not include these patients, whosoever used these regimens, they had excluded, so we have to exclude this before putting the patient on short course bedaquiline. The final sealing effect on the shorter bedaquiline containing regimen came from the Stream Study 2. The results were published in 2023, and they proved that, again, the success is better than the short course injectable to the tune of 12 to 13%. And not only a favorable outcome, the failures, the relapse, the discontinuation rate or the default rate was far less as compared to the injectable. Also, the side effects of hearing loss was less. So with this Stream 2 trial, the 9-month oral bedaquiline is now become the benchmark with a good randomized control trial support. So no injectable, all oral, 9 months regimen is now the standard of care. Now what to do about the group which did not match into the inclusion or exclusion criteria of the 9 months bedaquiline? So we had a fallback on longer oral regimen. And this regimen, I would say, is not an optimal regimen. It becomes an individualized treatment regimen because either the patient develops some complications or he is exclusion of some of the criteria in the primary 9 months criteria. Only those patients land up with the longer regimen plus those who have an XDR TB. So this regimen is largely a default patients for 9-month all oral. So again, the evidence. Now, if we compare this longer, 18 to 20 months all oral versus 9 months all oral short course MDR regimen. Now, again, the data set was done, and they had a longer all oral 1437, an injectable 987, and a shorter course 891 patient. And in this group also, they said the shorter all oral is as good as longer in terms of success, failures, and death, but it scored better on the default rate as compared to the longer. So with this data set analysis, the results were largely in favor of this. But again, as we say that we need a randomized control trial to say, so we eagerly look forward for the randomized control trial. The other thing which happened with the longer regimens that linezolid caused the problem, and thrombocytopenia caused the problem, the peripheral neuropathy caused the problem, and it was found that only 30% could take 18 months of treatment. So there were a lot of defaults on linezolid. And this drug, as a part of the longer regimen, was the worst tolerated by all patients. There is no randomized control trial for the longer all-oral bedaquiline regimen. So I think the shorter is the now benchmark for the treatment, and there is now hope that we can go more shorter than this. And as I said, that newer molecules like P824, which is pretinomed, there were again trials which have proved that this regimen given for 6 months in XDR patients could bring in a success rate of 97%. Not only this, the death rates were very less as compared to the other regimen which were the standard of care at that time. There were again issues with this regimen that linezolid caused a lot of side effects, and this was the next trial, and peripheral neuropathy and marrow suppression did happen. And then a second trial was done in which the dose was lowered, and they found that the success rate of 600 per milligram per day for 6 months delivers 91% cure rate without causing much of neuropathy, not single case of optic neuropathy, and not as a single case of thrombocytopenia. So these two trials proved that for XDR patients, an MDR patient who had problems with their primary treatment regimen, they can be transferred easily to this regimen, and in them, the success rate is 90%. Now, this is the Indian trial where pre-XDR and XDR patient underwent this bedaquiline, delamanid, clofazimine, linezolid for 6 to 9 months. Again, this trial showed that you can touch a figure of 90% favorable outcome. And almost all these trials which I've lessened to 6 months, the beauty of these trials is they had graded the severity. So whether the response is as good as 3+.
Since it is a debate,
right, sir.
Because your time is just take half a minute, conclude.
Right, sir. So all these trials, and right, sir. Thank you, sir. So these trials supported, and the last, I would say that the STREAM trial, which has STREAM 2 trials, which was a 9 months trial of injectable and a 6 months trial of injectable with bedaquiline, has now delivered. And I think with this, the best results have come from the STREAM stage 2 trials, in which kanamycin bedaquiline was given for 6 months, and then it proved a success of almost 90%. So with this all, we can come to conclusion that all these regimens can bring down the treatment of MDR as well as the XDR treatment to 6 months. So no injectables and a shorter regimen reaching to 6 months is the gold standard, and now it is knocking at the country level for the program manager how to kind of implement them into the program of the nations, thinking into their logistics and resources. Thank you, sir.
Thank you. Now, because your point, because since it is a debate, we will give equal time to the first.
Right, sir.
So, then there is a 2-minute rebuttal also.
Right, sir.
सर दीपक अग्रवाल, हाँ आपकी दो कौन सी चलाऊँ? प्रेजेंट पहले वो प्रेजेंटेशन. ओके, वेट अ सेकंड सर, वेट अ सेकंड.
Good afternoon, everybody. So at the outset, I would like to thank Professor Dhruv and his team for giving me the chance to be here. My talk is against the notion that all patients of MDR-TB should receive short-term regime. I know this is a difficult task because currently the evidence is currently in favor of shorter regimes for MDR-TB patients. And my respected senior Dr. Anand has very beautifully shown that all patients of MDR-TB can be put on MDR or a shorter MDR-TB regime based on the trial data. But we need to see the darker side of the story as well before we can have a consensus whether this picture is really rosy or we are sitting on the bed of thorns. So I'll have to have a friendly match, and my take will be on 3 parts: the trial data, the basics of TB treatment, and bacterial virulence. So going to the journey of shorter MDR-TB regime, the regimes came into being in 2017, and they were replaced by 2021 when the bedaquiline containing shorter regime came into existence. And now in 2022, the WHO has approved the 2 BPAL and BPAL-M regimes to be rolled out for MDR-TB patients for 6 months, thus making the duration of MDR-TB equal to that of a DS-TB. So let us see how these 3 regimes do work well or not. So coming to the shorter bedaquiline containing regime, it was based on WHO analysis of 2020, which was basically a single country data from South Africa. It was an observational data, not a randomized data, and there was no comparison with the longer regime. Overall, there was again residual confounding factors and there was a selection bias. So the WHO itself gave a very conditional recommendation for its use. Then came the Stream 2 trial, which was again an open label trial. Even though it documented the efficacy of this regime versus the injectable regime, but again there was no comparison with the longer regimes. Plus the shorter follow-up was there, so we could not comment on the relapse rate in these patients. Moreover, apart from that, there was a clear-cut exclusion criteria which was mentioned in the guidelines as well as taken up in the trial, that these shorter regimes should not be given to patients who are pregnant, lactating, children, patients with extensive pulmonary TB, patients with severe EPTB like meningitis and disseminated, patients with known resistance to these drugs. So there was a clear-cut exclusion. So it was clearly meant that this regime is not universal and is very selective. Then came the BPAL, and the basis was the NICS TB trial published in NEJM, which gave a 90% success of this BPAL regime in MDR and XDR patients. But again, the main point to consider is this was not a randomized trial. There was no control arm. It was again a single country data, and the shorter follow-up was there, even though the trial said that the longer 24-month trial follow-up is being continued. Another thing peculiar in this trial was that only 15% of the patients could take linezolid in the proper dose and duration. So at any point of time, 85% of the patients were taking 2 drugs, which again put a question mark on whether this trial or this drug regime was working very well or not. Then the third trial, the BPAL-M, now which has recently been approved by WHO on this basis, a TB practical study, which showed a high favorable outcome of this BPAL-M, that is BPAL along with moxifloxacin, as compared to standard of care. But again, this trial had various shortcomings. It was an open label design. The sample size was merely 62 patients for BPAL-M arm versus 66 patients in the standard of care. And it was seen that the favorable response in BPAL-M was primarily because of the dropouts in the standard of care. The efficacy per se was equivalent in both the arms. And over and above this, the standard of care was not uniform. So it was a 4-year trial and the standard of care kept on changing. So it was not an actual comparison. Again, the subgroup of patients like children, severe extrapulmonary, pregnant, and breastfeeding were excluded in this trial. And this trial was underpowered to show any treatment effects, varied according to HIV, sputum smear status, cavity and fluoroquinone resistance. So if I try to sum up all these trials, the shorter regimes, I can still vouch that they are meant only for selected patients. Why? Because this is based on observational data or a single RCTs that have been published recently. The trials itself say that it's not a universal regime, and the subgroup patients have been excluded in these trials, particularly pregnant, lactating, extent of disease, so severe disease were excluded. And we know that majority of the patients of MDR present with an extensive disease in our practice. So let's say this is an X-ray of a patient with the right side localized involvement. Here I can think of putting this patient on a shorter regime. Vis-a-vis the patient with extensive miliary involvement or patient with bilateral fibrocavitary extensive. Can you think we can treat this patient with a 6-month regime? I really doubt. Moreover, the data from India is quite limited. And we know that geography changes the strains of the bacteria. It changes the virulence of the bacteria. It changes, and we do not know the baseline resistance of the Indian patients. We do not know the tolerance level of the Indian patients. So how can we say that whether these regimes will be universally applicable to all the MDR TB patients? These are package regimes, BPAL-M, BPAL, we cannot replace these drugs. Vis-a-vis a longer regime where we have a flexible option is there. So if my patient is not tolerating that drug, if the patient is found to be resistant to any of these drugs, I need to replace the whole regime and put them on a longer regime, and that will make the duration more longer. The long-term follow-up is not available in the trials, so I cannot say whether giving the drug for 6 months will make my patient a long-term relapse-free. Apart from some answered questions, there are many unanswered questions as well. So I know that this is a fibrocavitary disease, an extensive disease. I will put this patient preferably on a longer regime which is available currently. But let's see this patient. This patient is an old treated case with an element of fibrosis. then this kind of X-rays will bring some confusion in the mind of the treating physician. What to put, a longer regime or a shorter regime? The trial does not support this. Then there are certain scenarios, the TB with diabetes, TB in elderly, TB in malnutrition, abdominal pericardial involvement, TB with renal involvement, TB with other respiratory comorbidities like ILD, where the data or the trial is lacking. We do not know what to put, and we need to generate the evidence for this. And till the time particularly when these type of scenarios do occur in a drug-sensitive patient, we usually need to extend the treatment. So how can we vouch on we can treat this patient with a 6-month regime? That may not be possible. After analyzing the trial data, my second stand will be on the basics of TB treatment. So when we treat a patient of TB, our aim is to achieve a relapse-free cure, to prevent a drug resistance at the same time, and to prevent failure. So how do we do this? We do this by targeting all the bacterial populations, by giving multiple drugs and for a longer period of time. So this is the basic principle of TB treatment, and we know that the bacterial populations are multiple populations, like they are our rapid growers, they are dormant bacilli, they are persisters, and they all need a different duration of exposure to drugs to get killed. So what will happen if we give an inadequately shorter regime to all MDR TB patients? It can increase genetic resistance, and it can also increase the phenotypic resistance. And how can it happen? In the initial response, when we start giving this regime, like a BPAL or a BPAL-M to all these patients who are treatment naive, initially we'll get a high treatment success rate, as we have already seen in these trials, to the tune of 80 to 90%. But when we start using these regimes in all the patients in a programmatic manner, there may be a chance that the drug mutations will arise and leading on to increase in the number of drug-resistant bacilli. And if we are using a shorter regime in these patients, that can amplify the drug resistance, leading on to failures. Also, if we are using a shorter regimes in all the patients, there is a chance that the dormant bacilli, which are not multiplying, they may be more in number in these patients. Now we know that dormant bacilli, they are inherently resistant to many antibacterial drugs, and they require a longer period of exposure to anti-TB drugs to get killed. So how can we think that 6 months of regime can kill these dormant bacteria? And if they get retained in the lungs for a longer period of time, they may lead on to increase in the relapse rates. So this is a genuine issue which needs to be taken care of in pre-hand before we can say that all shorter regimes all patients or MDR TB patients can be put on a shorter TB regimes. Anti-TB regimes, sorry. So the third and the last part is the bacterial virulence. Do we know that the two bacteria, the drug-sensitive bacteria and the drug-resistant bacteria, are same, apart from the resistance levels, that one is drug-sensitive and one is drug-resistant? So earlier we used to think that these drug-resistant bacteria are weak bacteria because they have their low growth rate and they become less virulent. But now there is a growing evidence which say that the drug-resistant contributing mutations, certain compensatory mutations, and certain global response factors, they increase the fitness level of these bacteria, making them to be more virulent. And when these become more virulent, naturally a 6-month regime cannot work. So after seeing all this variability in the disease, in the bacteria, in the patient population, can you think that a one shorter regime can fit for all the patients? Definitely no. So if I take the whole bunch of MDR TB patients, based on the experience in the previous slides and the evidence which I've shown, I can still vouch that more than 50% of the patients will end up in the longer regime. And the shorter regimes will be meant or justified for patients with a localized non-cavitary disease and certain forms of extrapulmonary disease patients. Also, there may be a third group of patients at this point of time, which is a gray zone, like the patients with comorbidities, patients where there's a dilemma on the extent of disease, where we do not know what to put. The data is not very clear. And till the time when we don't have any clear evidence, I think it's better to put them on a longer regime because we know that the efficacy is similar. So I'll conclude here. The longer regimes have a long way to go still, and till further evidence arises, shorter regimes have a shorter and a limited role and not suitable for all MDR TB patients. Thank you.
Thank you, Deepak. I think
Yes, now you have to rebuttal, Dr. Anand. 2 minutes. Then Deepak, you will also get 2 minutes.
Okay. So, as I said, that the longer all oral bedaquiline regimen does not have even a randomized control trial. It is, as he said, observational. What I said about the shorter injectable and shorter all oral, they have a randomized control trial. So that we need to understand. And as I said, the side effects and the default of the longer regimen, and the success of that regimen as of today is far less than these two. So if you have to choose, there are 2 randomized control trials for each one of the shorter course. There is none for the longer. The side effects are there. Now, the issue of multiple bacillary population, what has been said, bedaquiline has been studied. It acts on slow multiplying, dormant, semi-dormant bacteria, sensitive as well as resistant MTB bacteria. So it has that inherent capacity along with pyrazinamide to kill those semi-dormant bacteria. So the drug regimen which we have chosen for a shorter course answers to all the bacillary populations, even to the drug sensitive, as Dr. Sareen has shown that bedaquiline is effective. Now the question comes as to fearing about the extent of disease, about radiological extent of disease, about the bacillary load of the patients and the relapses. As I said, these 2 trials which supported these shorter oral and injectable, they mapped out all their patients into grades of 1+ sputum positive, 2, 3, and more than 3. And then they studied the effect in the 2 groups, and they said that in multibacillary disease also, this drug works as good as in 1+ or 2+. They divided their X-rays into zones and into cavities, counting the cavities, so less than 3 cavities, more than 3 cavities, and then they said that these drugs work like the same. So that randomization and subgroup analysis did happen. And then only these NEJM and clinical infectious disease accepted that this analysis is good and the regimen can work. Finally, about the relapses. Now, either you wait for, in TB they say that you should study 6 to 7 years of relapse. Now, how long the country is going to wait for a regimen to mature when everyone has started using it? And there are clinical inputs that if relapse is directly proportional to how fast the culture conversion occurs. So the scientists have now introduced 2 new tools, time to culture negativity, and they did weekly cultures of these patients. Every week the culture happened, and they demonstrated that majority of the patient, by 4 weeks, 8 weeks, they had converted on culture. 2 cultures, 1 week apart. And that, they say, extrapolates into the low relapse rates. Though the follow-up is not that for 4 years or 5 years, we'll be foolish to wait that period if we prove that this regimen is okay. So even 72 weeks follow-up, which happened in Stream 2 trials, is good enough after randomization to suggest that there were no relapses or 1 or a 0 relapse happening with these regimen. So I think it is time for us to kind of see the data, analyze what we wish to choose for our population and our patients.
Thank you. Yes, Deepak.
Yeah, I have 3 issues basically. Now these regimes are using the drugs which are totally naive. None of our patients have ever been exposed to bedaquiline currently in our Indian environment, or betaminid, let's say. And it's not a short game what we are trying to play. We know that there is no point of questioning the efficacy of these regimes. We have already seen that these regimes are giving an 80% cure rate or a 90% cure rate. My doubt and my confusion or my apprehension is that whether are we going to sustain this much efficacy 2 years down the line or 3 years down the line? Behra sir already told in the evening that we have started getting bedaquiline resistance in our patients to the tune of 2 to 3%. And if we are using BPAL regime, in which we are using bedaquiline, pretaminid and linezolid, where linezolid is also used for non-tubercular reasons as well as in India. So if you're using this 6-month regime like a BPAL in our patients, are there not any chances that it will increase the resistance to other drugs as well? So it's matter whether how can we sustain that. It's a question basically. So the trial, a single trial, and recommending the recommendation on that basis, it's not justified. Secondly, I'm not against the shorter. I personally also wish that all the patients should be treated with the shorter MDR TB regimes. I totally vouch. But currently the evidence is not in favor of this. The trials itself have excluded many patients where this regime should not be given. Secondly, as I already shown in the previous slide, these are package regimes. And we need to upgrade our diagnostic facilities. We need to know the baseline resistance level of bedaquiline, predominant and linezolid at baseline, because these are package regimes where we can use these regimes uniformly. Thirdly, the tolerance level. We do not know how much tolerant our Indian population is for this bacteria. So if the patient gets any side effects for which reason these regimes cannot be used, definitely that we need to stop these regimes and we have to put them on a longer regimes or some other regime. And definitely that puts a question that we need to upgrade our diagnostic facilities in India so that we are in a position to use these regimes uniformly in all the patients. Till the time we are not able to justify, we're not able to get a DST pattern of these drugs, using them uniformly, I'm scared that they may further amplify the resistance and make these regimes as a shorter game. Thank you.
Both the debaters, Dr. Anand and Dr. Deepak, had done their job well. They have given the scientific data in support of each and other. But I feel like that this was a fight between the Bali and Sugriv. The Anand has the power of the Bali that it is portrayed by the WHO, it is portrayed by the NTEP. But just in spite of that, Dr. Deepak could have a good fight. I had presented good data. But who is going to be the winner or both are winner? That my Bhagwan Ram, Dr. Behra decide.
So I think you see in any scientific evidence is always a question, but I should say for both the debaters, I think they did their job extremely well. They have touched every point. What are the pros, cons, and then what are the difficulties? I think in any, but I, from the program point of view or from as a clinician, I should say, I should like to have a regimen which is as short as possible, having the fulfilled criteria. That means it should be efficacious. There should not be the 4 important criteria which are being seen under all these trials are what is their primary outcome. That means what is the sputum negativity, clinical cure, radiological cure, etc. Number 2, how soon the sputum is converted. As one of the points Dr. Anand also told, how soon the sputum is getting converted. And third thing, the side effects, the tolerability. And then obviously the most important thing, particularly in TB, is the relapse-free cure. That is very, very important. We have to see the relapse. Of course, some of these trials, they are not very extensive. In our own country, before even introducing this bedaquiline, there was a CAP study you must have remembered, that is the conditional access program. It was done at 4 different centers, and then the country got satisfied, so then they implemented it. So I think taking everything into account, another disadvantage of a BPAL regimen in particular, I should say, that if you see the practical trial, which has just come in December, New England Journal of Medicine issue, that shows the BPAL regimen success rate is 66% only. They have told you the primary outcome, whereas the regimen which Anand showed, that was the next TB trial, that was they are telling to the tune of 90%. So, there is also discrepancy there. So, maybe all sizes do not fit to all. There we have to do. And then the difficulty with the shorter regimen is the Bipal, the bedaquiline regimen, bedaquiline containing regimen, is the getting the result of a fluoroquinol resistance, which we had commented in the morning, how soon we get it, because before you have to put the patient on this giving fluoroquinol, which is a major drug. So you should have got those results available. So that is, I think, one of the practical difficulties which Deepak took in his favor. But you see, Deepak, these are the type of things that is not if the program or the country or the physician is not getting that, there is no fault of the, regimen also, because you have to take all these precautions. So provided you take all the precautions, but I should say both the points are very well taken. But ultimately, we presume that we will get all these informations in time. It is a different thing. We don't get everything not in time. The duration is very short. It is well tolerated. The side effects are well tolerated. But I agree with you. And then at the national level, you see how we have jumped from the 45% success rate to about 65% success rate. I am not telling it is still 100%, but you have to choose the better one. When there are two evils, we have to choose the better ones. It may not be the best, I agree with that part, but we have to choose the better one. But in the overall, I should say both of you put the points very well, and maybe I will give them an equal mark. Yeah. So thank you. There is some question or something, maybe Dhruv, it will be taken in the next session.
Okay, thank you.
I would like to invite both the speakers on the stage and Dr. D. Behra and Dr. Jaikishan to present their token of gratitude. Let's move forward with our next session, that is clinical failure with ATT. And for this session, I would like to invite Dr. Anand Agrawal, Professor and HOD of Respiratory Medicine, BPS Kanpur, as the moderator of the session. Chairperson, Dr. Sudhir Attri, Senior Professor, Department of Medicine, PGIMS Rohtak, Dr. Vipul Goyal, Professor of Department of Respiratory Medicine, PGIMS Rohtak, Dr. Divya Saxena, Vice President of Indian Medical Association, Haryana.
Thank you very much, Dr. Dhruv Chaudhary, sir, for providing this opportunity to moderate this interesting session. This is a very interesting topic. I also invite Dr. Ashutosh Agrawal to start the session, because this is very important to be comment on the treatment failure, because if we say not everything, we say koi bhi chamakne wali cheez or pathar, or we can say any shining stone can't be a diamond. That's why every failure regime, it is not possible that is due to the MDR or the drug resistance tuberculosis. So now I request Dr. Ashutosh Agrawal to start, please.
Thank you, Chairperson, sir. And I bring you all greetings from PGI Chandigarh. And a very big thank you to Dr. Dhruv and his team for providing an opportunity to have this interaction. So all of you listened to this lively debate, and even at the end, neither the chairpersons, nor the debaters, nor the audience could reach a definite consensus. The topic that I have been given is all clinical failure with ATT, drug-resistant tuberculosis. And for this, I must say it's a no-brainer. There is no debate. There is a clear consensus on this. So I'm going to break protocol and probably start with my conclusion slide first. So the conclusion is, of course, a big resounding no. All patients with clinical failure to standard anti-tubercular drugs do not have multi-drug resistance and need not be considered for treatment as being MDR-TB. And in support of this, I'm not going to present you any big data or any studies or any great scientific stuff. I think a lot of it is just pure logic and simple clinical practice that we do day in and day out. So for me, at least as a clinician, it is absolutely important to confirm multi-drug resistance before even thinking of starting a patient on an MDR-TB, because that treatment for MDR-TB is a big commitment. And unless you are sure about it, I don't think it is justified. And as a clinician, I've always refrained from putting in a clinical label of MDR-TB. For me, an MDR is something that has to be proven microbiologically. And this microbiological proof has to come from a good lab. Even the national program also says that all these tests should be done from quality assured and accredited laboratories, so that at least there is some sense of quality in the reports that you get. We have seen cases in the past when people come with reports of pan-resistant Mycobacterium tuberculosis from a particular lab, and the patient is absolutely fine. Really no clinical evidence of drug resistance or disease progression. And when you repeat this sample, this person is either sputum negative or comes back with a pan-sensitive report. So this has happened on multiple occasions in our OPD. And therefore, it is essential to choose a good lab to get these tests done. And nowadays, with the advent of molecular diagnostics, a lot of the tests have become simpler. They give you results much more quickly, and stuff like Gene Expert or TrueNat or line probe assays are now a routine practice in our national program. So, and you really don't have to rely on cultures and wait for several weeks or months to finally get a report of drug-sensitive or drug-resistant bacilli. The only caveat here is that a lot of times, especially in patients who have been recently treated with the standard drugs, the Gene Expert or the TrueNat or similar test could give you false positive results or indeterminate results which are difficult to interpret, and patients can continue to be positive by molecular test even after they have been successfully declared cured both clinically and microbiologically on other tests. So culture plus drug susceptibility testing still remains a good tool. It is virtually the gold standard against which we all test the newer techniques, upcoming techniques, or point of care tests or rapid methods. So for difficult cases, I would still say that you can go in for culture plus susceptibility testing. But overall, I don't think it is anybody's right to clinically label a patient as drug resistant and start a treatment for MDR-TB purely on empirical grounds. So this is the general way in which I will look at the problem, that first you should attempt a microbiological evaluation from a good laboratory. If you get a multi-drug resistant bacilli from any of the tests, then yes, please do consider treatment as a multi-drug resistant TB case. But in case you either pick up no bacilli, or if you demonstrate drug-sensitive bacilli, then I think it's time for you to figure out why this has happened. So in this, I think the two main issues that we need to consider is, one, we need to check whether or not we are actually dealing with the TB or is there something else. And secondly, especially if the tests do not show any mycobacteria, or if they show drug-sensitive disease, then why is this patient having a delayed response or lack of response? So for all these, you have to try and figure out the factors that are responsible. And if you are able to identify those factors, then maybe you can tackle them appropriately, or maybe you can even try extending the duration of your standard antitubercular regimen, as is commonly done with, say, osteoarticular TB or with neurological TB. So let me first come to the fact that whether or not the tuberculosis diagnosis itself is correct. This is an important thing that we must all consider. As an example, this is quite an old patient with us. He had more than a decade back, he had sputum positive tuberculosis. He received treatment. After treatment, he got symptomatically better for a few days, but then the repeat X-ray showed almost a destroyed kind of right lung. This patient continued to have hemoptysis, and he was started for the second time on the standard antitubercular regimen. But at this point of time, his sputum AFP was negative. He had no response to his symptoms. He completed this treatment also, and intermittently he got some antibiotics and other stuff. And finally, someone thought that because the radiological shadows are not improving or rather worsening, the symptoms are persisting, there is no response to standard ATT, let's try giving him a multi-drug resistant regime. That is when he had come to us. At that time, we were slightly building up our interest and experience in chronic pulmonary aspergillosis. So we subjected this patient to AFIgEG, and which was strongly positive. A CT scan was done subsequently, and it showed a destroyed lung on the right side with a suspicion of aspergilloma in one of the cavities. We gave this patient oral azole therapy, and over the next few months, he had some symptomatic improvement. His hemoptysis got better, and this patient was then subsequently lost to follow. But what I'm trying to say is that, as Dr. Anant Mohan also pointed out in his previous talk, that please consider that this could just be a sequelae of TB and not a case of TB that has gone bad. This is another patient. This patient presented with miliary shadows on chest X-ray. He was sputum negative at that time, but it was thought that miliary TB can be sputum negative. So he was started on ATT. He received 6 months of ATT. He was stable in between, but after he finished his ATT, he started having some worsening of symptoms, and he also started having some small degree of hypoxemia. That is the point when someone tried to evaluate him. His X-ray showed worsening lesions with a lot of soft tissue, soft opacities also. And a CT scan was done which showed both nodules and ground glass opacification. He was subjected to a transbronchial lung biopsy, and which showed a lot of non-caseating granulomas. His PPD skin test at this time was negative. So a diagnosis of miliary sarcoid was made. He was started on steroids, and he improved with this treatment without the need for going on to MDR regimen. This is another patient which we saw just recently. This patient had the usual curved sputum, hemoptysis kind of history. He had a cavitary lesion, he had lung nodules, and he received ATT, but to no response. There was no improvement in the radiology, no improvement in the symptoms. He was intermittently sputum positive and always expert negative. So there was no documentation of resistance also, and someone outside then thought that because he's continuing to be sputum positive, he should be considered for multi-drug resistant TB. But what bothered us was that the sputum AFP was persistently positive, but the gene expert was persistently negative. And we, at this point, looking at the X-ray, also thought of non-tubercular mycobacteria. We did a bronchoscopy and a bronchoalveolar lavage for him, and it grew Mycobacterium avium intracellular, and this patient was put on appropriate regimen. So everything that is sputum positive need not be drug-resistant TB. It could also happen that this could just be a dead bacilli which is giving you a false positivity or some other factors. So please try and exclude these factors before you make an empiric diagnosis of MDR TB. The second issue would be, what if the disease just does seem to be because of drug-sensitive Mycobacterium tuberculosis, which means that you have persistent smear positivity, or if you have persistent expert positivity with drug-sensitive bacilli, then what do you do? And here, the problem could be multifactorial. There, as we all understand, there is a complex interaction between the host, the pathogen, and the drugs. And several of these factors, alone or in combination, could be responsible for the way the patient is not responding to your standard treatment. So coming to the pathogen first, obviously someone who has a very high bacillary load is likely to respond rather slowly as compared to someone who has a paucibacillary disease. So that could be one reason. And in some of these instances, it might be justified to probably increase the duration of regimen if you feel that the things are not going as planned. As I said, that you could be having false positive test results due to dead mycobacteria, and if the patient is improving but the sputum is still positive on gene expert, then maybe this is a consideration that should be made, and culture is likely to then settle the issue because dead mycobacteria will not grow on culture. Then you could be looking at some resistance patterns other than the classical multi-drug resistance, for instance, a monoresistance or maybe a polyresistance, which is not rifampicin related, or stuff like maybe a CAT-G mutation where you could simply increase the dose of INH and get away with it. So some of these factors again could be either picked up on molecular testing or on conventional culture and the standard testing. Similarly, there could be other specific bacterial genomic determinants that could determine how fast or slow the bacteria respond to your treatment. A lot of them are still not known. There are several mutations that have been identified which confer low-level resistance, but which will ultimately respond to your standard treatment, and these could be responsible. And finally, in a high endemic zone such as India, exogenous reinfection is also a possibility that you must always consider. So we don't think about it frequently, but I'm sure this must be happening. On the host side, you may have several underlying disorders of immunity, specifically like diabetics or people living with HIV or those taking immunosuppressive drugs for other disorders. All of them may show a delayed response to treatment. Not all of them will be ultimately drug resistant. There could be several other comorbid conditions that can explain the symptoms, and for instance, patients with heart failure can continue to have dyspnea, and you cannot always ascribe that symptom to just a failure of adequate TB response. Similarly, we have had patients of lung cancer in whom who have been coexisting tuberculosis is there. So you treat the tuberculosis, but the lung cancer shadow on the X-ray is not going to vanish. And so you will have a persistent progressive disease on that. But here the symptoms and the radiology is better explained by an alternative diagnosis. So obviously this kind of patients also should not be considered to be drug resistant. And lastly, there could be complications or persistent residual disease. Some of these issues have already been discussed by previous speakers, but just to emphasize, like this is a patient who has meningeal TB, who had basal exudates at presentation. On ATT, he has developed basal ganglia infarcts. He has gone on to develop hydrocephalus. And even after a successful treatment, he continues to have some of these residual lesions. He's not going to improve neurologically to a normal level. It is naive to even think that he will do so. And therefore, a clinical response should not be really confused with a radiological or apparent radiological lack of response. Similarly, this kind of patient with osteoarticular TB or spine TB. So you see that this one level of vertebra is involved at the beginning. There is some epidural collection. There is a lot of soft tissue component. This patient received ATT. He showed some clinical improvement, but somebody ordered a MRI 6 weeks down the line. So as was pointed out earlier today also, you don't ask for MRIs at this point. So obviously this will show some kind of paradoxical response or some disease which is seemingly progressive, but the soft tissue component is so less. The epidural compression has all disappeared. The patient is better. You would not consider just the fact that he has who was prescribed rifampicin, just scribbled rifampicin. The chemist could not understand it, and he gave him rifaximin. So you can understand that these things do happen. On the MDR side, we have at least 2 or 3 cases where cycloserine has been replaced by cyclosporin. So these things happen only in India, but this is a point that you should always check whether or not the patient is actually taking the drugs that you have been prescribed or not. Sometimes the drug dosing is inadequate. Patients gain weight, but the dose is not adjusted accordingly. Or sometimes you ask for rifampicin 600 milligrams, but the chemist in his wisdom is supplying him only 450 because that comes in a standard packing or something. The reduced drug absorption is something that, that is bothersome and sometimes very difficult to identify. We recently had a patient in whom he was very sick, very emaciated. He had already taken ATT on 3 occasions. Each time he was sputum positive. He used to take standard ATT. He used to respond. 2 months down the line, he would again start having symptoms. Retested, sputum positive, drug sensitive. So this happened for 3-4 times, and then somebody outside said that it's time to consider MDR regimen. When he finally came to us, he was quite
Dr.
sick. We
Ashutosh,
admitted him.
please conclude your session as time is running.
The last slide. So we admitted him, and then we tried to get his drug levels done. And his rifampicin and INH levels were quite low. And we just hiked up the regimen, and this patient was then put on rifampicin almost 25 mg per kg, and INH was also increased, and he was sent home. He has shown improvement, but I'm not sure whether this has been sufficient or whether he will relapse again or not. So sometimes the drug also does not penetrate optimally into the site of disease. We see it pretty commonly with tuberculous empyemas, where the drug absorption into the empyema fluid is poor, especially when granulomas get walled off by fibrosis. Then also drug penetration can sometimes be poor, and these patients can have a delayed response. And then there is the issue of the fixed dose combinations. Some of the older fixed dose combinations, they were documented to have poor bioavailability. So if you give these drugs singly, the bioavailability is good, but in combination, somehow the bioavailability is not as good. Fortunately, the program has some internal quality control mechanisms by which they ensure that the drugs are of good quality and have good bioavailability. But outside the program, I am not all that certain. So to summarize, I would again stress that apparent lack of response to a standard antitubercular treatment does not always imply multi-drug resistance. Always try and figure out if there is an alternative explanation. If you can sometimes identify pathogen, host, or drug factors that can contribute to a seemingly subtherapeutic response. And finally, diagnosis of multi-drug resistant tuberculosis should never be made empirically without microbiological confirmation. Thank you for your attention, and I'll be happy to take up questions.
Thank you very much, Dr. Ashutosh Agrawal. As you have concluded that all the factors which are responsible for the failure of regime, not only the MDR tuberculosis. As Dr. Vera is sitting here, Dr. Vera have a smart work over it. He has published this paper in 2006 about the failure of the regime. So they have shown there are a lot of causes like alcoholism, drug abusers. So they are least reliable, and they are not sure. It is not sure whether they took their medications properly or not, and that may be the reason of the failure. The recent study which has been published in American Journal of Microbiology, that has been studied in South Seoul by the Dr. Park, that shows there is a MIC, minimum inhibitory concentration, which actually work during this treatment failure. The minimum inhibitory concentration is very less in the 4-ATT, like isoniazid rifampicin, ethambutol and pyrazinamide in that study conducted on more than 400, over the 400 patients. So the isoniazid was least absorbed in the blood as a routine. So that may lead to failure of the regime. And similarly with the ethambutol, pyrazinamide, as well as with the rifampicin, that has been published in 2022. So that will give us some idea about why these regimes get failed when we are not conducting all these investigations prior to starting off these regimes. So the minimum inhibitory concentration may be low or may vary, depend on the genetic variations of the persons. So that may be another cause which you have mentioned in your last slide also. Thank you very much, Dr. Agrawal. Any question from the audience side?
So what I have seen is that tuberculosis is, I don't know, somewhere because of the things which are associated, and I have discussed with Dr. Ashutosh quite often, otherwise earlier, it's a bacterial disease. And all principles of bacteriology are applicable here. Just because that its growth period was longer, so probably entirely we forgot the principles. That's why we're coming back again to cultures, short durations, And obviously now the molecular diagnostics is taking over. And again, if ask me my lesson, what I heard, or rather what I listened is that please individualize the treatment. And when you're making the diagnosis, ensure that within the program or within when a patient is being referred, as individualized as possible, so that day one itself we know. And what you talked, which we discussed in the morning also, is that by increasing the doses, we are trying to some extent looking at the suboptimal values which are there, because 10 mg per kg is 600 ceiling. So what will happen to 80, 90? So I think to that extent, some operational research has shown it, and it will take it. But the point which you, Ashutosh, is making, which large number are, like your department is a pioneer now, is CNPA. A lot of patients of aspergillosis repeatedly being put into it. And again, 3 drug series being added if person is not responding. That still practice continues. And so that's what scares us the most.
Sir, I think in such cases, when the dose is optimum or the maximum ceiling is there, that has been used, and still patient is not responding, therapeutic drug monitoring should be considered in those cases only, selective cases.
Yeah, the current recommendations also say that at least TDM should be employed as much as possible. In a country of our size and with the magnitude of the problem of TB that we have, routine TDM is not possible. So I think it should be offered to at least those patients who have a seemingly inadequate response. For them, at least we can do. But the quality control, the actual values, the cutoffs, even these are not very well defined. For instance, if you want say a rifampicin TDM, then you have to have a minimum of 2 to 3 samples. A single sample will not do. Patients don't just stay back. If you call them at 8 a.m. in the morning, take a sample, ask them to be, tum yahi rifampicin khao, ek sample fir 2 घंटे के बाद एक और दो, 4 घंटे के बाद एक और दो. Patient says, what are my wages for today? So
that is all practical issues, but still the things which we should keep in mind for the research point of view also. The one more important thing which I just want to share with all of you, that many a times when we rely on the culture and sensitivity reports, that is actually conducted at a higher minimum inhibitory concentration. So many a times it gives the false presentation that the patient is not resistant, but actually he is. If we go in a molecular diagnosis, then we found that the patient is resistant to that particular drug, but it is not shown in the culture report, because the minimum inhibitory concentration which has been taken in the laboratory is quite high. It is more than 4 to 5 times of the in vitro level. So that's why there are a few points which are unanswered that can be addressed later with the research, more research. Thank you very much, Dr. Ashutosh Agarwal.
Thank you
for the nice talk.
I would like to tell all the dignitaries to present the token of thanks to Dr. Ashutosh.
One question, please. One question. Dr. Ashutosh, when we used to study MBBS or MD, we were always told rifampicin has to be given empty stomach. Still we follow this practice. But after this RNTCP, drug combinations, these are given after meals. Has this something to do with the absorption and poor results?
Sir, it could be, unless we conduct a good absorption study or a drug monitoring level study, it's not possible. Not only that, there are other factors also which could be involved in malabsorption. For instance, if the patient is taking concomitant antacids, especially aluminum hydroxide base, so they are known to interfere with both absorption of both rifampicin and INH. So some of these problems are there. Plus the FDCs themselves, the bioavailability is not guaranteed for all preparations. So unless you have a good preparation which is standardized and which has been tested, you may not have as good a bioavailability as is with the original drugs themselves, individual drugs.
The original work which was done by pharmacokinetic studies, they showed 40% if you take it with food, 40% less absorption.
Yes, because I am giving it empty stomach still. All the 4 drugs empty stomach. And I am not facing all these problems. Poor bioavailability or poor results or uncertain results or negative results. We are not facing it.
I think that these are the questions which actually come up with the day-to-day daily practice. Very right. Multiple issues which are there, but you go with the fat valley so that majority fits with it. Outliers you look at.
Interestingly, Stanford drug formulary says that only 5 drugs needs to be given empty stomach: cycloserine, rifampicin, INH, voriconazole, tetracycline.
Tetracycline
I
is
searched the
very
entire
important.
list.
So tetracycline sir, is basically whosoever prescribing, we are prescribing a lot. If you have a milk or a milk product, it's as good as not giving it. So you need to keep a difference of at least an hour when you are actually prescribing tetracycline. And we rightly tell patients that if you are taking tetracycline, please don't take tea at least an hour before or now. That's what we very rightly said, sir.
Now, I would like to invite Dr. Rajesh Raju, State TB Officer on the dais for preventive therapy of TB.
Good evening. At 5 p.m., just at the verge of ending, it's a difficult part. And I would like to thank Dr. Dhruv. He has gone. And my faculty. I did my post-graduation from this institute in 2003. And to rise on these 2 feet, it took me at least 20 years. So after 2003, I am here on the dais in 2023. So to rise above this, 20 years. I was not a bright student at that time. Still not, but Dr. Prem Prakash, my mentor, my teacher is here. Dr. Vipul, Dr. Rajesh Gupta, Dr. KB Gupta was my HOD. I thank them all. And recently, I did observership under Dr. Behra also for bronchoscopy. And after that, I did at least 150 bronchoscopies till yesterday. So, I will not take much time. This is something which we in 2000 and 2003, within that 3 years, RNTCP was expanding at that time. And in Viva Voce, I still remember that we had to learn the strength and weaknesses of DOTS program, RNTCP. And I was not aware at that time that at one point of time, I'll be responsible for those weaknesses and strength as State TB officer.
If you are a weak student, then that's the job.
Yes. That I'll not go into the detail, but this is the tip of the iceberg. What we are treating is just tip of the iceberg. What we can prevent is below the water, which is unseen. Addressing this latent TB infection reservoir is critical to achieving TB elimination. Latent TB, as earlier envisaged, it was dormant phase, bacilli are sleeping, not taking anything. Now it's clear that it is an active stage. Bacilli is dormant but still active, so drugs can act on them, right? I'll not go into the details of these slides because the paucity of time, but main features I'll emphasize. Maintaining latency is an active process. So drugs, the spectrum of TB, we all know, I'll not go into this, but quiescent infection and acquired immune response. These 2 stages are there where something can be done to stop the transmission. Then when active infection occurs, disease occurs, we have to treat it as a disease. With review of literature, it was found that TPT reduces the overall risk of 60 to 90% among people living with HIV. And the United States public health study trials showed that when INH was given to household contacts, HIV positive, the placebo group had more of infections in extrapulmonary as well as pulmonary TB. The patients who had INH, they were less in cases of extrapulmonary and pulmonary TB. 6 months therapy, as you can see with the middle line, that 65% case reduction, 5-year reduction, 78% compliance, and risk reduction was 69%. Though it is more in 12 months, risk reduction is more, but side effects are on the higher side. Then other studies in Brazil and then TB-TC studies, it showed that INH rifampicin versus rifampicin and pyrazinamide, INH rifampicin was the chosen one, which showed less of hepatotoxicity. Rifampicin pyrazinamide had excess hepatotoxicity. Then in Prevent TB study, which was published in NEJM, 2 arms. One was directly observed treatment with INH and rifampicin. Second was self-administered therapy for 9 months, daily dose INH. Both studies showed equal response, but INH and rifampicin had more of problem with hypersensitivity. And long-term safety monitoring, it was shown it is to be important to monitor them on long term. This is the result. Non-inferior in effect, both were almost equal. Treatment completion was more in 3 HP because once a week dose for 3 months, that is only 12 doses. So compliance was better. Drug discontinuation after this event was almost equal in those, both 2 arms. Toxicity was more in patients who were taking 9 months isoniazid, hepatotoxicity. But hypersensitivity reaction was more in rifampicin group. So rifampicin group, nowadays latest is that just 3 weeks back we supplied isoniazid rifampicin to all the districts of Haryana. Rohtak, I got one request 2 days back that ART center doesn't have any isoniazid prophylaxis. You have isoniazid and rifampicin, ma'am. Start giving that. It has been proven in HIV also that isoniazid rifampicin is efficacy. It is non-inferior, as good as isoniazid. In one study, there were 4 arms. I'll go directly to the result. 4 arms, isoniazid rifampicin, 3 months of isoniazid rifampicin, 6 months of isoniazid and continuous isoniazid, that is for 6 years. So I'll go to these 2 lines. Serious adverse events were more common in 6 years of isoniazid. No significant difference in all the arms regarding prevention of TB. So one question which is repeatedly asked, especially in medical colleges, that we are giving single drug to a patient who can develop TB later on. So are we promoting isoniazid resistance? In this forest chart, it has been shown that it is almost non-inferior, almost does not cause or does cause a balanced type of, which can be debated again as Dr. Jaiswal and Dr. Deepak. But another study showed conclusively that no statistical significant difference in isoniazid resistance among those who had received IPT. This was a control clusters. So isoniazid can be given safely without the doubt of isoniazid resistance. But one catch is there. While giving isoniazid, you have to rule out the disease, that the patient is suffering from only infection, that is latent TB infection, or disease. In one example, in one prison, they did sputum examination and CBNet in one of the intensive case finding campaigns. In one cell, they found sputum positive case. IGRA, they did all other patients. 150 prisoners were IGRA positive. And the next day they asked me to supply course for 150 patients, that INH prophylaxis. I said, first do X-rays. Then I have sent the medicine, but not before giving X-rays. So Medanta went to that prison, got their X-rays. 30 X-rays were abnormal out of these 150 patients. So you have to rule out disease before giving INH prophylaxis. And now, due to paucity of time, 6H and 3HP have equivocal results. So they can be used interchangeably, and even in HIV patients also. It has shown results. Government of India policy is test and treat policy. Do Montu or IGRA of household contact. If it is positive, rule out TB disease by X-ray and sputum, and then no symptom, no X-ray abnormality, sputum negative, then put on INH prophylaxis. That's it. So target population as per Government of India guidelines, less than 5 years, without test, directly treat after ruling out disease. More than 5 years, household contact, test and treat. HIV population, silicosis, anti-tumor necrosis factor, dialysis, TPT after ruling out TB disease among TBI positive. Regimes, 6 months of isoniazid daily therapy or 3 months of isoniazid rifampicin therapy. And this is painted by Dr. Rajiv Vig. Sir, you might remember, he was our your student. Yes. Now he has big beard also. He depicted the end of TB by showing this, that we will pack TB in a coffin and send it away from the earth. And the last slide, which I am passionate, I wanted to show that if you don't want me to do the full presentation, doesn't matter, last slide दिखाने दो. Sir, हम 90% reduction को कह रहे हैं in deaths, 80% incidence, or zero cost to patient. In some of the group, chest group, I have seen some doctors saying it is impossible. Right? In the morning also someone said that it is far distant, 2035, 2040, any time, any number of year, doesn't matter. But I want, as a warrior against TB, all my team, as a state TB officer, I want to request you, get into the war mode. Learn the lesson from our Indian Army, which won Kargil, even in adverse circumstances. We have to beat TB. If someone says that we'll lose the battle, that means we are accepting the loss. No. We have to learn the lessons from Indian Army. 3C, 4D. Courage, conviction, commitment, and 4Ds, discipline, devotion, dedication, and determination. Courage is to support what you believe in. Conviction is to accept and adopt Government of India recommendations. Commitment is to serve the underprivileged to the last mile. Discipline is to follow the recommended guidelines. Devotion to selfless service for mankind. Dedication to manage and support TB cases. Determination to end TB by 2025. To say with conviction that TB harega, desh jitega. Thank you.
Raju, this was appropriately then kept.
I would like to invite Dr. Dhruv Chaudhary, sir, to present the token of appreciation.
Sir, what we have done today would not have been possible without his help and the Directorate of Health, Government of Haryana. They supported us. I did what I wanted to. They always said, "मैंने यार ये कर दिया, Dr. Raju, इसे बहुत अच्छा किया सर, और बताओ." Thank you so much from the bottom of my heart. Thank you. God bless you.
for our next session, that is just ask me anything about tuberculosis, including DRTB, I would like to invite Dr. Pawan Kumar Singh, Associate Professor of Department of Pulmonary and Critical Care Medicine, PGIMS Rohtak, as the moderator of the session.
So just as a moderator, so don't ask me anything. I will invite some people, ask them everything. So for the first session, JAMA, I'd like to invite Padma Shri Dr. Digambar Behra sir on the stage, Dr. Jay Kishan, Dr. Ashutosh Agrawal, Dr. Rajesh Raju, Dr. Anand Jaiswal, and Dr. Deepak Agrawal. So believe me, there are no stupid questions. Very rarely you will find such high-profile people sitting in front of you to answer your questions. So basically, there viva. So just to start the session, anybody who asks questions will get toffees and chocolates and very costly gifts just outside the reception. So just before anybody asks this question, I would like to ask my own question first to Dr. Ashutosh Agrawal sir. Sir, out of the context of program and everything, my MEN2 is positive. I don't have any symptom. My X-ray is normal. Should I take IPT?
As per the program, whatever the program says. Because I swear by the program. I swear by the program. Even if the program recommendation is slightly unscientific, or if I have some personal opinion against it, I would still say go ahead with the program. I can still be biased. What the program does is for the population. What I think is for the individual. And I think the two approaches are slightly different. What the program recommendations mean will benefit most of the individuals.
Okay, sir.
What I say may or may not benefit that individual.
Okay, sir.
So my take on that is as per the program, in general, for any TB elimination target, you have to clean out the reservoir. It goes without saying. And if the program is suggesting that these patients should receive a prophylaxis after excluding active TB, then I think it's a good decision. It's a decision that I feel is slightly delayed, but it is definitely a good step forward.
Okay.
There is a rider to this, you have to be in a close household contact of a sputum smear positive. So you will be focused on that. In that way, you won't go into the population and find out all the MON2 positive and start treating them.
Yes, sir.
But the household contact, sputum positive patients, rule out disease, yes.
Okay.
So please, it should be a shared decision between the patient and the program people. You have to give the decision, and at your age, if you are having the HIV, if you are having the liver disease,
HIV is negative, sir.
Renal failure, then you will be definitely passed for this. Otherwise, you may skip also. It should be a shared decision. Okay.
If you take prophylaxis today, after 6 months, you will again get reinfected because you sit in the OPD.
So, questions from the house?
My question is that we are seeing a lot of our medical students who are coming. And when we did a study, we found there was equal incidence between the nurses, the medical students, the nursing students, and the engineering. And end of the 4 years, 42% of our nursing students who consented were positive, 41% medical students, and in the engineering it remained the same. Now, what will be your recommendations in terms of preventive treatment in this category of patients? Because we are seeing maximum number of young doctors, especially pre-final, final year interns, or first or second year of post-graduation, because this becomes a question. Because for us, if we insist, sometimes people may say you are trying to misuse your position. So the question, sir, is there, because we are seeing threefold increase over a period of time, and we find it out. What should be the approach? Should we follow, as Dr. Ashutosh said, what is written in the in the now guidelines, or test and treat, that's what, or across the board, if they're not symptomatic, to go ahead with that.
You see, it is going exactly the way I think I showed in the morning, the National TB Prevalence Survey. People above the age of 15 years, 31% are, IGRA positive. So, if since they are the, in a way, the medical exposure people, so it is 41%. So, no surprise about that. But still, I think as Dr. Jaiswal and Ashutosh, they have already said, I think the current policy is a different thing. We cannot go on, we have to follow certain policy. If they are household contacts of a active case and then you have ruled out active TG, I think they can wait.
That's where the confusion comes.
So I think, Dhruv, there is something wrong. There has to be an administrative action also. If a group of people are working under you and getting converted, the rates are increasing, then it means that there is an environmental control problem. And that should also be redressed. If you find that by the year 5, all your MD students or postgraduates starts having tuberculosis, there is something wrong with the administrative side. So beside going into this INH prophylaxis, detecting them, treating them, I think we should look at that angle also. The second thing is recent converters are the most dangerous. If you find that someone who has joined was a negative MON2, by the year end he has turned into a positive.
That's exactly
that is something which needs to be redressed.
That is exactly the point I was asking. Because this is a group which we are seeing. And that's what Dr. Ashutosh also said, that you take 6 months, you will be sitting. And the data shows that nearly 3/4 reduction, there are various studies about 60 to 90% reduction they are demonstrating in terms of active TB. So that is the question which comes up the back of the mind. What should we do in these cases, especially these youngsters?
In some of the countries, it is mandatory for, as a job requirement, that a PPD skin test or a IGRA be done on an annual basis. And in some of those countries, it is also legally mandatory to give these patients prophylaxis if they convert. Of course, the incidence and the reinfection rates in those countries are pretty low, so they can handle it. But as I said, for us, it has to be a decision that we as a group cannot take just as of now. As far as the governmental policy is concerned, we are currently offering prophylaxis to only the high-risk population. High risk as defined by the administrators. We might be ignoring some other high-risk groups or maybe even the general public at large, but I think the ultimate aim would be to get everyone under the umbrella. It's just that we are now progressing in a stepwise manner, but ultimately it has to...
You have answered my question. That given ideal circumstances, the answer is yes, if there is some concern.
So my take is that once you are having the aerosol genetic procedures, the bronchoscopy, in case of anesthesia, the intubation, and in case of dental and the NT people, so you should be having the personal protective equipment so as to prevent the infection to yourself. So that will be the prevention of the infection.
Dental is as bad.
We have to have this.
Thank you.
So we have a couple of questions from our residents. Dr. Aman.
Same drug in divided form, they tolerate it better without having toxicity, but when we are giving it as an FDC in the same doses, they are having gastric or hepatic side effects.
Sir, he's saying when you give the same drugs, independently they are able to tolerate it. In FDC, they are finding a challenge.
Hello. See, the bioavailability in FDC is sometimes doubtful, may decrease. But side effects which are dose dependent, they go down with the lesser dose. So it's highly unlikely. But if it occurs that you are giving single drugs, then the side effects is not there. Dr. Suman Vishkarma also gave an example. In FDC, some of the drugs are on the higher side they don't cross the border, but they are on the borderline side. For example, ethambutol. So when we decrease that dose as per the weight of the body, that with the single drugs you can fine tune the dosages. But with FDC you have to be in the table. So for example 6 to 12 milligram per kg body weight. But as per the single dose you can be as precise as 10 milligram per kg body weight. So this advantage is there in single drugs, but otherwise the FDCs are well tolerated and we in general don't see these things. But rarely these things happen. Yes, that then you have the fallback plan. You can give individual drugs as per the weight of the body.
Yeah, because these things sometimes do happen. One reason sir has told that it's because sometimes as per the body weight, individual drug dose is higher. But in other way also, if you're giving a single drug is equally good, here you have an option to divide them. For example, giving the same drug in a 1 hour period rather than giving all the FDC in a single shot. So that thing can happen and you can do so in certain patients.
The formulation also has a challenge because what we have done sometimes, let's again experience, these are anecdotes, probably may not have an evidence as such, is that when we give from capsules, we shift over to oral formulation, liquid or a syrup formulation. Rifampicin acceptance becomes, one has seen it doing it, but this is again, these are few examples but cannot be generalized. As what Dr. Ashutosh tells me, this is your experience, this is an evidence has to be there, to say so. So we have tried to change the formulations. Sometimes it works, sometimes it doesn't work. Probably that comes up within the clinical paradigms to try different things.
So it may not be related to your question of hepatotoxicity, but as such, once you are giving the loose drugs and the FDC, the coloring agent used in the FDC may be having the allergy and there may be allergic dermatitis, but it may not be the same in case of the loose drugs. So there can be a difference in the dermatitis part also with the FDC beside this hepatotoxicity.
So anyone else? Dr. Vishal?
During my FD, I came across a patient of MDR TB. So he was having HIV with CKD and hypothyroidism. So at that time, we were not able to design a regimen for that patient. So what are the drugs available if we can give in such patients or similar patients having multiple comorbidities for MDR patients?
Dr. Deepak, would you like to answer these questions?
So, patient is having renal dysfunction, hypothyroidism and HIV.
Yes.
They do admit these kind of patients, sir.
Okay, so
actually that patient was referred from some district TB DTO.
So hypothyroidism as such, if you are using, we need to see what type of regime we are planning. It's a longer regime or a shorter regime as per the criteria. And what drugs are causing these side effects. Per se, presence of hypothyroidism is not an absolute contraindication for not giving any particular drug. If the condition or the comorbid condition is well stable and settled, we can always give a challenge with the drugs. Secondly, with HIV, all the drugs can be given. There are certain interactions which we need to know with bedaquiline and certain ART regimes. So in those cases, those interactions need to be taken care of. Renal dysfunction, it depends on the regime which you are giving and which drugs get eliminated by the renal route. There, the dose modification as per the creatinine clearance, I think will solve that issue. In the longer regime, as already shown, we have an option to replace the drug. Where there is a very severe renal dysfunction, we can replace the drug. If it's a mild one, we can modify the dose as per the creatinine clearance. So basic crux is that if the comorbidity is stable, then we can give the drug to that patient. If that gets unstable, definitely we need to replace the drug.
So I think for both the longer and the shorter regimen, they are both have been analyzed for HIV positive patients, and they have said that this is not a confounder for choice between them. The second issue is the renal impairment, and there is a table log in which you can modify any drug dosage as per the creatinine clearance or GFR. So I think It's up to you to choose whether you choose a shorter regimen or a longer regimen, depending upon the other inclusion-exclusion criteria. Because if this patient has a severe pulmonary disease, he will go on to a longer regimen. So you just have a report and just sit with the GFR and you can decide regimen. The ART treatment, you have to consult with your nodal center or your ART center, and they will definitely adjust as per your regimen. They have different regimens. With RIFA, they have different. With the MDR, they have different, and they will give you the answer.
So now you accept that like a severe patient should be on a longer regime?
No, this was before the stream trial. You see. So this recommendation, what we have read as of today, is before the stream trial was published. Now the stream 2 says that all severity, radiological, zone, cavity-wise, and all AFB positive, this is going to go off from our guidelines now, after the stream 2.
So as far as modification is concerned, you have not to decrease the doses, but to increase the periodicity for the renal impairment. Yes. 1. 2, as far as hypothyroidism is concerned, you treat the hypothyroidism part with the drug and continue with the thiona or passivity there.
So next we have Dr. Jyoti followed by Dr. Aman.
Sir, I wanted to ask about in a patient with tuberculosis that we are detecting, suppose it is a pulmonary TB that we are presenting complaints of a pulmonary TB, X-ray suggestive of pulmonary TB. We are starting our own treatment. Should we screen a patient with a localized or one system involvement disease? Patient should be he or she be screened for disseminated tuberculosis?
Ideally, it should be clinically screened for any disseminated involvement. And if you are suspecting a disseminated involvement or a multi-system involvement, definitely that system should be evaluated with an appropriate investigation.
So basically, clinical screening is more than enough. Dr. Aman.
But it is a definite recommendation that in case of the EPTB, you must go for the X-ray test and rule for the pulmonary TB.
Sir, we are now getting with the usage of Expert Ultra, we are getting a lot of patients who are being referred to other centers who have been treated for tuberculosis after 8 months or 10 months or around 1 year. They are again coming as expert positive with sensitive disease. Do we have any cutoff like till what they have a cavitatory lesion, the lung is showing a cavity, that may be a healed cavity, but this active disease, how we can rule out in these patients, and what is the time duration till we could say that this is maybe a dead bacilli after having a complete clinical cure and microbiological cure also.
Dr. Ashutosh, I think this is related to your topic, sir.
I think the Expert Ultra is a very sensitive, highly sensitive test, and therefore the false positivity rate is also high. So I think that is a limitation of the test. I don't see any reason why somebody should be routinely doing a Gene Expert Ultra just for the sake of it. Unless the patient has some clinical pointers towards disease reactivation. See, if you start doing, say, 100 tests, just by sheer probability, at least one of them will turn out to be abnormal. And then you don't know what to do with the result of that test. So once you order a test, you should be clear in your mind why you are asking the test, and is it really going to influence your choice of further investigations or choice of treatment. It is well recognized that even after a year of completing ATT, patients can continue to remain positive by molecular methods. These could be the remnant of dead bacilli or residual genomic material that might give you positivity. But it does not necessarily mean that the patient has reactivation unless you also have clinical correlation for that. For instance, patient has come up with fever once again, or if there are radiological lesions in some other part of the lung, or you must have some clinical correlate, and only then you would be asking for a Gene Expert test. If you have such a clinical correlate and your expert is positive, then I think it is better to err on the side of giving this patient ATT. But if you have just asked it as a routine measure, say a screening or for some other purpose, then please don't rely on this. A lot of times, low-level positivity is the problem. If the test is clearly positive, then it is okay. But low-level or indeterminate results, these are the ones that cause problems. In case you still have a doubt, please get the test repeated. Or you can go in for some other variant, for instance, a LPA or a culture.
Yes, I think for the safety check, you should always ask for a culture. Wait for 6 weeks and keep your patient informed that a report is pending.
May I, sir? I'll overlap the earlier question and this question also. You asked for screening of the person as a whole. As a state TB officer, I'll ask you to screen the family as well. Right? So if a patient is extrapulmonary, in that case might be sputum positive or transmissible. Right? So any person having cough in the morning even, call all of them for sputum examination. Second is, when you have completed the examination of the family, counsel at the same time that you'll have to go for Monto or IGRA regarding this latent TB infection. Right? So at that time only, you'll have to counsel the patient as well as the family. You'll have to rule out active infection and then LTBI and then treatment for disease or infection. And second question, sir rightly said that even after 1 year you can have that positive, but you have that privilege. In Medical College Rohtak, Dr. Aparna is doing liquid culture as well as conventional LJ medium also. So you can ask them to do culture for you. You are privileged. And third thing is, ultra is not yet established in the diagnostic protocol of anti-EP, because we are still debating that this indeterminate result and this low positive, where will it fit regarding repeat test or indeterminate or low positive, these only 15 bacilli it can detect. So it cannot tell you regarding the rifampicin resistance or sensitivity in a definite manner. So ultra as of now is not recommended in anti-EP protocol. Thank you.
Dr. Raju, problem is not the problem. We are getting from the outside people getting it.
Yes, go for liquid culture then. You have the privilege.
We are going, that's what we are saying, that whenever doubt, go for the culture.
Yes, yes.
Secondly, what the problem we are seeing is what he is talking about, sir. Particular, you may have a positive, you may have a cultures are coming repeatedly negative. But what I have realized there is that, giving an example, we had a boy which we got admitted. When 3 times admission, every time rifampicin sensitive and again. Then his sister would come, rifampicin sensitive, then we use the therapeutic drug monitoring. And we realized and later on found out So probably this was one factor which we found out. And then when why it is happening, his father was sputum positive, who was not treated. The children, the mother was getting up. So once father was treated, children who were, the daughter was declared cured once. Now we were able to treat again with the rifampicin sensitive, she improved. So I think it re-emphasizes what you said. Look at the family and drug, whether person is taking adequately to is there. And third answer is, as we said, it's a microbiological disease. And you may continue to have a positivity of the molecular test, so go for the cultures, because they will tell whether bacteria is alive or dead.
I'll again give 2 examples. One is from PGI Chandigarh. Dr. I.P. Singh called me and asked about the result of one patient. Yes. He was CBNet positive, rifampicin resistance. Actually, after investigation, they found out that he was ABPA positive, case of aspergillosis, and earlier he was TB, diagnosed as TB, and that earlier report is interfering with the CBNet report. He asked for liquid culture or any other culture report, we didn't do. So that time it was a diagnostic dilemma. So ATT was continued. So this is a dilemma, yes. Second is example of Rohtak itself. In the internal evaluation we did 4 months back of Rohtak, we went to the patient homes. We conduct TB patient interviews, how they got into the system, when was their sputum examination done, whether they are getting free treatment or not. So out of these 6 patients I interviewed in the slum, in the middle class, and even one person, 14-year male, who had the dream of becoming a boxer, very fit and healthy boy. So 2 things came out of this Rohtak experience. Middle class and slum dweller both had problems of airborne infection control in their room. Middle class had AC, but everyone just closed all the vents for the effectiveness of AC. Lower class, 6 persons in a room, 1 door closed always, 2nd window cooler placed, and that exhaust PVC envelope so that hot air or cold air may not come. And then the person with the active TB is lying on the cooler side. They had only double bed, and other person lying on the way to exit. So airborne infection control is a neglected part which has to be seen in our OPDs, in our wards, in our hospitals, even in the homes of the patient. So you have to counsel the patient regarding screening of the patient, screening of the family, screening of regarding LTPI and airborne infection control. Thank you.
Sir, Dr. Behra, sir, I have one question. Is pyridoxine still to be given as a supplementation to patients who are on ATD?
Pyridoxine is not to be given as a routine unless patient is diabetic, patient is pregnant, patient is malnourished, etc., etc.
Any more questions? Sir, no, sir. You have asked many questions, sir, today. Everybody has a quota.
Sir, in routine clinical practice, we see a lot of discordant results between CB-NAT and first-line LPA. So what is your take on that? Because the patient, suppose we get a CB-NAT report, it is rifampicin resistance. We start the patient on the MDR treatment regimen as per the guidelines. And after some time, first-line LP report says either INH and rifampicin both sensitive, or discordant results are quite common. And these are not real-time available. They are available after 1, 2, 3 weeks, 6 weeks. So what is your take on that, sir? How to deal with this particular clinical problem?
Is the program officer there?
वाइवा मुश्किल होता जा रहा है. Sir, as a program point of view, first is how is the sample taken? What is the quality of sample? And as Dr. Jayakishan had suggested, we sent a letter to all centers, including PHCs. The best sample is to be sent to IRL, Intermediate Reference Laboratory. And if you have only one sample, don't test it at your level. Send it to Intermediate Reference Laboratory for testing. Problem arises when they don't get sufficient quantity or they don't get good quality at that time. So errors can occur pre-analytical phase, analytical phase, and post-analytical. So pre-analytical is the most important. And second is in how much time you are transporting that sample to the center. You are privileged, you would have just 2 departments in between the microbiology lab and your department. Still, this can happen. But the solution to that problem is communication. If microbiology department finds a problem with your sample, communicate. For that, removing that communication problem, I have fixed IRL Friday. Microbiology department gives a VC of all DTOs are present in that video conference. 2 intermediate reference laboratories, they give their presentation as a standard template that we got so many samples, this much sample rejected, this much in process. Our turnaround time is this. They have to declare transparently. And if their turnout time is less or more, DTO will counter that at that time only. So I'll send you the link next Friday. You can see that. So these pre-analytical problems we are continuously striving to remove. And regarding that sample quality, only your LT or only the medical officer or only the doctor dealing with the patient can remove that problem. But what happens is, as a doctor, I never see that what quality of specimen is being sent, or as LT even don't see that, they don't bother to see that sample is fair enough or not. It is kept in a shelf outside their room. So as a program person, sir, I am giving the grass reality. This is the most neglected part. If this problem is solved, analytical phase, now both of my intermediate reference laboratories are at par with that Hisar private model. And our turnaround time is 5 days. Each Friday, you can see that. Whenever it goes beyond a typical time, they declare it, that because of this problem, it is going on. Dr. Dhruv and Dr. Lochav was there. They had some problem with the cooler, that is cool room. What is it called? Doctor, cold room, yes. So I sent a message to Dr. Lochav repeatedly till the problem was solved. So we as a program are striving. So let's communicate, let's form a team, and let's resolve all these problems. Thank you.
So, this is an interesting question. In a small study was done, and in which this discordant results were matched with the genomic sequencing. So they did a Sanger sequencing of all these where there was a discordance, and they found that the better correlation occurred with the gene expert, CB0, rather than LPA. So that is one scientific piece. I do not know how robust that design was, but this information is there. And obviously you can get a culture and request your lab to confirm that. And in any case, the guidelines says very subtly and smartly that this issue should be redressed by the IRL microbiologist. We should not be emotionally burdened with this. We just feed him and then get back to them, what should I do and what is your final report. So within their gambit, they will solve this. And if you have access, some of the Delhi labs do sequencing of genome now. So you can order that, and it is in an occasional case, Dr. Raju won't mind paying for that.
So one last question, sir. Dr. Aman is our exam going. He is trying very hard to get a good impression, to impress everybody who is a potential examiner. He doesn't realize that, sir.
Sir, there is a very big problem in this clinical failure. Like patient is having a drug-sensitive TB. We have given him his compliance is okay, everything is okay. Supposedly he came with right upper lobe cavity, and at the end of the treatment, we are getting radiologically we are getting a whole destroyed lung, and there is no clinical improvement also. So the thing is, as we have discussed in previous session also, we'll do the drug levels, we'll look for other resistance parameter and everything, but can we put a clinical failure patient up front on a second line therapy directly? Because already we see a young patient who has lost a whole lung. Because all these things, drug level, everything, it takes a lot of time, and in that also the disease is particularly active.
So that's why I put up my conclusion slide first.
No.
So there is no need for discussion on that. Empiric treatment is a big no. I think you're as a clinician and as a responsible health personnel, you have to get to the root of the problem. It's taking the easy way out. Then what is the difference between you studying at a premier academic center versus somebody who is doing a private practice just to make two ends meet and writing whatever he or she wants to. So as a responsible clinician, you have to find out why this discrepancy is there. A lot of times the radiology may worsen, but if the patient has otherwise okay, he has converted, sputum conversion has occurred, he has gained weight. So I think those things do point to a clinical response. Just the worsening radiology does not mean anything. It is also well known that CPA can get established in the early phase of active disease. So when the cavity is formed, the fungal colonization can occur any time after that. And CPA is a progressive disease. It is likely to continually involve more and more areas of the lung. So some of our patients, we have found that they are AF-IgG positive even towards the end of treatment. Of course, we don't know whether they were initially sensitized or not, but what I'm trying to say is that worldwide, there is ample proof that fungal colonization can occur in the early phase of disease also. So at least that thing you have to consider. Don't just go by the radiology. Also look at the patient, the other clinical parameters, whether those have improved or not, whether the sputum has converted or not. So microbiologically, you have to be sound. If the sputum is still positive, please get some testing to find out if it is drug sensitive or drug resistant. If it is drug sensitive, then it is likely to be a delayed response. And then you have to work out why the response is delayed, or maybe you can extend the duration of treatment. Again, this sputum positivity could just be because of dead bacilli. If he has extensive disease, but he is microbiologically cured, you can still have the dead bacilli that can continue to give you positive results. So just don't go by a single parameter. You have to look at everything in totality.
So as Dr. Ashutosh said, confounders, maybe this patient is developing a bronchial stenosis and there is a distal bronchiectasis, or chronic cavitatory pulmonary aspergillosis, or a chronic fibrosing pulmonary aspergillosis is developing. So whether there is a stenosis now occurring into a bronchus and that is leading to destroyed lung, we have to redress. Maybe it needs a ballooning, maybe it needs a stenting. One thing. The other thing is that Gene Expert and Gene Expert Ultra is not 100%. So you must realize that RPOB gene is a base pair sequence that harbors 95% of the mutation of reefer resistance. 5% lies outside the genome. So you can get a Gene Expert sensitive, but that patient could be resistant. So in these kind of cases, you look for the other sites, and there comes the role of gene sequencing and other method to detect what RPOB gene. So it is only 95% true. So if you tell me that you are so sensitive, 5% time you can be wrong. So just remember this, there are beyond RPOB genes, there are mutations which can lead you, and you can be falsely thinking that it is a sensitive one. So phenotypic testing or a next generation sequencing.
So only last question.
Sir, my question and comment to all the esteemed panel is, sir, we are knowing that the bedaquiline resistance has started coming up. And one of the factors they are looking up is the fluoroquinolone resistance, which probably is adding it to it. Now, when we intend to use bedaquiline extensively, now has started coming for MDR, and now we are finding very high incidence of fluoroquinolone resistance in this country. Any comment about it in terms of the program or in terms of any insight how to handle it if it happens, or the probability of it happening? That bedaquiline may be a drug which may get knocked off very quickly because of this peculiar problem in the South Asia.
That's why it is not yet open to the market. That is one strategy.
Okay.
That will continue for some more time. Definitely, it is not going to be made open. It will be given to people who know how to use it, and when to use it, and how to use it. So I think that is one good strategy they are doing. That is one good strategy they are doing, although there is a lot of criticism. You give it to, or question it cannot be open market. That is one strategy they are doing. But again, in spite of that, still the things are coming up. I think I showed a slide. So it is coming up. So all the types of, antibiotics in the world, they have got resistance using any type of antibiotics. So that is an inherent property, and we have to face it.
So as the labs are standardized to give us more and more sensitivity reports of bedaquiline, clofazimine, linezolid, we will definitely, it must be there in our population. But currently, most of the labs, except for Chennai and NITRD, they have been accredited, and their reports is to be respected. If they say delaminid or bedaquiline resistance, we'll respect that. So that is one thing that this must be there now also, yet not detected because we don't have a good lab. The other thing which Dhruv would impact is a indiscriminate use of clofa, because it has a cross resistance with clofazimine. So it can also spike up the other way, with efflux pump, which clofa controls, the same bedaquiline works on. So, there the problem can increase. But as our lab starts working and they give us reports in given case, even before starting, Deepak and me were fighting, because most of these trial people did the sensitivity and then put the patient, and later removed those patients which are at the 0-month resistant to bedaquiline or pretinomide or something. So, using these drugs without their sensitivity is a scary thing, but it is there. But whatever tools we are given, we should play it well. We should ensure that 6 months we truly guard our patient to swallow each and every dose. Second time, there is no second time for him after this shorter or longer.
Yes.
Sir said that every antibiotic will face the problem of antibiotic resistance sometime. So, as a program person, I have seen some of the faculty members, not this, resistant, hesitating to start bedaquiline or delamanid or these newer regimes, and to keep them reserved for next stage. So again, that conviction and discipline, if the guidelines are there, use these drugs full-heartedly, wholeheartedly, to stop the chain of transmission at this time. So if the chain of transmission stops here, and we are able to control the disease here only, it may develop resistance later on, doesn't matter. At least this will not be an epidemiological problem, and then later on, with the time, newer drugs will come. So using this weapon wholeheartedly and with full force is the answer. Thank you. And responsibly, yes. Thank you.
Rajesh, just one clarification from you. Do you think the microscopy has been taken out from the program? This is question number 1. Question number 2, what is your instruction to your healthcare workers to how the drug is given? And what is the program guideline says? Because my impression was different. Because last week we had a big fight at Trivandrum. During the JTF meeting, they told me something which was not digested by me. So is the microscopy, they said it is upfront, not now. So you don't do the microscopy. That is what I was told. Is it correct? Some of them, they all remain quiet. Nobody told anything. So what is your reaction to that? You have,
Sir, yes, they told us to do upfront this nucleic acid amplification test of all the patients. But at present, we have just have 32 plus 45, 77 machines in whole state of Haryana. And that too, out of these, almost 10 to 15% don't work at one point of time. So it's not possible to cover all the population upfront for this molecular test. So we are doing microscopy. Last month, even we sent FMs, that fluorescent microscopes, to all districts, 3 to 4 fluorescent microscope to each district. And maybe in the next 1 to 2 months, we'll be supplying more of the binocular microscopes. But yes, they have, yes, they asked me to give upfront molecular testing facility to each patient.
माइक्रोस्कोपी सर बंद है
सर फिलहाल नहीं माइक्रोस्कोपी फिलहाल मैं अपने स्टेटस बता रहा हूँ ना सर, हो रही है, इवन अपफ्रंट भी हो रही है जहाँ पे मोलिकुलर टेस्टिंग फैसिलिटी अवेलेबल नहीं है. तो लेट द डीटीओज आंसर. आपके यहाँ कितने % हो रहा होगा सर? यही एग्जैक्टली, आई एग्री विद इट, आई एग्री. 94% अपफ्रंट, 24%, यस, 86% में माइक्रोस्कोपी हो रही है.
अभी there was a discussion about during Ashutosh's lecture how the drugs are given, what is the instruction. The patient comes as it, I went to your drug center, your health worker gave me drug. So what instruction is given to me? How to take?
DTOs बताओ जी.
क्या इंस्ट्रक्शन है या जैसे मर्जी खा लिया?
माइक देना मैडम.
That is not the प्रॉब्लम, ऐसे चीजें हो रहा है, तो इसके लिए कोई देख नहीं रहा है, कोई कुछ नहीं रहा है। सॉरी, मैं आपको नहीं कह रहा हूँ कि कंट्री में वही हो रहा है।
सर अब जो हमारे पास है ना 99 डॉट्स वाली आ रही हैं सर दवाइयाँ, जिसके अंदर टोल फ्री नंबर लिखा होता है, तो हम पेशेंट को पूरे हफ्ते की फोन कैसे
कैसे खाने के लिए बताया जा रहा है, पहले तो ये बताओ।
पेशेंट को सर हम पूरा
खाएगा, अभी बात हुआ ना।
नहीं, सर का पॉइंट वैलिड है। हम निक्षय पोषण योजना, कम्युनिटी सपोर्ट, MPMLA इन्वॉल्वमेंट, उधर सर हमें ज़्यादा लगा दिया गया है। जो बेसिक चीज़ है, जो आशा वर्कर खिला रही है, डॉट प्रोवाइडर पेशेंट को दवाई खिला रहा है, वो नेग्लेक्ट हो रहा है। लेकिन एज ए प्रोग्राम पर्सन वी कंडक्टेड आशा ट्रेनिंग आल्सो, इवन CHO ट्रेनिंग आल्सो, और इस चीज़ पे हम खास ध्यान देते हैं कि पेशेंट को, इवन ये जो 99 डॉट्स है, ये भी मैंने शुरू किया है क्योंकि इंफॉर्मेशन टेक्नोलॉजी एनहांस्ड कंप्लायंस एडहेरेंस मेथड हमें करने हैं, हमें हेल्प मिलेगी।
इज इट
सवाल ये हो जाता है, आपने दवाई दे दी, वो हम फैमिली से भी देख,
वैलिड है सर, बिल्कुल।
बाद में पीछे कहीं और से देख, तो हाउ आर वी इंश्योरिंग कि जो दवाई
नहीं, देखो राजेश, ये बेसिक पॉइंट जो मैं कहना चाहता हूँ ना,
एग्जैक्टली वैलिड है, वो तो सबसे पहले मान गया मैं सर।
बिकॉज आई एम ऑलवेज पॉइंटेड आउट कि दैट ये कहता है, ये करता है, बट पॉइंट देखो, दीज आर बेसिक क्वेश्चंस। ये
एग्जैक्टली
पता नहीं किसने कर दिया। मैं इनको पूछा किसने ऑर्डर दिया आपको, तो चुप हो गया DDT में, तुमको किसने कहा? यू मे बी DDT, बट व्हिच एक्सपर्ट हैज टोल्ड यू? किससे कब डिस्कस किया आपने? हाँ, यहाँ नहीं कर रहे आप, बच के वो प्राइम मिनिस्टर का मीटिंग करा रहे हो, यहाँ कर 2025 में, इस आपके भी तो
एग्जैक्टली आई एग्री।
देखो ना, these are basic fundamental things you must understand and that must be highlighted. I'm sorry.
नहीं सर, आई एग्री सर, सबसे पहले मान रहा हूँ पेशेंट सेंट्रिक है, पेशेंट पे पहले बात करनी है, बाद की बातें बाद में, और उस पे हम एफर्ट कर रहे हैं सर।
इट वाज अ वेरी नाइस सेशन which should be concluded on
अब जैसे एग्जांपल सर मेदांता की ले लो सर, बताएंगे। इनका यूपी का पेशेंट था, बिडाकुलिन इन्होंने शुरू करनी थी, DTO कहता जी हम नहीं देंगे, वो अपने डिस्ट्रिक्ट को संभाल रहा है, कहता मेरे पास बिडाकुलिन लिमिटेड है, मैं नहीं देता। तो हमने DTO को कहा ठीक है, तू भी एज पर गाइडलाइन ठीक है। हमने वेदांता को PHI अलग से बनाया, स्टेट से सीधा इनको सप्लाई देनी शुरू कर दी। TB का पेशेंट यहाँ का है, यूपी का है, बिहार का है तो TB एलिमिनेट करनी है हमने TB। सो वी हैव टू बी पेशेंट सेंट्रिक, नॉट डिस्ट्रिक्ट सेंट्रिक। Thank you.
Thank you so much, all the dignitaries and my dear colleagues, for asking good questions and for their kind responses. I think we can move over to the last session of today, which is conclusion, sir. Vote of thanks. Vote of thanks. So the session, vote of thanks by STO, sir. Before I hand over the mic, we have to end TB not over Haryana's also, but UP's also.
Thank you all for patient hearing, listening मैंने वर्ड एम्फेसाइज किया क्योंकि आप वाकई सुन रहे थे, और जो क्वेश्चंस पूछे हैं आपने, हमें भी सोल को स्टर करने का थोड़ा टाइम मिला है। थैंक यू फॉर ऑल द ऑर्गेनाइजर्स, स्पेशली डॉक्टर ध्रुव चौधरी, इनके लिए तो स्पेशल तालियां हो जाएं। Thank you, chest department, pulmonary critical care medicine department, the company which organized this event, the NGO, क्या नाम था NGO का सर? TB Alert and Mylan. Thank you. And there is a message from my worthy Director General Health Services, Madam. She wished you all, and she wished that we all will form a team to eliminate TB. And thank you all. Thank you.
अरे एक सबकी हमारी सर के साथ, ऑल ऑफ अस हैव अ फोटोग्राफ।
बंद हो रहा है।
दोबारा आया हूँ, ऑडियो विजुअल टीम और हमारी डिस्ट्रिक्ट टीम के लिए भी तालियां हो जाएं।
All of them have worked very hard. Thank you. तुम ऊपर आ जाओ, ठीक है मैडम, ऊपर आ जाओ, आप जाना चाहिए। जितने भी रह गए सारे आ जाओ पीछे, हमारे डिपार्टमेंट वाले